Good morning, everybody. I take great pleasure in starting the first day of our 3D conference on behalf of all our organizing team, and thank you all for spending your day to be here. Let's roll off this thing with inauguration with invocation of Ganesh song.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। गणपतये नमः। ॐ गणपतये नमः। ॐ गणपतये नमः।
Thank you. So without much ado, let's start with the first session for this program. Management of obese diabetics would be the topic, for which I'll call upon stage the chairpersons Dr. A. Ramanan, Dr. A. Natarajan, and Dr. U.V. Mohan. So please take over.
Good morning, dear friends. Today, obesity everywhere, it's a hot topic. You all know obesity itself is a chronic disease. You have to recognize obesity as a disease. Today, Dr. R. M. Anjana is going to talk about diabetes. So I now invite Dr. Anjana to take over the stage.
Good morning. At the outset, I would like to thank Dr. Vijayakumar and 3D Con for inviting me here today. So this session is going to be on diabetes, and there are two talks in this session. The first part is going to be about causes and consequences, followed by which we'll be talking a little about management. So diabesity causes and consequences, and I have no conflict of interest to declare. Now, what is diabesity? Now, this is a term that is a little controversial, not well accepted everywhere. It's simply a combination of diabetes and obesity, because these two occur together. The combination of these is diabesity. Now, if you look at the natural history of obesity, you'll see that for diabetes, obesity is in the causal pathway. So the first step happens with obesity, usually due to excess nutrients, etc. This leads to insulin resistance. From there, we go to the pre-glycemic, hyperglycemic, dysglycemic states, IGT, IFG. From there, hyperglycemia, and then on to complications and disability. So this is the natural history of obesity leading to diabetes. So when you say the causal pathway, there are many mechanisms by which these two entities are linked together. But today I'm going to be talking about 3 hypotheses. The first one is called the inflammation hypothesis. Now, to understand this, one must know the term called metaflammation. Now, what is this? This is a chronic low-grade inflammatory state that is a response by metabolic cells to chronic dietary excess of nutrients. So what happens when there's excess of nutrients? There is a cytokine release. The macrophages inside the adipose tissue release all of these cytokines. So you can see them there. The TNF-alpha, like weak adiposity-related protein, the monocyte chemotatic protein, the IL-1, IL-6, etc. So all of these cytokines come out from the infiltrating macrophages. Then what do? They do a whole lot of things. So typically they act on the adipose tissue, the peripheral muscle, the pancreas itself, the liver. So these are the key organs, is it not? And they introduce insulin resistance. How do they do this? The mechanisms are very, very complex. But primarily, if you look in the insulin, if you look at the insulin receptor itself, the insulin signaling gets a little gets blocked. There is a pathway problem. Now, if you look in the muscle, it releases all reactogen oxygen species. You look at these things, ceramides, diacylglycerol, stuff like this are lipotoxic agents that interfere with insulin signaling. They cause DNA fragmentation and apoptosis. So due to this, the insulin signaling pathway is then is disrupted, and this leads to insulin resistance. So the same story in the adipose tissue, in the skeletal muscle, in the pancreas, similarly in the liver as well. There is increase of the triglyceride secretion. So all of this leads to either there's suppressed glucose production, impaired beta cell secretion, impaired glucose disposal, etc. So this is inflammation hypothesis. The next one is the lipid overflow hypothesis. Now, what does this mean? Now, adipose tissue is typically a passively expanding tissue. So the more and more nutrients that come, the more and more adipose tissue is formed. But after a critical point, there is a theory that there is a lipid overflow. So what happens, instead of going and sitting in the peripheral tissues, adipocytes, what happens is that there is spill onto visceral organs. So again, same thing happens, whether it's a skeletal muscle, there is myocellular fat. So there are 2 things what happens. One is there's a hyperplasia, that is number of cells increase, and there's a hypertrophy. So it is this hypertrophy that actually causes the insulin resistance through pretty much the same pathways. You have it here, the CPT1, the HAD activity, etc. All of these cause insulin resistance in the periphery. Similar things happen in the pancreas, ceramides, diacylglycerol, as well as in the liver. So we all know about the twin cycle hypotheses, how fat sits on the liver, fat sits on the pancreas. Even a 0.5 gram increase in fat sitting on the pancreas can cause impaired insulin secretion, as well as glucose disposal. So first one is inflammation. Now you have the lipotoxic effects of the fat causing damage to the peripheral tissues. That is the lipid overflow hypothesis. The third hypothesis is called the adipokine hypothesis. So here what happens is that excess adipose tissue secretes adipokines. Now what are these? These are things like leptin, resistance, adiponectin, retinol binding protein 4, etc. Now what are the actions? Now leptin has a central CNS action. It acts on the hypothalamus, suppresses appetite, and helps to decrease energy intake. things like adiponectin work on the periphery through the AMP kinase pathway. It also works on the liver to actually help in glucose disposal, suppresses gluconeogenesis. So adiponectin, leptin, they're good guys. Things like resistin, they have an opposite effect. So adipokines have both good and bad effects. There are new ones coming every day. Vasaptin, there are so many, visfatin, so many are there. Some of them have insulin sensitivity action. Some have insulin resistant action. So depending on the amount of fat and which ones get upregulated, this is genetically programmed as to which one comes out and thus produces insulin resistance. Hence, I've showed you that there are 3 mechanisms or hypotheses by which obesity can cause insulin resistance, primarily causing diabetes, but it can also affect insulin secretion, again causing diabetes. So this together, if you look at diabetes, there are many, many causes. I told you there are genetic factors. So if you look at, we know the FTO gene and the TCF7L2 are the obesity and the diabetes secretory genes respectively, but there are many, many other genes. 9 more genes are under investigation as causes of obesity. However, this is a very small part of the obesity that we're dealing in. The larger obesity comes from dietary factors, lifestyle factors, the built environment, and I'm going to talk to you a little more about that, stress, etc. Now, these are factors that all of us are very familiar with. But I'm going to take a few minutes to talk about the built environment, food and physical activity in terms of the built environment. So this is a 4-country study funded by NHR called as GHRU, the Global Health Research Unit. It's UK funded, and there's India, there's Chennai, there's Delhi, then there's Bangladesh, there's Sri Lanka, and there's Pakistan. These are all the sites that are involved in this study. So in Chennai, of the 144 wards, we've sampled everything for the surveillance study, but here for the built environment study, this is work of a PhD student called Aarti. So this is what she did. She took 2 of these wards and not only studied the individual health data, but also have the environment data, which is the food environment, the physical activity environment, and linked this to diabetes. So this was her PhD thesis work. So what did she find? So given here, this is Chennai city alone. Look at the prevalence of obesity. Blue is males and the pink are females. The prevalence of obesity in urban Chennai, this is 2021 data that was done, it's 82%. And here she has a combination of both abdominal obesity and BMI related. It's really, really high in urban Chennai. If you look at earlier data, you'll see there's a clear increase in the prevalence of obesity, and this is adults above 20 years of age. Look at diabetes prevalence, whopping numbers there, both among men and women. So if you look at diabetes, we see 37% in females and about 30% in males. So these are the figures. Look at the age-wise distribution. As you would expect, diabetes, there is a continuum. There is an increase in the diabetes prevalence with age. Obesity also, it's like that, but you will see that after a particular age, after about 60 years of age, there is a dip in obesity levels, and that is very much expected. Sarcopenia, other things. So these are all the data that she has shown, and diabetes follows the same pattern. Now, this is a very interesting thing. This is the food environment, okay? Now, we're looking at something called as Retail Food Environment Index, RFEI. Now, what is this? This is number of healthy food outlets versus number of unhealthy food outlets in a particular area. So remember, we went to people's houses and studied. We then do a mapping. So what are these buffer areas? So you draw around a person's house, you draw an area, say 300 meter, 400 meter around a person's house, and look at all the various stores and available things around that person's house. So that is what this comes. How do we do this? We do this through GIS mapping, and this particular thing has been done also with physical audits. So she was a PhD student. She went house to house for her study and did physical audits around that buffer area around a patient's house. So what we found is that for every person, so look at this, with diabetes, look at the 400 meter buffer, 1.89. So that means, what does that actually mean? For every person residing in the study area, this person was surrounded roughly by 2 fast food outlets or unhealthy outlets for every healthy outlet. That's what she's saying. So for every grocery store or health food outlet, there are 2 unhealthy options available for this person. So that's what she was able to show here. Now, what does that mean? Does that relate to other, things like she's looked at waist circumference, and this is basically diabetes. Does this relate to that? Yes, it has a definite availability of food outlets is related to obesity. It was not related to sugar levels in this particular study. Then she looked at the prevalence of diabetes along with this score. So what she shows is that those who have a score of more than 1.9 or 2 have a 1.5 times higher risk of developing diabetes. So what does this mean? Availability of food outlets, obesity, and diabetes. That's what she's showing. Now let's quickly look at physical activity. So what does she show here? If you are more physically inactive, then you have more diabetes, and that is quite clear. Now, let's look at, just like we said, dietary areas, food areas, physical activity areas, parks, green spaces, gyms, etc. So she looked at the availability of physical activity areas within a 1 kilometer, rather a 1.1 kilometer radius of that person's house. So if there was a more than 1 kilometer distance to the physical activity area, this was associated with more diabetes. Again, when she did this, now when she did it by diabetes, there was definitely a 1.6 higher time risk of not having a physical activity area around a person's house. So have unhealthy options, diabetes present. Not have healthy physical activity options, diabetes present. That's what she's showing. But we also had to show one more thing. We had to show within a physical activity area, it's not enough. If there's an area, do people actually do physical activity? The answer is yes. If it's available, people are able to go to a park and walk or whatever it is. So within a 1.8 kilometer radius of a person's house, availability of green space helps to increase physical activity. This is called reduced rank reduction. So what we do here is that normal regression, you only have a single variable output. Here you're able to look at multiple variable outputs and come out with patterns for this person. So what does this mean? What we're able to see is that we looked at multiple things. We looked at fruit intake, vegetable intake, family income, physical activity, RFEI, distance to physical, all these things together. You can put it in a single regression, and this is called RRR. So what we are, not the movie, this is a regression, okay? So what we show here is that if people have 2 patterns, an unhealthy pattern and a healthy pattern. The unhealthy pattern is live far away from physical activity area, have access to all these unhealthy food outlets, eat less fruit, eat less vegetable, do less exercise, etc. All of these are significantly linked with obesity. And these are the tertiles of the regression. So what we see is that clearly, look at the first one, diabetes, it's clearly increasing with increase in the unhealthy pattern. So further away a physical activity area is more damage. For closer, you have unhealthy food outlets, more damage. Less physical activity, more damage. So like that, we are able to show. Now, but this is only from Chennai. Do we have any national data on this? We do. From the ICMR study, which has about 1 lakh population inside of the study, we are able to show, I'm very, very happy to say that this data has just been accepted in Lancet DNE, just came last week. And this is the first national data on diabetes. 15 years of work has culminated in this paper, is just accepted. These are the diabetes prevalence state-wise in our country. You have urban areas and rural areas. So this is the diabetes prevalence. Look, it's color-coded. Red is 10% and above, green is below 5%. So you can see India overall, how it is. South and all is very red, north is very red. In between we have some yellows and greens. But look at obesity. Whole of urban India is red. Obesity, and here we're talking about 25% prevalence and 15% prevalence is green. So you can see the numbers are absolutely different. This is abdominal obesity. This is our country and abdominal obesity, 25% prevalence. Whole country has about 25% prevalence. So what is the prevalence of diabetes overall? It's 6.7 in whole of India, urban, rural, etc. You'll see very similar maps to the Chennai data, what I showed. There is an increase with increase in age of diabetes. Numbers increase pretty much. So the consequences, well, they are the consequences, of course, obesity and diabetes. You have sleep apnea, digestive problems, PCOS, fatigue, osteoarthritis, infertility, gallbladder disease, stress, quality of life, all cause mortality. Now, the important thing to note is that these are all the complications of obesity. Everything worsens with uncontrolled glycemia. Complications of diabetes, macrovascular, this audience does not need this at all, but just important to note that all of these worsen with obesity. So the diabetes is there. I'm not going to go into the management, but I just want to tell you that one has to look at this at all levels, the individual, the community, and the government. We now know that access to areas helps to increase physical activity, decrease, so access to healthy foods will help to decrease diabetes. At the community level, your gated communities, access to areas, etc. help. And also, as far as the nutrient goes, trying to decrease the carbohydrate intake and increase protein intake will definitely help to reverse diabetes as well as obesity. So I'd like to conclude by saying diabetes is present in about a third of our population. It's lower in rural than urban, but rural is catching up. It's affecting younger individuals, and this is a problem because there is morbidity and mortality, disastrous effects on the economy. Health impact has long-term effects. There are complications of both diabetes and obesity which get compounded, and we definitely do need measures that are outside of our traditional measures. We talk only about the individual level, but perhaps it's time to think outside this box, because tackling the twin epidemic of diabetes is becoming a very, very important need of the hour. Thank you very much.
Thank you, Dr. Anjana, for your excellent talk on obesity and the predisposing factors and the causes and how the implication in the diabetes prevalence. Thank you, Dr. Anjana. Having understood about obesity, the management of obesity comes. For that, we have Dr. Rajiv Koil to deliver the talk on management of obesity with lifestyle management, anti-diabetic drug and surgery. Over to Dr. Rajiv.
Thank you so much, Chairperson. Thank you, Dr. GVK. Thank you, Anjana, for setting that stage. Fantastic about what actually happens in our country. We know that obesity is the mother of all NCDs, and I've been fighting this excess fat for the last 2.5, 3 decades, and I've been yo-yoing, and it's tough. It's easier to control diabetes, easier to control blood pressure, easier to control dyslipidemia, but obesity and weight, very tough nut to crack. So I'm going to give you something to take home, I hope. So management, LSM, anti-diabetic surgery, drugs and surgery. So if you look at it, that the cornerstone of management continues to remain the same, with this lifestyle, pharmacotherapy, and then probably surgery wherever it's required. Evidence-based approaches, dietary therapy, physical activity, behavior is the only way. When we say mindful eating, there's a lot of cognitive behavior change we need to make. A lot of patient support system. As we have diabetes educators, we need obesity educators. These are the pharmacotherapy, orlistat, liraglutide, available in our country. SEMA, not yet. The combination of naltrexone, bupropion, and phentermine, topiramate, not yet approved. Weight loss, we have the adjustable gastric band. We have the laparoscopic gastric band. Then you have the gastric bypass as well. Now, when you talk about lifestyle intervention, what are we looking at and what is the objective? Like we have an HbA1c less than 7 or 6.5. We are looking at least a 5% weight loss in 3 months. And intensive behavioral lifestyle change should include at least 16 sessions of counseling, which is approximately around 3 to 4 counseling sessions in 6 months, and focus on dietary changes and a 500 to 1000 kilocalorie deficit per day. That's the only way that you can achieve the target. And individuals' preference, motivation, circumstances, again have a huge variable in them achieving these kind of changes. Behavioral changes that create an energy deficit regardless of macronutrient composition will result in weight loss. Dietary recommendations should be individualized. For patients who achieve short-term weight loss, the long-term thing, which should be maintenance, should also have a lot of counseling sessions of at least one per month, and physical activity at least up to 200 minutes a week. Short-term dietary intervention using structured, maybe very low caloric diet may be prescribed, but a long-term comprehensive weight management and counsel should be integrated. That is what the ADA also comes up with, that there should be integration of a short-term with a long-term plan, so that there is a good outcome at the end of it. What are the overview of the recommended behavioral changes? Obviously diet. Second is self-monitoring. We know a lot of us know how to do self-monitoring of glucose or self-monitoring of blood pressure. But dietary recall, observing and recording caloric intake and other aspects of eating behavior. Anjana just spoke about the index. It is very prevalent. If you tell a patient to eat out in the whole city of Mumbai, I don't think he can find even one healthy outlet. So it's very difficult. It's a challenge for him on a day-to-day basis. Sleep management, physical activity of at least 150 minutes per week with 2 resistance exercise, and if you have to go up to moderate to at least 200 to 300 minutes a week. Very easy to say, but stress management plays a huge role in this. Counseling, we're going to take this forward about what is all about counseling. Counseling is behavioral counseling, and it helps in a lot of ways. I'm not getting into details, but individually tailored interventions which include self-monitoring, a lot of social support, problem solving, a cognitive restructuring, slower eating, smaller portions, strategies for dealing with weight regain. A lot of community programs need to be inbuilt for kind of treating obesity as such. So what are the dietary modification? Of 500 to 1000 kilocalories should initially result in 0.5 to 1 kilogram per week weight loss. If you don't have more than 5% weight loss, because of whatever strategy in 3 months, we need to redesign the strategy. The higher the energy requirement is sometimes easier to create a restriction. Macronutrient composition may be less important, but greater initial weight loss with a lower carbohydrate intake is known. Mediterranean diets, I hope we lived in those areas, but is very, very helpful, and there are other alternatives to also low fat. Adherence is important. Most patients are unaware of the calorie density of food, difficult to control the calorie content of food outside. Patient preferences also matter. So Anjana did speak about this, the carbohydrate consumption. We know about this, 45 to 60%, fat 25 to 35%, replace saturated with unsaturated protein, 15 to 35%. Now this is what we need to actually stress upon. 150 minutes of walk or some form of aerobic activity per week can promote good amount of weight loss. If you have more than 300 per week, it can actually help in achieving more weight loss. At least 2 sessions of resistant training, engaging in leisure time activity is something that we actually never understand in urban life. Again, occupational or transportational exercise also, we do not have breaks even during conferences. So forget breaks in offices. Pharmacotherapy, again, there is a debate across the globe that whether we should just target HbA1c in people with diabetes or whether we should target weight loss. And if you look at all pharmacotherapy related trials in diabetes and obesity, it's very tough for patients with diabetes to lose weight. So whether you look at the scale, you look at STEP, the amount of the percentage of weight loss with people without diabetes can get, people with diabetes somehow are not able to get that. So weight loss medications are effective adjuncts to the cornerstone, which is diet, physical and behavioral modification. Pharmacotherapy for patients' response to weight loss is effective, defined as more than 5% weight loss after 3 months, then further weight loss is likely with the continued use. If that is not happening, then probably we need to reconsider what pharmacotherapy we are giving. We know SGLT2 and GLP-1 do help in weight loss in patients with diabetes. This is the scale study which was with liraglutide at the higher dosages, not in our country and not approved. Again, it caused a weight loss of 5.8%, which is much lower than the weight loss it achieved in people without diabetes. So Even in the scale studies with liraglutide, people with diabetes were able to achieve just 5.8%. And after 56 weeks, you can see that the HbA1c again reduced by 1.1%. If you look at semaglutide studies, which is the step 2, where it compared 2.4 with the scheduled dose of which is used in diabetes, which is 1 milligram, you can see an impressive 9.6% drop with semaglutide as compared to placebo, and a 2.4-fold more patients on semaglutide achieved at least a weight reduction of 5%. Importantly, as the dose of GLP-1 goes up, the HbA1c reduction is not as good, but the weight loss obviously keeps getting better. These are the various anti-obesity medications approved by the FDA. If you look at it, you have the phentermine, unfortunately is not there, and fortunately I would say is not there. Orlistat there, but usage is very low, side effects are high. Topiramate is there, phentermine is not there. Liraglutide is there at a lower dosages, and higher dosages we hardly use. So there is a gap there as such. If you look at the anti-obesity medication and its role in diabetes prevention, 3 major studies of Zendol, Scale and Conquer, and also with, I have not added that, which is also Surmount with tirzepatide, you can see that the body weight change is anywhere between 5.8 kilos to 10 kilos with the combination of phentermine, topiramate. And again, the prevention or the prevention of progression of diabetes was better with liraglutide, almost close to 80%. If you look at Surmount, it's almost close to 90%. So GLP-1 seems to be coming up in the treatment and also in the prevention of diabetes and obesity. And very, very important line in the Surmount discussion was that in future also, maintenance of weight loss may also require pharmacotherapy. So today we may be using, or in future, we may be using pharmacotherapy for weight loss, acute weight loss, but probably when maintenance you may require it. If you look at anti-obesity drug and its effects on HbA1c, obviously liraglutide had a much better reduction in HbA1c as compared to orlistat or the other combinations. If you look at the mechanism of actions of the available FDA-approved anti-obesity drugs, orlistat, we know that it's a energy wastage. Oily stools is the problem with that, so you need to up-titrate very slowly. In India, we have the lower dosage as well. A good product if you use it wisely. Some parts of the world, it is also as an OTC product. Some parts of the world, you also have an alpha-glucosidase plus orlistat combination, again as an OTC product. People abuse it as a party pill. So you have these drugs, and probably you can use it and the up titration needs to be very, very careful with this. Liraglutide at that dosage is not available, is not yet approved in our country. Semaglutide is approved in our country, and it's an appetite suppressant. Now, if you look at the effect of the available anti-diabetic drugs that we have, we know that the GLP-1s and the SGLT2s help in weight loss, and DPP-4 and alpha-glucosidase are weight neutral. Insulin and SUs may cause a little bit of weight gain. So again, we know that in the last 1.5 to 2 decades, we know that high glucagon, or paradoxically high glucagon, is a defect in our people with diabetes, and incretin-based therapy, both oral DPP-4, oral GLP-1 and the injectable GLP-1 actually help in that program. If you look at the data from the Pioneer program, if you look at a good 1.5% reduction, you're going to have 2 studies coming at the ADA, which is the OASIS, which is on the oral semaglutide in people without diabetes at a dose of 50 milligram. You also have Pioneer Plus, which is on 7, 14 and 50 milligrams. 14, 25 and 50 milligram in people with diabetes and weight loss, both going to be presented at the ADA this year. And it's going to, the results, the top line are out, and it seems to be very effective. So probably you may have a labeling for this in the coming years as such. So targeted approach to weight management, 5 to 15% weight loss is beneficial in our people with diabetes. We need to look at all these things to improve the quality of life. Bariatric surgery, just giving a small snapshot of what we have. We have the gastric bypass, which a very long technical experience is required, partially reversible. As you can see, the stomach and small intestine are bypassed, and stomach is reduced to a very small pouch. Gastric band reversible, around 10% to 15% weight loss. Sleeve gastrectomy, which a lot of people call this as diabetes surgery or metabolic surgery, 10 to 15% weight loss, again an irreversible procedure. A little bit about cagrisema, because that's going to, it's in a phase 2A program. Cagrilintide is an amylin analog, and you can see that the HbA1c reduction, when it's compared to semaglutide alone or cagrilintide alone, the combination has a fantastic HbA1c reduction, and the weight loss is also close to 15%. Phase 2A will go into phase 3, maybe in the next few years. You may have all these drugs coming in. Tirzepatide, with its SURMOUNT studies, has shown that all the three dosages of 5, 10, and 15 cause close to 15%, 19, and 22% reduction in people with obesity and no diabetes. Again, in its studies on diabetes also, it has shown the same thing. So again, when we talk about weight management to our people, there's a lot of shared decision making, much more than that we do in diabetes. We need to be very, very empathetic. We need to take permission, talk to their patients about weight, because this is something which is culturally spoken at kitty parties and parties, and not in doctor's clinic. So understand the underlying causes, barriers, stigma, body shaming, so many things. So there needs to be a lot of empathetic counseling when we treat obesity. So set realistic goals. 5% in 3 months is realistic. Don't set the patient up for multiple cycles of failure. I would summarize saying that this an upstream approach can lead to early intervention in the treatment paradigm of diabetes and can reduce complication. Weight is given more importance in according to recent international and national guidelines. GLP-1 are a good class of molecules which addresses both. Recent advances present with combination could yield better results in both these and help in managing diabetes. Thank you all for a patient hearing.
Thank you, Dr. Rajiv, for your excellent talk on the management of diabetes. Now the section is open for discussion.
What is fat compaction? Does it occur on a routine basis or what is fat compaction? Does it occur on a routine basis, and then how does the overflow occur after that?
Oh, the overflow. So what happens is that genetically determined, so this is supposed to be a passive organ that keeps accommodating the excess nutrients that you keep getting. So in some people, this genetically determined ability is a lot. So you have these people who are metabolically healthy but rather obese. So most of this fat is happening in the subcutaneous component. Now the overflow happens when the subcutaneous spills over to the visceral component and goes and sits in the various. Now how does this happen? What triggers it? We don't know. But we understand that there are genetic triggers for this, and for different people it's different, which is why today we do not know if someone takes a certain amount of calorie for a certain period of time, who is going to overflow, who is going to become insulin resistant. It may not be the same for you or me or him or anybody else. So this is the understanding of the lipid.
No, is the physical activity, is there any evidence to state that any studies done to say that by physical activity and LSM, we usually reduce the inches, rather, we call it more than BMI, the inches matter. And then as the waistline comes down, is there any equal amount of visceral fat coming down with that, or?
Yeah. So physical activity on its own helps, yes, in fat burn. So as the subcutaneous fat goes down, the weight goes down, the visceral component will also come down. Now, is there a direct correlation how it works? Generally, they say that you need about 5 to 10 kilos of weight loss for visceral fat to start coming out. It doesn't go down with the first few inches or kgs. You need quite a significant amount of weight loss, because what happens when you gain, also you gain in the subcutaneous. When you lose, also you lose in the subcutaneous. So that is what is visible in the waist and all that. The visceral one takes time to come. It takes time to go. So around 5 to 10 kilo loss is the general thing for visceral fat to burn. You'll see that happening. NFLD will come down, the twin cycle, the pancreatic fat comes down, but it takes time. Having said that, over time, if physical activity is continued, there are epigenetic modifications that happen. So over time, there is a sustained, loss of physical activity, but you have to combine this with an energy deficit also. You cannot keep loading on one side and then it doesn't, your physical activity will help in the peripheral insulin sensitivity, all of that will help. But if you load with calories, then the overall fat doesn't go down totally.
Yeah, but according to the prevention of, there's not reversal, remission in diabetes part of it, when you lose about 10 to 15% of your body weight, what happens is more of the hepatic fat reduction that happens and sensitivity improves. It doesn't matter whether the skeletal muscle resistance improves or not, according to the studies that they've done.
So according to Roy Taylor's and all the Caucasian data we have, sir, the cutoff point is 10 kilo weight loss. If you have 10 kilo weight loss, then hepatic insulin sensitivity and pancreatic fat are shown to come down. We are showing that even at lower levels, we are able to see that these are changing. We had Anjali Chelaram's work with Dr. Unikrishnan was the first work. Even about 5 to 8 kilos are showing changes in our, but the Western data says about 10 to, and anything above 10 is beneficial is what they are saying. We don't have robust data yet, but Asian Indians, the problem is, sir, we don't have that much massive accumulation of body fat in the first place. That is our issue. We have more of the insulin kind of secretory defects along with the obesity. This is always like an added on phenomenon for us. So even a smaller weight loss is able to have a better beneficial effect in the Asian Indian.
Thank you. Rajiv.
Thank you. You're expert. See, you said about 8 months. The issue is that in diabetes is a lifelong. So these are all chronic diseases. You said about 8 months. But what happens is that when you stop the drug's cost we don't discuss, okay, obvious reasons. So whether cost effectiveness is one question. Ideally, none of, I don't know, Vijayakumar is a poor man, okay. So ideally we should lobby for conditional licensing. That we never talk, otherwise you wouldn't be here like this, okay. The problem is that once you stop the medication, what happens? Rebound. So how long we have to give these drugs? Nobody knows. So don't put it in the front page.
I agree with you.
Slowly. See, the thing is, we think that the conferences are marketing places. Okay, you propose your own people like that. The problem with the metabolic fat is that it is very active. The sympathetic receptors are very, so it is metabolically active fat. It's like a black money. Okay. Thank you, Vijayakumar. Good. So, Rajiv. Our commitment is for the diabetics, not for the pharma industry, okay?
Same, you and me are on the same page.
No, he feels in the same fashion, sir.
But action.
No, it's a part of the lecture, sir. As he said that, no, I also feel in the same sentiment. For example, now that it's a continuous process, as Dr. Karnanidhi has explained very nicely, don't you think that SGLT inhibitors make a more sense for us? Because in our Indian phenotype, I think there is more weight reduction compared to Caucasian population. That's what most of the centers have said. A few people lose even up to 8 to 10 kilos and all. Some people lose about 3 to 4 kilos. But for looking at the cost of it, I think, do you prefer SGLT inhibitors to other drugs? That is number one.
The experience with SGLT2, Dr. Vijayakumar, has been that after around 12 to 15 months of usage, again, one, there is a plateau. Two, there's a compensatory eating, which obviously, I think Ferranini's daughter and Ferranini have that study. So the compensatory eating leads to either you gaining the same amount of weight or some amount of weight loss which you had lost again is regained. So it cannot be a long-term process. Why it happens, we don't know. Why if 250 calories are going out, you are still not losing weight, and there are so many, at least 20% of patients who don't lose weight with SGLT2. So SGLT2 just for that benefit could be there in the first 1.5 years only. I think long term will require some other.
It may not be there. Okay.
SGLT2 we may not be able to give it to non-diabetics.
Yes.
Yeah. Yes.
So in diabetics, again, it's a very simple, even before you came to this stage, you get maximal dose, you get maximal benefit
Sir, actually, in yes, in fact, I asked the question actually. The EMPA renal study, not EMPA renal, EMPA heart failure studies, where the significant number of non-diabetic population is there. They have found about 4 kilos weight reduction even in those people, not more than that.
You all talk about the good things, but why should you invite UTI?
No, no.
Consequences also are there. That also has to
No,
be.
sir.
Just because you want a weight reduction,
I agree.
2 kg, doesn't mean that patient should go to the urologist.
I agree with you, sir. That's about 5 to 10% of the people, but 90% of the people are losing the benefit now, sir.
Not that significant.
See, 90% of the people are losing the benefit, number one. Number two, if anybody is developing a problem, the moment you stop the drug, I think they are going to recover immediately. In that way, I think we need to look into the...
The problem is that not the good quality of the drugs, cost of the drugs. Next year when there is a new come, he will come and talk.
No,
we
no,
will
no.
correct.
No,
That
no,
is
no.
why, that is the issue. நீங்கெல்லாம் வந்து என்ன பண்ணுவீங்க புது actors
Sir,
look at him. So wisdom. சரியா நீங்க பேசலாம். அப்ப when you talk about good things, you should also highlight the
Yes, sir. We are balancing it, sir. Definitely we are balancing it. Okay.
Thank you.
Thank you, both Dr. Anjana and Dr. Rajiv. We have come to the end of this first section. Thank you so much.
Let me thank with the chairpersons and the speakers for the wonderful lecture. Shall we all, we have a few minutes for the inauguration. So a formal inauguration shall be done now.
Yes, come. Vanakkam. Good morning to everybody. Thanks for coming for this conference, which we usually do it every year. Last year we could not do because of the National RSSDI, and then the organizing committee and the scientific committee, on behalf of all these people, I cordially invite all of you, welcome you all of you for this wonderful meeting. And the scientific committee and the organizing committee have taken a lot of efforts to look into the scientific agenda as well, and we try to cover as much as possible in more a practical and pragmatic fashion. That's what we did that. So our organizing committee, they're very, very strict. Oh, and Sellappan and Kannan are here. See, these guys are very strict, that. So they started on time at 9 o'clock. Actually, 15 minutes in advance. I would like to congratulate them, actually. This is the way we should be there, actually. This is the way I think we should have a meeting, actually, So, that's nice, actually, to be like that, actually. Thank you. Anyway, we'll have a formal inauguration today. And we have amongst us our teacher, our senior most professor of Dr. A.K. Das, to please come, sir. It's just a formal or informal inaugural function, so that traditionally we can write the Kuttuvilakku. I think Ganesh Vandanam is already over in the morning. Sir, kindly take your seat, sir. Okay, Eid Mubarak. So, as a mark of respect, we will have the lighting of the Kuttuvilakku. Sir, can you say a few words, sir?
Dear Dr. Vijayakumar and the team organizing 3D Con, and my esteemed colleagues and friends. It's a matter of great honor and privilege to be here this morning. I consider this a conference with a difference. The difference is the fact that there is a lot of emphasis on the things which are simple but can produce great change in the management. You will find that both in this room and the other room where the people below 30 and the postgraduates are there, there is a lot of emphasis on the diet, lifestyle, exercise, counseling. So that's a great aspect of this meeting, Bijay. I like it because it gives a great augury for the country. Second, the topics are very simple and the messages, I'm sure, will be simple because the greatest truths are the simplest. I'll be talking about CVD. The greatest truth about CVD, we know how to do it. The Steno 2 had shown us that you can add to life 7.7 years, bring down all the cardiac complications. But why we are not doing it? And simple medications, cheap medications. The data from the Swedish study and the USA data showed that the CVD is coming down. But in India, it is not coming down. The fact is, we don't use statins. We don't do physical activity, the diet is not rich in fiber, etc., etc. So the topics chosen are the greatest topics with a great message. Dear friends, I must also express that the speakers have been chosen after a lot of consideration and they are the who is who in the field, and the messages will be definitely cut across the people sitting in the audience. My dear friends, it's my great honor and pleasure to say, in the name of the divine, the meeting is open and we'll all partake of it. And you know, I have come to a very important conclusion. I'll tell you that we had a discussion regarding what should be the real motto of diabetes care. And it came out that we should take care of simple things. Like we never take care to ask the patient, either we ourselves or our staff, to continue with the patient, are they pursuing diet, physical activity, drugs, etc. Number two, no, so that we don't need exactly twin health. We need people to follow it. We do not take care of the facts that we have to also take care of the socio-economic aspects, also take care of the family aspects. You know, the diabetes today is poised to become a multimorbid disease with 3 types of complication. Traditional, we know all the pathies. Non-traditional, we know the bone health, which just now will be discussed by people, so many things. But there are also emerging complications like mental disease, like Alzheimer's, so we call it today diabetes multimorbid disease. Therefore, dear friends, this conference is an integral conference, and I'm sure there'll be a lot of interaction. And the fact to start it, I thought 9:15 I'll be here. By the time I came 9:15, the first slide of Rajiv is on. So, but good, sir, everything must happen in time. Thank you very much. And I wish and pray on behalf of all of us for the all-out success of this conference. We'll carry home clear-cut messages for our patients. Thank you. Thank you very much.
Thank you, respected sir. In fact, I'm so happy that you are here, sir, actually as a senior statesman. And
I must tell you that for a Government of India work, I was in Delhi last night, and Rajnath Singh was addressing, he has COVID, so he came virtually. He said what is most important for the doctors is education. And he was telling the doctors are above gurus and just next to the divine. It was a very good talk. So I thought that the emphasis on education is so much, and thanks to BG for this wonderful educational evidence.
Thank you very much, sir, because it was actually, we had a new plan for inauguration except that. And I'm so happy that you are here and accepted to give us the start the inauguration. Officially say it's open, sir. Thank you very much, sir, for As Professor Das has said, that we also this year we have started a master class certificate course actually. This is for basically for young physicians who are less than 30 years of age and postgraduates, to make them self-sufficient when they go and start their clinic and start treating. It is basically, today this totally is basics actually, that both morning and afternoon. And then tomorrow they're going to have more of interactive sessions and as well as workshops, including how to go through the literature and how to start probably a small research in their own clinic, and how to improve the practice, how to impress, and how to, convince a patient to do things. All those things will be discussed there actually practically. And we thought that's a very good initiative, what we thought. In fact, actually this idea came when we did the National RSSDA. And we had a plan a bit late actually. Within 1 week we had about 500 people who registered for that actually. That is a very good success that we had. I thought we should replicate in our own Tamil Nadu as well, and that is the reason we started this program. We restricted to 80, but 100 people have registered for that, and then I thought it's a good initiative. I thought we'll see that actually. And then, so thank you, and then we'll just go ahead with the next program of the academic year.
Friends, let us move on to the next very important and interesting session, the food for thought. For that, we have the eminent chairpersons. I'm happy to call upon the chairpersons. I invite Dr. J.C. Shekhar to the dais, Dr. N.S. Prasad, and Dr. K.P. Pichumnisa to the dais.
Good morning, all of you. It's my great pleasure to be here with you on the chat session on a very important session, Food for Thought. And I'm happy to invite the first speaker, Dr. Sri Mahadevan. The topic is bone health and anemia. Anemia seems to be a very important part, not only many systems of the body, but equally well in the bone health and metabolism of the bone. Severely anemic patients, because even the osteoblasts and osteoclasts, they need iron for their normal functioning. And a lot of research being done recently, and we're just looking forward to enlightening talk from the eminent speaker, Sri Mahadevan. Before that, I'd like to congratulate GVK sir for this nice conference, nice speakers, as sir just now told. I'm very happy to be part of the team. Thank you, sir. Sri Mahadevan, sir.
Thank you very much, sir, and I profusely thank Dr. GVK sir for one more opportunity. And on a topic, I was repeatedly told in the last few minutes that it's going on time, but I have been given two topics. I spoke to GVK sir and he said anyway you try to squeeze in. Bone health itself can be a 1 hour session. Anemia and diabetes can be another big session. And both are given only 15 to 20 minutes time. I'll try my best to squeeze as much as possible and give a quick review or bird's eye view of these problems. And I thank Professor Das sir. He nicely mentioned that some of these simple things which we are taught from our first year MBBS days are sometimes overlooked. And that will be actually the introduction for anemia. Because for this talk, last 1 week in our hospital with our PGs, I was repeatedly looking at how many of them had hemoglobin levels, etc. And almost 50% of them have WHO definition of anemia in the standard clinic, which means women less than 11 and men less than 12 in non-pregnant state. So you can imagine the burden is too much, and those slides will be boring. And both anemia will have an impact on diabetes, not only the pathophysiology of the disorder, as well as the complications, response to medications, causing complications. The reverse is also true, which means diabetes also causes anemia in various ways. Most common cause of anemia in a diabetic, suppose you are following up in a typical clinic, a general clinic of diabetes. If 40, 50-year-old patient who comes with diabetes, male or female, he has anemia less than 10, first rule out CKD. This is the most important. Immediately don't just prescribe. Many times creatinine is missed. Today packages have come. We are from the era when packages are not, the tests are not done, sometimes it's overlooked. So if you rule out the CKD part, then comes all other discussions on what are the various ways diabetes and anemia interact with each other. And since type 1 diabetes may not be the cup of tea for many people here, especially in children, but it is worth remembering that this is one unique condition among the subtypes of diabetes where the causes of anemia are very unique, unlike the usual nutritional, iron deficiency, blood loss, etc. in a typical adult practice. So autoimmune etiology of anemia in addition to nutritional anemia is the most important cause of anemia in type 1 diabetes, both in children, adolescents, and even when you are following up adults. Had this been North India or West India, celiac disease is very common. In South India, fortunately, it is less. This exemplifies again our understanding of how nature, food, the topic theme itself is food for thought. So the food and diseases also interact. In the rice eating belt of India, generally celiac disease fortunately is less common. There are 3-4 South Indian papers from Vaidehi Medical Institute, St. John's and other places. It is less than 3% or 5% in type 1 diabetes populations in South India, but it is almost 30-40% in the North India. So you can imagine any patient with anemia in a type 1 diabetes, celiac will be screened every year. If you look at the guidelines of follow-up of type 1, celiac will be there. However, in our setup, in adults practice, B12 deficiency due to malabsorption related to pernicious anemia and rarely hemolytic anemia, or the hypothyroidism, which is again is almost 2/3 of your type 1 will be hypothyroid, especially on follow-up if they are autoimmune etiology. So this is type 1, so we'll set aside. Type 2, this whole slide is taken up from a beautiful review by Dr. Rakesh Sahai and Sanjay Kalra, published in one of the standard journals, a review of anemia and diabetes. You can see everything is there. Today all these words will be repeated in several of our lectures here, and some of them are very important. Every aspect of diabetes and its vascular complications in one way or the other influences the development and progression of both its own complication and anemia. Especially one of the commonest drugs we all use is metformin. Metformin and B12 deficiency is repeatedly talked about. Even in the US guidelines, now they are saying that routine B12 supplementation may be indicated in metformin. And interestingly, few things like DPP4, SGLT2, which I'll touch upon in the next few minutes. So, in addition to this, per se anemia can influence your way of seeing HbA1c itself, which is a very important tool in our monitoring of diabetes. Every time when you see very low hemoglobin, please check whether your HbA1c is reliable. The iron deficiency, the prolongation of RBC can increase HbA1c. I'll come to some interesting points epidemiologically that in India we have this dual or triple problems of anemia, diabetes, obesity, everything occurring in the same population. So iron deficiency anemia, you can overestimate diabetes if you go by HbA1c as the definition of diabetes. B12 deficiency, folate and all I mentioned already. And there are conditions of hemoglobinopathy with the world becoming smaller and too much of medical travel. We have many Bengali patients coming in many hospitals in Chennai. We have so many hemoglobinopathies picked up daily. HbE very common, even HbS 1 or 2 we picked up, and rare hemoglobinopathies. So whenever there is a discrepancy between your fasting postprandial reports versus HbA1c, and if the CBC is not showing any major abnormality, think of a hemoglobinopathy. A low hemoglobin, thalassemia is not rare in our population also. So always look into other causes of, so we cannot be very happy seeing a HbA1c of 7.1 in a long-standing diabetic, but the fasting is 180 and PP is 280. There is some, so these are all small clues which will give us when to suspect these causes of anemia as well as the etiology of anemia, which will help you in monitoring. So what do you do in those kind of hemoglobinopathies? That is why technology is helping us. Either you should go for CGM, which is now available, or 1,5-anhydroglucitol is one more marker, but these are all not standardized. Fructosamine, which is otherwise glycosylated albumin, can be used, but all these need standardization in a given setup. The easiest way is to frequently monitor SMBGs, which is the easiest in any setting, or use CGMS at least once in 3 months to know that they are under good control. Otherwise, hemoglobinopathy, you can't say the HbA1c cannot be used, so I won't monitor diabetes. So what does anemia do to the complications? It's very well known that CKD causes anemia, but it is worthwhile remembering from today that anemia also complicates CKD. So one of the basic diabetes defining problem is the microangiopathy. We all know that, endothelial dysfunction. And at some point, the microangiopathy, especially at the local level, causes hypoxia or decreased perfusion. Anemia also does the same. So wherever there is microangiopathy complication, it will be worsened by anemia, and kidney is not an exception. And you can imagine the number of studies showing, both animal and human studies, due to altered sympathetic activity, how the local oxidative stress in the peritubular and other areas causes both the RAS pathway dysfunction as well as local functional erythropoietin deficiency, leading to more worsening of the pathophysiological process, leading to DKD. This is diabetic kidney disease. And needless to say that when these 2-3 unholy nexus between anemia and diabetes and kidney disease go together, worsening of CVD, stroke and hospitalization, they all will happen. Retinopathy, I remember my DM days, one of my seniors did a beautiful study on how correction of anemia actually improves retinopathy. Correction of dyslipidemia improves retinopathy. Good dose of statin, the hard exudates will come down. These are all proven facts. If you listen to ophthalmological lectures, it's well proven fact. Anybody with retinopathy, please, lipids even if normal, if they have hard exudates, they are an indication for good dose of statin. Same way, anemia, same hypoxia, same. So you should correct anemia to improve retinopathy. And multiple pathophysiological processes are there. And all these culminate the danger fellow, which is cardiovascular disease. And anemia is a well-known risk factor, both precipitating heart failure as well as worsening your CAD. And the same ischemic problem of anemia can be a risk factor in worsening your wound healing in a case of diabetic foot ulcer. So these are all easily understandable things. Only thing is extra attention and extra few minutes of addressing these issues to be done in our day-to-day practice. A few seconds on medications and anemia which are used in diabetes. Metformin I already mentioned. It is interesting to note that metformin actually, through some calcium dependent mechanism, actually reduces the B12 absorption, and there are studies to show that even calcium supplementation can improve B12 absorption in a case of metformin. There are some companies which are coming with metformin and B12 together also. I am sure you must be knowing some of the brands. And here I would like to make a provoking statement. It is unfortunate that India has the dubious distinction of the maximum methylcobalamin prescriptions in the world. Methylcobalamin need not be given for B12 deficiency. Cyanocobalamin is simple, plain B12, cheapest. You give it the same response. There is no proof to say that conversion of cobalamin to methylcobalamin is defective in diabetes. But for various commercial reasons, we know that how methylcobalamin is the only brand now available. Any multivitamin has methylcobalamin, not cyanocobalamin. Can anybody name here how many cyanocobalamin preparations we know? A lot of senior people are here. They will be knowing in the past. Today, many of them are converted to methylcobalamin. So this, please remember. And this universal omeprazolization of the whole world is happening now. So this PPI use is rampant. And this PPI is one common link between two of my talks. Both bone health is affected, anemia is also worsened, B12 deficiency, iron absorption, everything affected, achlorhydria, hypochlorhydria, calcium absorption, you name it, there is a problem. But unfortunately, rampant prolonged use of PPIs is going to have a detrimental effect. But in an academic forum like this, I can add a nice twist to this story by saying that PPI use can reduce diabetes, it has a GLP-1 secreting effect, etc. These are all academic things which can take us away from the main point. The main point is do not overuse PPI for a long period. And there are interesting points like AC and ARB also through their effect on the RAS system and through that on the EPO, that is erythropoietin, can have some effect on erythropoiesis, but they have tremendous beneficial effects on both kidney and CVD reduction, so we have to continue them. So one more point is, interestingly in this whole discussion, DPP-4 inhibitors and SGLT2 inhibitors, at least on some small scale studies, have shown that they have some improvement in anemia, not in worsening the anemia through their effect on erythropoietin. But none of these are used for that particular purpose, but in a given case, in an academic forum, it is worth remembering. And glutazones, due to their dilutional effect and replacing the bone marrow into fat, will have an effect on anemia. So in bariatric surgery, we all know how those things occur. So I have already mentioned iron overload, hemochromatosis causes anemia because there is iron deficiency. There is one new term being discussed with this dysmetabolic iron overload syndrome. That means in insulin resistance, obesity, NAFLD, there is an extra iron absorption, unknown reasons happening, loading the pancreas. Some extra iron causes oxidative stress and distress of the beta cell, leading to worsening of the pathophysiological mechanisms of diabetes. And in the same note, you can imagine how much complicated will be in a gestational diabetic patients. Overzealous use of iron in gestational diabetic patients, they have clearly shown by many observational studies, there is a link between extra iron dose and anemia. But here is the problem in India. I cannot say this in the same tone in an OG forum, where already anemia is a big problem in our pregnant patients. I can't say you give iron, will it cause GDM? No. Be moderate. The alavukku minjinal amrutham nanja is coming everywhere in our practice, and iron is also not an exception, and already there is an OG practice that they don't give iron extra in the first trimester for various other teratological reasons. But here they give, in GDM, we have to be careful not to treat overzealously. So what are the take-home points from anemia point of view? This is an often overlooked problem. HB less than 10, be very cautious, look carefully into it, find out the cause, treat it, don't label it as just diabetes related, just write one more multivitamin and send. See to it that it is corrected. So next 5 minutes only I'll take on bone health. I'll quickly rush through like a video here. We have another problem of bone health in diabetes. These are all skeletal problems which we all see day in and day out, but focus will be on only osteoporosis over the next 5 minutes. India is an aging population. We all know longevity of our diabetic patients are much more than non-diabetic people. And we are going to be having dubious distinction. Already we have crossed China last few days in population, aging population increasing, diabetic population increasing. Across states, it's not just Kerala alone anymore. Everybody is having 70 plus. And osteoporosis prevalence in diabetes very high, because both are common chronic conditions. You have a 60 plus, 70 plus people, you will have diabetes and anemia. Every fracture patient we are seeing in our hospital has some form of diabetes also. And interesting, these are all comparisons. Type 1 diabetes, very poor bone health in the long run if they are not controlled well. Comparing with type 2 and versus rheumatoid and SLE, they have shown that diabetes fares like rheumatoid. So a patient having rheumatoid for a long time and a patient having diabetes have somewhat equivalent detrimental effect on the bone health. And this is being shown. That's why I will come to the practice point on this. What is the use of knowing this? The important point in this slide is diabetic patients fracture at a higher BMD. So using the already DEXA scan is an underused or an abused, both end. Abused in master health checkup, underused in needy patients. This is happening in routine our practice. Bone in diabetes is quality is affected, quantity is not that much affected. So they all fracture at a higher BMD. You cannot diagnose osteoporosis and fracture risk by BMD alone. So what have they suggested? You either use FRAC score, actually I'll tell you. You take diabetes as rheumatoid equivalent. I was remembering Hafner when I was studying this, because he only said that diabetes is cardiac disease equivalent. That was the early 2000s. Every lecture like this, somebody will say Hafner data, diabetes equivalent to CAD. Similarly, you say diabetes equivalent to rheumatoid arthritis with respect to bone health. And use in your FRAC score, instead of rheumatoid, you put diabetes. If your patient has diabetes, put rheumatoid plus. Then you will get a score which will tell you the real thing. This is the simplest practice point, the only treatment. But I will not bore you all with all these complex nature reviews on how osteoporosis, pathophysiology, in a complex manner. And so many anti-diabetic medications have some detrimental effect. The most important is glitazone. Please, in your practice, in a postmenopausal lady at least, do not use glitazones if they have a bone health problem or fracture. Please, this is a very, very serious issue. This will cause, there is no doubt, sugar control nalla varudhu, vendam. Avangalukku vendam. Avanga fracture appuram vera enga made poduvanga. And we are often seeing all these problems. So do not use glitazones, at least in elderly people with fracture risk which are higher. Secondly, of course, you should control hypoglycemia, you should control the nervous problem. Fall risk also should be assessed here. It's not just the bone quality alone in these patients. SGLT2, it's controversial, but in a given patient, take your own call. There are incidents of fracture, canagliflozin study, they passed off saying that it's only the metatarsal fractures, but in a given patient, be careful. So the safest agents are the other agents, which we all know very well. So we need to think beyond BMD when assessing bone health in a diabetic patient. Just I ordered DEXA, T-score is good, so diabetes lo onnu illa, appadi panna mudiyadhu. You have to use what is called FRAC score, the quality is affected, and the same advanced glycation end products, all these are affected. So the quality is affected than the quantity. So how do I assess? There are certain modifications which can be done within the available framework of our DEXA scan. What is something called trabecular bone score, which is not available routinely. It's just a software. If you add another 7 lakhs or 8 lakhs of that software, you can assess all your this kind of a pictorial diagram you will get, and this trabecular bone score is a very useful score. If available, it can be used. Otherwise, as I said, use the and always all your diabetic patients, if you suspect bone health, get an X-ray at least, if not this VFA and other things, any spinal fracture to be treated. The only message from bone health diagnosis point of view in a diabetic patient, use FRAC score and use rheumatoid arthritis as your equivalent. You put yes there. Here I have put no here. This is Indian score, by the way. This is now reasonably standardized. It gives a very nice idea at a primary care level whether your patient is at extra risk for bone health. Use diabetes as rheumatoid arthritis equivalent. And what is the treatment? Always good bone, vitamin D and calcium. I cannot say more than this, and I'll skip some of these slides in view of time constraints. Bone health diagnosis will be a problem. BMD will not be low in diabetic patients. Secondly, vitamin D has multiple pleiotropic benefits. Do not use vitamin D do not use vitamin D just because for diabetes will improve. No, bone health will definitely improve. Supplement calcium. If in the calcium PPA use, absorption will be poor, calcium carbonate won't work, you have to use then citrate. All these are discussions beyond the limit of this 20 minutes. But just to tell you that supplement calcium and vitamin D adequately. Do not just like that reflexly prescribe an agent which is anti-osteoporotic. Bisphosphonate kuduthalla. That's not the answer. Preventing fall, adequately treating vitamin D, calcium, checklist of all the drugs so that you modify the drugs which are detrimental to bone is the most important step you can do. I stop here and thank you very much for your kind attention.
Thanks, sir, for the excellent session, sir. Please stand by for the questions, sir. We'll take questions later on.
Good morning, everybody. I first of all thank the organizers, especially Dr. Vijayakumar, for having given me an opportunity. So today's topic is cardiovascular disease. Next topic is cardiovascular disease, Indian scenario, challenges and opportunities. We all know that the prevalence of diabetes and the prevalence of cardiovascular disease are on the increase, and more than 60 to 70% of our diabetic patients land up on some or other cardiovascular problems. This is going to be a challenge for us, but we have at the same time got a lot of opportunities with the advent of newer drugs like GLP-1 receptor agonist, SGLT2 inhibitors and other, which might be helpful in preventing or at least reducing the risk of cardiovascular events. To talk about this, we have none other than a great doyen in the field of diabetes, endocrinology and medicine, Professor A.K. Das. He does not require any introduction to the audience. Only thing we would like to say that in spite of achieving great heights, he is a very, very simple and he is a very, very affectionate person to all of us. Over to you, sir. Thank you.
For this very hearty and loving introduction, dear friends. What I'm going to speak today is some new facts. We'll discuss the CVD in diabetics, the Indian scenario, and what are the challenges and opportunities. Dear friends, I'll present 3 facts which are important for today's discussion. Number 1, the disease burden study, global study, showed that the age-standardized CVD death rate for 100,000 population, 1 lakh population in India is about 272, whereas the world average is 235, meaning thereby that we have more CVD deaths. Number 2, this CVD in Indians, all of us know, occurs at least 1 decade earlier. Third and most important thing, that if you have 22% in diabetics having CVD, we have non-diabetics about 11%, meaning thereby that it's a great problem in our population. This is a very important study. This is regarding the state level variation in the age adjusted rates of IHD and stroke. To make a long story short, this study done by Dr. Prabhakaran from PHFI, I just like you to read the bottom line. Now, we have substantial variation in the burden of IHD and stroke and mortality variation also. But if you look at this, between 1990 and 2016, when this study was called for, that is for about 26 years, it was found that the rates of CVD and the mortality in CVD has gone higher, whereas the mortality and the prevalence of stroke has remained constant, meaning thereby that the vascular risk is more in form of IHD than stroke, and it is more so in diabetics. I'll show in the next slide. Dear friends, this is again from the Dr. Prabhakaran, my classmate from the PHFI, who has shown that if you look at the various things, I'll again go to the bottom cartoon. If you find that in Indians, we have diabetes at a lower body mass index compared to, say, Americans. Number two, we have same prevalence of CVD despite major differences in the BMI. Our BMI is low, but CVD rates are same or even higher. We have, of course, low intake of fiber, and we take a lot of whole grain. But the bottom line is that as a race, we are more prone for the cardiovascular complications. Dear friend, this is a funnel chart, and this is a new chart which I like to show it to you. This is a meta-analysis which shows that in type 2 diabetes mellitus in India, the prevalence of CVD, heart disease, cardiovascular, not the vascular as a whole, the heart disease is about 21.1%. In the forest plot, if you see the black one, the forest plot, you will find, anyway, in the forest plot, you will find that the middle point shows the prevalence of CVD in each study, and the rhombic figure shows the prevalence of cardiovascular disease in patients in type 2 diabetes entire study, and the prevalence of heart disease in diabetics is much more in Indian population. This is a very beautiful data, which again new data, which shows about the duration of diabetes and the prevalence of CVD. Now, this study assessed the CVD risk over 10 years of diabetes duration. It showed that the duration as it increases, there's a linear increase in the CVD complication. But what is most important, even after 5 to 10 years, the CVD risk in diabetes increases linearly much more than other diseases. Therefore, when we get diabetes at a younger age, and now we are living longer, the cardiac disease becomes very, very important. Dear friends, this is in the newly diagnosed type 2 diabetics. As you know, when you diagnose type 2 diabetics, there is already some comorbidity. It shows that if you take between males and females, what is the differential? You will find that that in the females, the CV risk is little lower. You find in the hypertensives, the CVD risk is very high, and we have high level of hypertension in diabetes. In the persons who smoke, it is still higher. Obese, it is still higher. And most importantly, people who have renal disease, their developing CVD is great. Therefore, we are as a population are very prone, even at the time of diagnosis, the Q risk score in our population in males is higher than the females. Smokers having highest CV risk, followed by CKD, stage 3 to stage 5, hypertension, obesity, and of course male gender. This again shows that the CV risk in the newly diagnosed type 2 diabetes is propensely increases, and it is very important to know that it strongly increases with the age, and after 35 years of age, the males have significantly more risk compared to the females till the menopause. Not only the CAD, if you look at the heart failure, the diabetics also have the greater degree of heart failure because of hyperglycemia, IR, hyperuricemia, and many other things. And it has been also shown the atherosclerosis in Indians because of IR, because of lack of insulin signaling proper, is also higher. And you find the hypertense Indian population is also higher, which addresses the stress of oxidation, rash system, insulin resistance, simple nervous system, and adipokines. So therefore, if a diabetic develops proteinuria, please, we all know about it, it leads to hyperlipidemia, and this leads to CAD. Dear friends, there is a greater degree of dyslipidemia in our diabetic population. Adipose tissues release free fatty acids, and this free fatty acids increases the peripheral insulin resistance. They are further entrapped in the liver, giving rise to triglyceridemia in the hepatic cells, and therefore the dyslipidemia in diabetics, we find there is triglyceride-rich LDL molecules, and they are the forerunner of the heart attacks. Now, if you look at the lipid abnormalities in type 1 diabetes, it is similar to general population if the blood glucose is controlled, but our main problem type 2 diabetics. In type 2 diabetics, the apoprotein B, LDL, LDL small dense proteins and other fractions are very high, and if there is a poor glycemic control, still higher. Therefore, lipids are very important in our country to give rise to the diabetic heart disease and coronary disease. Dear friends, there is a disease called primary specific heart muscle disease. Without hypertension, without rheumatic heart disease, without any known cause, they develop heart failure. We call it primary specific heart muscle disease. This is a study which was done in 2020. It has shown that the LV mass index is higher in diabetics due to interrelease of the cytokines, and they produce the heart failure and the other cardiac problem. Now, if you look at the diabetic dysfunction at the cardiac system, what we call whatever the REF or PEF, or look at the various types of dysfunction, we find there is increased cardiac lipids, the cardiac steatosis, and the homeostasis of the calcium is altered in the diabetic muscles, so that the resistance to insulin, and they produce primary specific heart muscle disease, giving rise to the heart failure. Dear friends, there are some genes which variants increase the risk of diabetes and CVD as a whole. There is a new finding. The genes which increases are TCF7, which is very common in our population, the FA-CTR1, HMG-A1, and the other genes are given there, and these genes are forerunners of diabetes mellitus and CVD. The Indian population, the entire genetics has not yet been worked out. Now, what we should do, what are the challenges, what we should do, next 10 minutes I'll spend on that. Now, I'm very pertinent to say that we are not doing what is available with us as the low-hanging fruit. Dear friend, the statin use in the I7 India study we found was hardly 21%. Wherever we say the statins are like, they say statins is the second aspirin of the modern world, statins are used only in 20% of the patients. Number two, the hypertension is controlled in about 25 to 26, 24% cases in diabetics. The advice regarding physical activity, diet, salt, etc. are not usually given. I'll draw to two things to say that the addressing the use of lifestyle and statins or antihypertensives, the USA has brought down the cardiac problem. Similar thing also had happened in the Swedish national study. I did not put the slides, I have only put the new slides which are beyond 2020. This study, all of you know, the Swedish national study showed that the heart attacks are coming down. But in India, in contradistinction, we are increasing because our statin use is absolutely low, BP control is not as perfect, and also lifestyle, three things: eating less, walking more, sleeping well. Of course, stress-free is not in our hands, but these are the three things that we must do to keep it at abeyance. So the things that is most important is to look for a multifactorial treatment. Now, first we must have an anthropometric and clinical assessment. Therefore, we must screen for the BMI and screen for the waist circumference. All of you heard Anup recently in the Indian obesity data, the waist circumference has been again coming back. even though said should not touch the buttocks, take out the waist circumference. It is coming back because it's very important for the cardiac risk marker. You should do clinical assessment like medical assessment, obesity assessment, diabetes assessment, physical examination, review of all the systems, and clinical laboratory test. As all of us know, this is not the lack of knowledge, the lack of, its manifestation in our clinical practice important. Step 2, we must assess the risk and discuss with the patient and the family the goals we want to achieve. So we must ask the patient and explain to them what is their cardiometabolic risk. We have so many scores. UK PDS is giving 10 scores. You just use Q score for the cardiometabolic assessment and discuss with him the treatment goals, and there is a risk specific algorithm. If lipid is high, what to do, BP is high, what to do. So this we discuss with them. I must tell you, when you tell the patient about the heart, they are more receptive. We tell all our patients, possibly Rajiv said about the Mediterranean diet and the olive oil. It costs about 1100 today per liter, whereas the fortune oil is about 200. People don't listen to us. Cardiologists, once they have some chest pain, they say olive oil, they all change to olive oil. So my belief is that if you tell the patient very significantly that these are the diet and the physical, the lifestyle that you must follow for your heart, they will follow better. Number 2, and you must use treatment using multiple algorithms like lifestyle algorithm, I'll come to that, obesity algorithm, pre-diabetes to diabetes conversion algorithm, and the atherosclerotic cardiovascular disease and the CHF algorithm. So dear friends, this is the modern management which has come into existence today. So these 4 algorithms I'll describe. That's the end of my talk. Now, dear friends, now coming to the lifestyle therapy algorithm. As I rightly said, I meant that there's a lot of emphasis in this meeting on simple things, I just pointed out. Lot of things which are inexpensive. We cannot ever forget to carry our legs. So the lifestyle therapy algorithms, now nutrition. Please do a individual planning. Reduce calorie. Now, daily about 500 deficit. Meal plan including whatever, low carb, low fat, as far as possible, high protein. I believe in high vegetarian protein, but I have no bias towards non-vegetarians. And of course, there are so many approaches to prevent hypertension, including salt. DAS is not necessary, or ordinary approach is good enough. Meal replacement, very low calorie diet, etc. for the nutrition. Physical activity is about more than 150 minutes per week walk. Now, we do not say in Indian patients 5 days, we tell 7 out of 7 days. And you know, it is very important to do that. Some resistance exercises for the major muscle groups. And you know, we have just now published a study that if you do exercise in diabetics, your sarcopenia is not there. Otherwise, you find all the diabetes are developing the legs which are narrow, the hand which are narrow. Of course, at that age they don't need, but in muscles. But you know, you must have a body like the film actors Salman or whatever. You know, you must have, and that is only possible if you do regular physical activity. Reduce sedentary behavior, and also you must have a program which suits you. And if possible, you have some technology. Cheap technology is the wearable step meter. Behavioral support is very important. I'm very passionate to tell you. I'll be also speaking in the other room. Vijay has asked me that you must have this support for the behavior change. Like you tell them that you have to monitor blood glucose. It will now the price of the strips. Some strips have come down. It's about 10 rupees. Some strips remain little high, but you decide which strip to use. Food intake, exercise, weight control, and blood glucose monitoring. There is very important that we should have talking to the patient ourselves, nothing like ourselves or our staff, and also try to tell them remain stress-free, easily said than done, and very important to evaluate and see that they are happy. Now, we have a term today called glycemic happiness. You have to do that. You know, Abdul Kalam ji, he said once when I was in Bangalore with him, he said diabetes is not a disease, a syndrome, because when 25% people have, it is a syndrome, it can be disease. So why to worry about it? You do, take it as a blessing. It is there to control your life, to plan your life. So that's how we should approach it and motivate them. Number 2, of course, smoking cessation. I don't see the patients who smoke. At least if I see them behind my, it's very important to smoke cessation. And sleep is very important. At least 7 to 8 hours sleep is very important for the lifestyle algorithm. Obesity algorithm, normal weight without complication is our important objective. Eat healthy, act healthy, and spread the virtue of health education. We have started a new system called the health education program. This is very important. Now, in the stage 0, when they have overweight or obese, but they do not have any complication, that time you must institute a very aggressive lifestyle program and bring down the BMI much below 27. Anybody above 27 must be admitted for a great lifestyle program. Stage 1, overweight or obese with mild or moderate complications, there you must give lifestyle program and medications. I mean, medication simple, metformin. It reduces weight, at least weight neutral. The DPP-4 price has come down. There is also weight neutral. And the complication treat. When they're overweight, obese with more complications, then you have to decide what medication to give or how to approach their obesity. Now, for the dyslipidemia, it is very important to have the goal setting. LDL goal less than 100, triglyceride 150 for the high risk, very high 70, extreme risk 55. I have taken from the Indian guideline, so that must be adhered to. Now, CBD risk factor algorithm for the hypertension, use the drugs which are very simple like ACE inhibitors, ARB, or the CCB, or the beta blocker. And it's a combination therapy, and if it is not coming under control for a month, add the next drug. Now, there are so many treatment options for the hypertension, starting with lifestyle, sodium reduction, physical activity, weight loss, sleep apnea, taking care, steps, and also the impact with the newer drugs. So hypertension has to be managed, so lower the blood pressure by the synergistic drugs. Now for the diabetic cardiomyopathy, the drugs are nothing great, same ACE inhibitors, ARBs, the beta blockers, and take care of the diabetes control. Now the drugs which have got definite cardiovascular benefits and has been addressed by the EASD and ADA are these drugs. The prices have come down because they are off patent. The prices have come down, it's still coming down. Today we get DAPA at the price of 4 rupees. I'm not advocating for a drug, sir, but I'm just telling the price compared to previous years has come down. Some have not brought it down, they will be falling in line. So wherever necessary, you can think of using this drug. The issue is there's a lot of cardiovascular benefit. And if the patient is in the risk category 2 and 3, you must be used. Now there are GLP analogs which are also going off patent. The liraglutide has gone off patent. We have taken the patent out last week, so it will be available in the class now. We also have the drugs like metformin, which can take care of the weight, the anti-diabetic drugs, and the targeted blood pressure control but we don't achieve it. Lipid control achieved goals are given here. Now, what are the problems? The last 1 minute. Developing country like India, we face a huge burden of diabetes and its complication. Now we have socioeconomic factors, so we must be awake to it. Problem with the medical infrastructure. We have inadequate follow-up in monitoring, and we have a proper absence of care. The financial burden has to be looked into. It is government duty to give free treatment for everybody. Adherence to guideline must be there. And the strong correlation between diabetes and the CVD must be known to everybody. Health condition, dyslipidemia, hypertension, obesity, and other risk factors must be addressed. Now, there should be the prime reason of NCD rise is nutrition, lifestyle, therefore higher body fat, abdominal fat, liver and pancreatic fat, any ectopic fat has to be controlled. Conversion of pre-diabetes to diabetes must be checked. And last slide is that the huge number of patients with diabetes and with complications increase the morbidity and mortality and pose substantial economic problem, which we must be awake to and take care of. Thank you very much for a kind hearing.
You have really stressed the challenge of facing challenge of cardiovascular disease that is going to be especially challenging not only to the whole world but to the Indian nation per se. You have stressed the importance of good glycemic control, hypertension control, lipid control, and very well stressed the importance of lifestyle modification, which is the first and foremost step. apart from the various pharmacotherapeutic interventions that are available to us. Thank you very much for your great lecture. We will have the discussion at the end of the next session. Thank you.
Good morning, everyone. And at the outset, I would like to thank Dr. Vijayakumar sir and organizers of 3DCon 2020. And of course, next speaker is Dr. Shailaja Kale, who is actually has done a lot of work in RSSDA in Pune. And of course, see, the quality of life is more important. Ultimately, that makes more sense. And it should be people-centric and person-centric management of diabetes. The quality of life is very important, and the longevity of living is very important without complications. Dr. Sekadas has nicely stressed about the problems that we are facing in our country. And unless we have set goals to patients, we are not going to achieve this. Knowledge, information, just awareness, education alone doesn't matter. How we are going to implement it, how we are going to do it, how the patients are going to achieve the goals are very, very important and more sensible. I hand over the mic to Dr. Shailaja Kale, who is going to take us through this. Hope we'll have a nice session. Thank you.
The organizing team for a fantastic time here and very good academic sessions. So just we heard from Professor Das that burden of diabetes is increasing in India. And what do you mean by burden? Burden is not only numbers. It's actually the burden, so that there are more deaths because of the disease. There is more economic burden. So the India comes into a country where that not only the number is more, there is a huge burden, expenditure, healthcare expenditure, morbidity and mortality is much higher in our country, and so we need to get tuned to it. We are quite trained in the conferences to see the patients and have specific goals. So we are so much involved in the patient who is sitting in front of us to have a correct and proper treatment. Sometimes we need to come out of that and have a bird's eye view of the society and look at the points which can be missed if you are only involved with one patient. And here comes the role of, how the patients are taking these medicines or how they are following your advice, which we are sitting and giving. So we know the goals. We need early and aggressive A1C control without hypoglycemia, without any weight gain or maybe weight loss we need in patients. We need to focus on glycemic variability when we are managing this juggling of A1C, avoiding hypoglycemia. Also, we need to have whole vascular tree protected. It's not cardiovascular risk, brain, everywhere, peripheral vascular disease, kidney, liver. While doing all this, I think one of the goals we should make is also of the adherence. So if the adherence comes into the goal of our management, not only to improve other goals, but itself it should be a goal when we are practicing. And let's have some information which I will like to share with you about how adherence changes with different patterns of treatment. I think long back, 20, 30 years back when we started giving talks, there used to be a triangle: diet, exercise and medicines to treat type 2 diabetes. Some of you might remember that. So these are the major pillars of type 2 diabetes management. Then came the evaluation, tests, and of course monitoring glucose as well as other monitoring. And all these pillars are based on adherence, so which is the major base of all the peers. There is no adherence, there is no lifestyle change, not only taking pills or insulin. So adherence should be a goal, and if the adherence is suboptimal, it increases complications. We know that all microvascular major adverse events will go up if patients are not adherent to whatever you are saying or whatever you are prescribing. It will increase mortality, as I was saying, burden will be more, increase hospitalization and increase health expenditure. So that is the issues if patients are not adherent. There are barriers to the adherence. So most common is forgetfulness. Every day you have to take tablets, so many tablets. So sometimes they want to cheat a day or they want to take time off and patients don't take. So forgetfulness, cost, I will come to that, but the cost of the therapy is a major determinant of adherence. Side effects, if they are not properly explained, mainly hypoglycemia. So many of our patients come to us because someone prescribed me something, but I had a bad hypoglycemia. I don't know, then I stopped everything. A1C jumped to more than 10, and then the patient changes the doctor and comes to you. So we should avoid, especially in newly diagnosed diabetes, whether it is severe hypoglycemia, even a simple relative hypoglycemia, one need to be aware and need to avoid to improve the adherence. Low perception of complications. Patients are very hale and hearty, having a good life, they are enjoying life, they are fit, doing exercise, they are not aware of complications, we see them. And they don't want to talk about complications. Howsoever you know that important it is. They are interested in their daily life when they will go out of this clinic. Next appointment is waiting for them for some other work. Take the prescription and run out of the clinic. So these are the people, they are not aware of the complication. That itself decreases the adherence, whatever you are telling them. So I think low perception of complication is again important. This was the effect of cost on adherence prescription done by Canadian healthcare studies, and you can see that more people are adherent, there is a less of the expenditure, more of the saving, especially in chronic diseases of heart failure, hypertension and diabetes. So adherent definitely reduces the cost expenditure. There is one study done, though the country is Ethiopia, you can see it's a clinic-based study, outpatient department, and there are about more than 400 samples where the adherence was related to how the patient's HbA1c is controlled or not. Here it was more than 77% were not adherent. So it was quite a bit that they are not adherent, but I think any clinic, it's 50%. When you think of adherence, we see patients in our clinic who are coming to us regularly. We don't think patients who are not visiting you regularly, and there are so many patients that are not visiting anyone regularly. So the perception of adherence in our minds also need to be changed by proper seeing the statistics. So this actually study showed that the responsible factors for poor adherence was medication cost. You can see the p-value. Monthly income, the poorer patients have less adherence. Self-monitoring of blood glucose improves adherence. So done in a structured way, it will improve adherence. Number of medications, big prescriptions, adherence goes down, it has significant relation, and comorbid condition, of course, there is a relation with the adherence. So this was a clinic-based study. This was a nice meta-analysis just published in February 2023. There are more than 156 studies, you can say more than 10 million patients are here, and there is a systemic review and meta-analysis which studied the adherent, what are the different patterns of adherence, what is affecting. And what it showed, a significant association between good glycemic control and a good adherence. So someone is adherent, the A1C is better. This meta-analysis also showed that adherence to OADs in type 2 diabetes is suboptimal. You can see almost, I think 50%, 54% of patients were adherent, but almost 50% were not adherent. So one of the goals should be having a therapeutic adherence. So we should include this adherence in our goals to design a proper prescription. Therapeutic adherence is different between different oral agents, and which has seen in many kind of studies has been published, but this meta-analysis again shows that adherence was poorest with metformin and alpha-glucosidase inhibitor because of the GI intolerance we know. But best was with thiazolidine-diones. You can see 68% because we all remember the rosiglitazone days. The patient came to us after 6-7 years when the drug was banned. They were taking the tablets, whatever stocks were available with fantastic A1C, and then they came, now this drug is not available. So we know that adherence, but DPP-4 inhibitors and SGLT2 inhibitors have a better adherence compared to sulfonylureas or insulin secretagogues. So it changes the complex prescriptions like one insulin and 3-4 drugs, different complex insulin regimens, the adherence goes down, which we all know. Polypharmacy versus monotherapy, we know that sometimes too many drugs in one pill. As a treating expert doctor, you may not be confident because it may change pharmacodynamics sometimes by having too many drugs in one pill. And you don't get that, fine tuning of the patient's glucose if I'm using combinations. So many of us don't like these combinations to use, but number of drugs, polypharmacy will decrease the adherence. So whether you like it or you don't like it, decreased number of pills, combination pills will improve adherence. This is very important. What they found out that in younger patient, there is a poor adherence. As I was saying, very busy people, and this is alarming. So our approach to young patients who are working should be completely different, and we have to have some age-wise specification in our clinics, whatever digital technology we are using, to improve adherence and focus on younger patients. Older patients are more adherent, and there was no difference between men and women in this meta-analysis about adherence. The cost of the drugs, I think it's very important that we know that cost actually decreases because of, it's not only in India, we are very cost sensitive people. We have a big Apple store now in here, it's manufactured in India, everyone uses iPhone, people fly business class, but when it comes to health expenditure from their own pocket, they don't want costly drugs, which we all have experienced. So it's not only for poor people, but even for the rich people. India is a cost sensitive country, so low cost drugs will definitely improve adherence in all our patients, which we have experienced. This fight we know, Indian generic drug firms with pharma multinational companies about the cost of medicines. And every day we are going through this, we are reading a lot of articles. So patent rights versus patient rights. When you look, it's not only these fights between the pharma companies, but when you have a wider picture, a very costly drugs which is so effective to improve complications, if the cost is reduced, is it not patient's right to use that drug at a low cost rather than fighting for patents? So before the SGLT2 inhibitors became out of patent, this was a WHO study which is called as MPP licensing, that before the drug goes out of patent, if it is available as a low cost, there was a good paper here, and what it shows that if you make these drugs available, it was the focus on DPP4 and SGLT2 inhibitor before, this was some few years back, and what it showed that access is improved, so many patients can get these medicines, it delivers so many million patient years of life, it can avoid so many cases of major adverse cardiovascular events and additional good quality of life if the drugs are made available at low cost before the patent gets expired. That was the MPP licensing. And these calculations are only cardiovascular benefit, but there are additional benefit of delaying kidney disease, delaying vision loss, avoiding severe hypo, weight loss is there, delaying insulin treatment. These are indirect wider benefits of making these drugs. So there is no legal battles will go on, but if you see sometimes there is, we know that patient rights takes over the patent rights, and sometimes we need to accept these low cost drugs which will access like SGLT2 inhibitors. Now they are accessible to each and every of our patients, so maybe the benefits are much more. Structured monitoring of blood glucose should be used in a very correct way to improve adherence. It's not only improves HbA1c, it improves patients' adherence to drugs, to insulin treatment, their lifestyle, what they are eating, how much they are exercising. If it is done in a structured way, by using technology, by using apps or different kind of software tools, digital technology, we can use structured self-monitoring. CGM is there, no doubt, but you can't use it for each and every patient. But structured self-monitoring can be used for every patient, which will have an improved disease awareness. Patient feels participated in his treatment, he takes active control of the disease, and there is an improved ability to recognize not only hypoglycemia, but also his or her behavior patterns. And there is an improved adherence to drugs, diet, exercise. So structured SMBG should be used as a good tool with digital technology to improve adherence in our patients. So as I said, diabetes education, continuous education is important to patients. Age-wise different approach is important to improve adherence. We need to focus on a younger patient, as we see so many young patients below age of 40, below 45 who are struggling with diabetes with 4 medicines on that with their full life going on. Hypoglycemia, we needs to avoid not only severe but even a simple relative hypoglycemia can decrease adherence. Discuss side effects with the patient, make the patients aware so that they will not stop eating, but they will see it, in a proper way. Okay, these things may happen. There will not be a kind of misconceptions or myth about the drugs. Choice of drugs, as I was mentioning, you should know that which will have a better number of drugs, though whether you like it or you don't like it. Combination pills are going to improve the adherence. Different mobile apps, there are papers, because the apps are so different, You will not get a good papers which is showing, but perfect apps which are using these technologies, which can again change structure according to the patient's need, will definitely improve adherence as technology, as I was saying. So assume that every patient is going to be non-adherent, and then try to set up the goals and your prescription. Developing a trusting relationship with the patient is also improves adherence. So like as you become senior, your patients are there for so many years, they don't ask you questions. You write insulin, they will take insulin. No, I am telling you, I don't want to talk. I am telling you, you need insulin. They don't ask you second question. So one thing is good, as you become senior, the patients are more adherent, they accept your thing. But a trusting relationship is very important, and a better communication, which I feel in our medical education, these things lack. No one teaches us about communication, no one teaches about, we are only focused on the medical knowledge. And I think if the medical schools become like IIT schools, I think the doctors will also be all over the world doing so many better things, and the technology people will not overpower us. So I think our medical education system need to be changed, and we should include everything here which we always talk and say this is less. So effective use of technology is there. So as I was always, we know that one size fits all approach is not there now, and we know that it has to be individualized. Every patient we need to see that how I can improve adherence in this particular patient, then all my pool of patients, all my younger patients. So we need to change your approach in the clinic, and a lot of other associations, and also at the government level. Trust is a critical factor in an effective relationship. If you are a competent doctor, but if you are very low in competence and low in caring, it will create a distrust between the patient and the doctor. If you are very competent, but if you are not caring, you are not having a good communication, you are not talking, the old days are gone. That doctor is very rude, but he is very good. Those days are gone. You need to be sweet, you need to be better in communication, you need to be competent. But if you are not caring, there will be a respect, but patient will not follow you. They will say, oh, he is a very great doctor, but no, it's okay, I will go to my doctor. So only competence doesn't enough. If you are more caring, but if you are not competent, there is an affection. Patient will say, oh, he's a good doctor, she is a good doctor, but she is not great doctor or not a correct doctor. So you need both. You need a very competence by attending such meetings, having updating knowledge every week for ourselves, and also being very caring for the patient and having a very good communication. Then the trust develops, and actually the adherence can be improved. So thank you so much. And I really thank Dr. Vijayakumar, GVK known in this part of the world, and for having this topic to remind all of us that we are really forgetting this very important topic of adherence. So thank you so much.
Thank you, Dr. Kale, for a fantastic presentation. And how passionately you have done it, it's obviously seen. You have really nicely illustrated about adherence and the importance of adherence and the cost effectiveness, how much you can save as a patient, and it's a very good patient-centric and people-centric approach. Thanks a lot. We'll open for discussion at this session. We are going to take up the second part of the session.
You can stay back so that you can finish your questions. Thank you, Dr. Shalija Kale, for a wonderful talk actually. You know, it's a very tough topic actually to do that, and I think you've done a great justice. And how about your experience in dealing with the psyche of a person? You know, that first thing is that the patient feels that he is distraught, depressed, anxious, and you know, why me? So all these things are happening actually, and that is one of the reasons what we feel is that why they are not adherent. That is number one. They don't come for follow-up. They may be adherent to the prescription, but they may not come for follow-up. One thing is that what we found is that they are scared of the doctor. As you said that in the last slide, you said you should be caring and available and then soft to them. So if we don't do that, I think they will not try to come back immediately, and they'll give all reasons. That's one thing. And the other issue, what is it? How you look into that is that I think the way we approach. For example, if you look into the diet part of it, instead of telling, don't eat this, don't eat that, don't eat that, instead, because there are many things to eat, many minimal things not to eat. Usually, we know that. But the approach may be that, we need to have more of a positive approach where we can tell them that you can eat all these things, and then you tell them you can't eat these things. I think something like that. What is your experience in that?
I think the positive approach, absolutely, like mangoes now. So we put, but if you say no, don't eat, the discussion stops there. So you start, yes, you can eat, but, and then you add everything there. So that, but yes, a positive approach. That's what I was saying, a good psychological counseling, though we have counselors in our team, but I think we need to learn, because patients want it from your mouth, your discussion. So we also need to learn these communication things, psychological counseling, everything, but you are true. What you are saying is everything is true.
Shalja, excellent. Your topic actually to me has two parts. When we talk of adherence can be physician related. Means when we are sticking to the guidelines, we are prescribing the right thing, we are doing the ethical practice, we know how to counsel the patient. All these are physician related adherence. Another part of adherence is patient related adherence. There are many factors which are actually related to the patients, and which often in a busy practice we fail to understand and we fail to answer. Now why I am saying so, yesterday night we were discussing, today in our country, in a year, 320 conferences on diabetes are happening, right? And few years back, we have done a survey in Haryana, collecting how our general practitioner colleagues are treating patients of diabetes. And to my utter surprise, Shalja, despite so much of teaching happening, people, means physicians, they are actually not changing the way they should actually practice diabetes. And to me, that is the biggest barrier in adherence to the care of diabetic patient. Why our patients are not coming to less than HbA1c of 7%, why their blood pressure goals are not coming to the target, why their lipid LDL goal is not coming to the target. We all are involved in teaching in institutes, in conferences, but I do not know why when we go back to the home, we does not change our practice. So that gap either needs to be studied in a bigger way or needs to be addressed. Otherwise, all these discussions remains to a bigger room, and then we go back and we start practicing the way we are doing it.
I think let's remember Dr. Vijayakumar, and from Akshay Tritiya, which we start good things, let's say that we will change and do some change in our practice.
That is nice to have a professor. Of course, in Tamil Nadu we don't have endocrinology. Professor, good, welcome. Yes, you are Madras bred. Okay, I agree. See, his experience, I think, I agree. Now the Madras is corrupted in diabetes and diluted. Look at him. Okay. The question in diabetes, the goal is near normoglycemia, if not normoglycemia. That is the thing. Whether we achieve it with sulfonylureas or metformin or plain insulin, or somebody I heard that you are all here only to promote SGL2, or get cretins. That is not the way. Because even now we don't know, in the past, just a decade ago we have been talking about DPP4 inhibitor. We still don't know whether they protect the beta cells. So this cardioprotective, nephroprotective, it is not our job to promote them. Let the cardiologists come and accept. And we don't have enough evidence. These are all marketing tools. What he said is absolutely correct. The outcome is much better if it is done in a tertiary care institute with a dedicated team. Here, for obvious reason, in India we don't have general practitioners, we don't have general physicians, because everybody has got somehow diabetology diplomas. That is the reason for our downfall. That is why we have numerous conferences with empty halls. Thank you. Please.
I think, there's a study about the adherence, which also you presented in your things. For the oral medication, the adherence has improved. For the glucose monitoring, it is about 59, and one more thing is 56. But the adherence is very poor for the diet and for the physical activity. So that has been shown. And as you rightly said, adherence must be emphasized in every field. It is a science by itself. And as pointed out, we are not doing enough. I have only two questions to ask. Professor Mahadevan, please, I must tell you that it has been said today, you rightly said that the celiac disease also has anemia because of so many regions. And one of the regions is autoimmune, we do not see. I was told that about by Govind Makharia that, you know, it is that we have in type 1 diabetics up to 16% people. Out of 100 type 1 diabetics, 16 of them might be having celiac disease, which were not necessary to test. But if they have IBS of diarrheal type, then look into whether they have any one of the three things, transglutaminase or whatever, to diagnose celiac disease. Do you agree with that? First question. The last question, I'll hand it over to you. The last question is the very important fact that sickle cell anemia definitely interferes with the H1C estimation. Few of the new instruments that are available at a very affordable price, the glucometers of some things, they are also, I am told, are made eligible or made empowered to test for the H1C even in presence of hemoglobinopathies.
The second part, difficult to answer. See, the Biorad 10 and the advanced turbo varieties, in glucometers, the point of care HbA1c, whether it will detect this abnormal hemoglobin is questionable. I think that will not. That will not. I am not sure. That maybe we should be aware of that. The first question is, you are right, sir. In type 1 diabetes, already autoimmune prone, especially type 1A diabetes is prone. In them, diagnosing celiac disease should be routine. I mean, that is an yearly screening. What I mentioned in my talk is this, our South Indian thing. And so many patients of type 1, there are nice two papers also from, as I said, Vijayakumar Medical College and other college. They have done almost 100 patients of type 1, they have screened, and it was much less. It was less than 5%, and the two antibody positivity. So what I can suggest is, if somebody, especially a child, you are following up with type 1, if there is, growth problem or a pubertal problem or anemia, it need not have GA symptom. That's the important point in celiac.
Many of the kidney failure, I mean, they do improve with the iron therapy. The topic was anemia. So simple iron therapy also improves a lot of the kidney disease things.
To Dr. Mahadevan.
Actually, sir, as far as celiac disease is concerned, the prevalence is hugely variable depending on the population where you are seeing. If you talk about North India, the prevalence of celiac disease is as high as 1 in 300. So virtually all patients who are suffering from autoimmune disorders or even without autoimmune disorder, we have a paper published, Unexplained Infertility in Journal of Infertility and Sterility. Unexplained infertility, celiac disease is the cause. You treat celiac disease, the women will conceive, easiest possible treatment. So it all actually depends on which part of the country we are living, although with admixing, we are seeing still here. Coming to anemia in CKD, treatment of anemia I think does not improve CKD function, because anemia once develops in CKD, already the mass is quite low. So, but we have to treat anemia. We have to treat anemia, that is important.
About this celiac disease, it is not, many autoimmune diseases coexist with the type 1 diabetes. As you rightly said, annually, it is hypothyroid, pernicious anemia, those things that is why we want, see in India, in Chennai, unfortunately, the young diabetes, even in Institute of Childhood, we don't have what is the point in having an endocrinologist as a professor? Our job is just like his government department. Every college should have a endocrinology professor. Then only our academy, we will, there lies the point. Even Mohan has got the diabetes center is in the private setup. So we don't have celiac disease data, we don't have, there lies the problem. This is how Das is being misguided the whole career. Welcome. See, we want people like you.
Regarding pioglitazone, because I am a most powerful insulin sensitizer as on today, I am one of the very frequent user of this molecule. Regarding the bone loss, I was interested in knowing, is there any way to prevent the bone loss of this drug by simultaneously using calcium, vitamin D, and there's one paper by probiotics can to some extent decrease the bone loss with pioglitazone.
In an academic forum, it is worthwhile mentioning the mechanism of how pioglitazone causes bone loss. It is not by the usual, calcium vitamin D mechanisms, and it replaces the bone by fat. The PPA or gamma is proximal to the progenitor cells dividing into osteoblast and lipoblast. So that in that step itself there is a problem. So the osteoblastic lineage, instead of going towards the bone pathway, they go towards the fat pathway. So your bone is actually replaced by fat. This is very well documented by animal studies, human studies, MRI studies, you can go on and on. So the longer the use of pioglitazone, more likely that they are going in for a severe bone loss. So my small suggestion and important suggestion is, at least in postmenopausal women who are already at high risk for osteoporosis, and if already they have a bone related problem like a fracture patient, for suppose a 60-year-old lady, she has come to you with a hip fracture or asymptomatic vertebral fracture, in her at least you don't give pioglitazone. You have umpteen number of other drugs today to control diabetes.
But in practice, it is not osteoporosis, it is coronary events. See, what we get is that overdose of, first thing the cardiologist will stop the overdose of, this is the problem when general practitioner and general physician take you patient don't want insulin, you give pump up the glycosol, patient ends up with complicated either in nephrology or cardiology.
So I was wondering, as and when these slides come on these kind of talks on patient-centric, like I feel that it means we were not patient-centric before. Why are we rededicating ourselves? We should be, right from our MBBS days, that is the teaching. You should treat the patient as a whole. அதெல்லாம் ஏற்கனவே சொல்லி கொடுத்தாங்க. இப்போ திடீர்னு என்னமோ அந்த புது வார்த்தை பேஷண்ட் சென்ட்ரிக்னா அப்போ இவ்வளோ நாள் இப்போ நீங்கள் என்ன சென்ட்ரிக்கு அப்படின்னு இருக்கிற கேள்வி எனக்கு வரும் மைண்டில்.
So actually, I want to add up to this, sir. Sriram, I just want to add up this. See, it's not a patient-centric. It's a more of nowadays we are actually going towards the decision making. You make decisions along with patients. Patients should get involved in decision making of many things. It's actually cumbersome, time-consuming. See, if a patient decides that he should follow this lifestyle, he definitely follows. So the adherence improves there, and whatever we say, whether medicines or anything for that matter, it goes in very well, and patients do achieve the goals very well.
Even in treatable and curable conditions like tuberculosis, we have a very poor history in the last 6 decades. Even now we are saying that it should be eradicated. Here we have a condition where it is not cured, and there are already too much of media messages on these. You are only controlling, you are maintaining the disease. Now maintaining control, maintaining the disease na the opposite of what a pressure. Thank you.
Strong case for diabetes being elevated to the super specialty. In super specialty, the consultant spend more time and involve the patient, educate the patient. Okay?
Sorry.
There are no studies to that in a well qualified team, the outcome is much better, cost is less.
Sir was asking about pioglitazone or glitazones and anemia. That is mainly because of the hemodiluting factor, water retention issue. But bone marrow also, that's absolutely correct. If the marrow is replaced, then that's all. That's in extreme cases. So glitazones, there are some issues. That's the whole idea.
My question, I know you're talking about bone, but what is your opinion about sarcopenia? Not with type 2 diabetes, but because of the drugs, like SGLT2 inhibitors.
Okay.
Anyone can. Yes, Rajesh. Yeah.
Sarcopenia per se, I'm not too sure.
But
water loss.
Yeah, please contribute.
Shalja, when we are talking of sarcopenia, first we have to differentiate whether it is pathological sarcopenia or physiological sarcopenia. After 5th decade of life, all of us are going to have some decrease in muscle mass as a part of aging. But that is not pathological sarcopenia. In type 2 diabetes, this sarcopenia might be exacerbated. And there is a simple test from raising up from the chair. How quickly in 10 seconds, how many times you can get up from the chair. That is one of the easiest tests. If we see drugs, DPP4 inhibitor and GLP-1 RA, they are found to be protective to the bones. As far as sarcopenia effect on SGLT2 inhibitors are concerned, the DEXA studies have clearly shown the amount of fat loss is predominantly visceral fat. But then we have to remember, whatever way we are trying to lose body weight, some amount of muscle mass is also decreasing with whatever form of therapy we are using. So whenever we are using such type of therapy, advocating isometric, isotonic exercises so as to maintain that muscle mass will only prevent us.
That's great, sir. That's the nice discussion.
Thank you, ma'am, for the
Sir,
wonderful topics. I want to
oh.
know, in a type 1 diabetic patient with anemia, apart from hypothyroidism, what other investigation we have to do, sir? If hemoglobin is less than 10, say 9.
Anemia basic evaluation, peripheral smear. It will give you a good clue, microcytic, macrocytic. Macrocytic, if it is predominant, then obviously it is going towards folate B12 pathway, which is very common in type 1. Provided the nutrition is okay, you get a good history. Then comes hypothyroidism. If the type 1 is more than 5 years, CKD, then celiac. The etiology. First one, the broad classification. Are we looking at anisocytic, microcytic, macrocytic? This is first clue. Then of course you can, if the iron predominant, then you have to get a ferritin and saturation. And this is basic and algorithm. It's not, there was no time for all these basics. It's not difficult to pinpoint what is the cause, and in a given patient it will be always mixture of 2-3 things. So
whether we have to do vitamin D deficiency status, vitamin D status for them.
I personally feel in a low cost setting, more than testing, you treat it. Especially in type 1, you treat it. We have had enough discussions on vitamin D.
Yes, sir. Thanks for all the nice discussion, sir. Thank you. It went very well. So that comes the end of part A, the food for thought session. Now we got second part. First topic is early gestational diabetes. What does it mean? We know the increasing incidence of GDM nowadays due to various factors like obesity, late marriages, PCOS, etc. There's a huge list. Even to define when to test for GDM itself is a big question mark. And to answer that, we've got our eminent speaker, B. Mohan sir. As a legend, we know all about it. But unfortunately, he's not able to make it today personally. But he sent a video of that which will be playing. Then our experts will answer the questions if there's any. On to the video, please.
G. Vijayakumar, the Organizing Secretary of the 3D 2023. Dr. Vijayakumar has always been very kind to me, and he has been inviting me for almost all his meetings. I've always found that his meetings are of a very high caliber and also very practical and clinical. And I'm sure that this edition will also be like this. Congratulations to you, Vijayakumar. I'm so proud of you. Keep up the great work that you're doing. I'm going to talk on a topic on which I don't normally talk about, early gestational diabetes. What does it mean? Now, the reason I'm going to talk about it, I think we have some new data, some of it which I can share with you, and some of it probably will be online and published quite soon. So what is early GDM? Gestational diabetes mellitus, as you all know, is normally diagnosed between 24 to 28 weeks. In fact, the American guidelines, European guidelines all say that if you want to look for GDM, only look in the 24th or 28th week. Before that, if you want to do, it's just to rule out pre-existing diabetes in the first trimester. They are not talking about first trimester or early GDM at all. But what happens if GDM occurs before 24 weeks? This is called as early gestational diabetes mellitus. This is a term which we have coined and it's now becoming quite popular. It's also called as eGDM for short. So just to distinguish this eGDM from the conventional GDM, we have given two terms. One is called cGDM, which is conventional GDM, diagnosed in 24 to 28 weeks of gestation. And eGDM is diagnosed early. We don't have a strict definition for it, but it's at booking. Normally in India, it's below 12 weeks. Sometimes it can be 14, 16 weeks, but definitely in the first trimester of pregnancy. How do you diagnose early GDM? Now, when you do a blood sugar, fasting blood glucose, to rule out pre-existing diabetes, obviously if the fasting is more than 126 or H20 is more than 6.5, this is pre-existing diabetes. Even if you have pre-diabetes, it could be pre-existing pre-diabetes. Now, based on the HAPO study, in 2021, the IADPSG proposed a diagnostic criteria. What they said was that if the fasting plasma glucose is above 92 but less than 126, this is early GDM. Later on, they have revised it, and based on the latest studies which are coming, which I'll talk about, the toboggan study, this may get revised a little bit more. So as we speak now, early GDM, we all know it's there, but we really don't have a good hang of it, and we also don't know what to do with it. And I hope to throw more light on this as we go along. Now, one of our PhD students, Hannah, she's doing a PhD exclusively on early GDM. Now, where is her cohort from? A cohort is based on what is called as the STRIDE study. Now, STRIDE study is being done by us in collaboration with Dr. Saravanan Ponusamy, whom you can see here. He is a professor of diabetology at the University of Warwick, and he is one of her supervisors. But her main supervisors for her PhD are based at Deakin University in Melbourne, and you will find their names here: Kevin McNamara, Vincent Versace, Eric Martin. These are the people who are actually guiding her for her PhD, and of course I am her guide as well. We're very happy that Dr. Umaram is our obstetrics colleague, and of course we have our own team, Anjana and Dr. Deepa, and of course Hannah Bex, Baudarani and others. So this is a systematic review which Hannah wrote, trying to compile every paper published on early GDM to see what is known. And what we found is very interesting. There are 58 studies, and of these, 41 were on prevalence. And look at the range of prevalence. It varies from 0.7% to 36%. Obviously, this is because of different diagnostic criteria being used. One criteria will give low prevalence, another will give high prevalence. That is why it's time now to kind of standardize this early GDM. Risk factors for early GDM from all the systematic review that we did was BMI, previous history of GDM, family history of diabetes, and multiparity. These came out. Now, we further looked at, in the systematic review, Hannah looked at the birth outcomes, and 23 studies reported on macrosomia, cesarean delivery, induction of labor. Now, what also came out clearly from that systematic review is that the need for insulin was higher than in the conventional GDM. And postpartum, if you look at the development of prediabetes, diabetes, that is also higher in those who had eGDM compared to normals, or even compared to the conventional GDM. Now, some more points came out from this, that the eGDM with a lot of ifs and buts, showing that more studies need to be done. Then came out this particular meta-analysis of 13 cohort studies, which showed that there is a greater relative risk among people with early onset GDM compared to late onset GDM. So these people didn't use the term conventional, they used the term late onset. So perinatal mortality, neonatal hypoglycemia, and insulin use was higher. This is exactly what we showed in our systematic review as well. Let me now pass on to what is called as the STRIDE study. STRIDE is an abbreviation for stratification of risk of diabetes in early pregnancy. What we aimed to do initially in STRIDE was to screen all women during the first trimester and then see how many of them will develop GDM in the second trimester, and going back, can we develop a kind of a risk score for GDM? That was our initial intent. But it turned out that when we started screening, there was a lot of early GDM also. So this gave us a chance to compare early GDM with the conventional GDM. And this is one of the largest studies on GDM done in India. About 3,000 women aged 18 to 50 years recruited before 16 weeks of gestation. I would humbly submit that this is probably one of the largest series in the world on early GDM. Now, the investigators for this are Professor Saravanan Ponusamy, and I told you Dr. Umaram is our collaborator. We also have sites from Chennai. We have the Sitapati Clinic and Hospital EV Kalyani, but also Andhra Mahila Sabha, VHS in Chennai, Fernandez Hospital in Hyderabad. There are two hospitals and they are both collaborating. Plus, we have JIPMA in Puducherry. So you can see that a lot of government, quasi-government, plus we have private, charity-driven. So it actually represents all the socio-economic strata of society. What we did was that we did a fasting glucose. If it is the diabetic range, we excluded that. This is called diabetes in pregnancy. If it is normal, below 92, we did one more GGT in the 24 to 28 weeks, And if that time they had GDM, we call it as conventional GDM. That time also, if it is normal, we call them as normal glucose tolerance. Now, if in the first trimester, the blood sugar is between 92 to 125, we call them as eGDM. So now we have three groups. eGDM, diagnosed first trimester, cGDM, conventional GDM, diagnosed second trimester, and then of course, normal glucose tolerance. You compare these three, you can see very easily here, the numbers are quite large, as you can see. If you see the age, booking weight, BMI, waist circumference, blood sugars, HbA1c, all higher in the eGDM. Now that is why they're getting it early, and they're all statistically significant. So they have a more severe form. Even the A1C you can see not significantly high. I mean, it is significantly higher, 5.1, 5.2, 5.3. So there are significant difference between the cGDM and the eGDM. Now, what are the risk factors for eGDM in stride? Booking HbA1c. If your HbA1c is higher, you get eGDM. Then BMI, previous history of GDM, history of GDM in the family, all these came out as significant risk factors. Now, how do we screen for early GDM is another question. Do we do selective screening? That's what the ADA recommends. Or should we do universal screening? Now, if you look at ADA, they talk about the selective screening, but look at point number 3. Member of ethnic group with high diabetes prevalence, South Asian they put. So they are suggesting that South Asians should have a complete universal screening of all pregnant women. They themselves are saying it. Therefore, it's not surprising that in the DIPSI guidelines, which were published in 2006, almost 17 years ago, DIPSI has already recognized that all pregnant women need screening. Of course, they're not talking about early diabetes screening here, but they're saying that everybody should be screened. So it makes sense that if you don't want to miss early GDM, you should diagnose everyone in the first trimester, and I completely agree with the DIPSI guidelines. Now, which test to use for early GDM is still a matter of debate, and it still needs more work. Will you do an OGTT? And if so, will you do a one-step OGTT or two-step OGTT? Will you just do a fasting glucose, or will you do a random glucose, or will you do a HbA1c? I think more randomized clinical trials are needed in early GDM, as has been done in the conventional GDM. Now, I'm going to talk to you about a very important study, which is going to be a game changer as far as GDM is concerned. This is called as a toboggan study. Toboggan stands for Treatment of Booking Gestational Diabetes Mellitus. I told you that very little is known about early GDM, especially what to do if you diagnose early GDM. There is no evidence at all. The systematic review and all are based on some observational studies done randomly. We gave all funny results. You have to do an RCT. You pick up women with early GDM, treat one group, don't treat another group, and see what happens. That's the only way that we can actually show evidence that treatment is, number one, beneficial, and number two, safe. Sometimes we start treating them too early, we may cause harm. So that is what toboggan was all about. The first multi-center RCT for the diagnosis of hyperglycemia in women before 20 weeks of gestation. And we want to understand what happens if you treat this early GDM. Now, when the HAPO study was done and the IADPSG criteria were established, there was a criticism that there are no Indians in this. There are no South Asians in this. So we wanted to, in toboggan, we wanted to see that there's good representation from India. So from the Sitapati Clinic and our MDRF, myself and Anjana and Umaram are actually collaborators on the study, and we have provided the data on our early GDM. So India is very much part of this. Apart from that, this time they were careful. They've included a lot of South Asians from Australia itself. Most of the collaborators are from Australia, but we also have some people from Austria, Sweden, and from India, of course. 16 sites. We take women with in whom there's no pre-existing diabetes. And for toboggan, because it's mostly based in Australia, we didn't do universal screening. We took those with the high risk. That means BMI more than 30, past history of GDM, macrosomia, first degree family history of diabetes, or ethnicity. These women then underwent the following tests. Just like we did in STRIDE, what was done is that we did an OGTT in the first trimester. Now, if you had pre-existing diabetes, they were removed. Even if they had fasting more than 110, because that means pre-diabetes, they were also excluded. Now, you're taking people who don't have diabetes, don't have pre-diabetes. And then we did the GTT. Now, in them, using the IADPG criteria, we diagnosed GDM in some. What we did was, those who had GDM, we had 400 in the intervention arm, where they are going to be treated, 400 in the control arm. Although they have GDM, we're not going to treat. We're just going to follow them up and see what happens. You may say, is it ethical? Well, there is no guideline how to treat. So how do we treat unless you do an RCT and prove it? Suppose you do harm by treating too much. So therefore we can't. This is the definitive study. In a definitive study, until the study is published, it is ethical. Once the study is published and shows some good results, it will become unethical not to screen. That is how the entire medicine progresses, and that is how progress in medicine always occurs. So we have a control group and we have intervention. It's a proper RCT. Now what we did very cleverly was, we also included some women who did not have GDM and took them through the same protocol. They call as decoys. Why should you have decoys? Because sometimes just putting women in a trial will make them better, okay, and they'll have some benefits. So to see whether this effect that we're seeing due to intervention is simply a placebo effect or not, we had the decoys. And then of course there are women whom we didn't do anything, we just left them alone also. That's a non-active group. Now, unfortunately, I'm not able to show you all the tables in this graph. The reason being that tobogam has just been accepted for publication in the world's #1 journal, New England Journal of Medicine. I'm very humble that we have been included as authors in this, as primary authors in the NEJM paper. Therefore, in a major game-changing study which is there in the field of GDM, India will have a representation as well. And so that is something which we are very, very happy about. But NEJM has not yet published it. It's just accepted it. Now the proof stage is coming and it's going to become online. So they've given strict instructions not to publicize or present the data. NEJM is very strict about it. So we'll have to wait for another. Unfortunately, if it was just 2 or 3 weeks later, probably I could have presented. But let's wait for it and you can see the results in NEJM anytime now. But I can just tell you what we found. We found that there is benefit in treating eGDM. For the first time in the world, we are showing that treating eGDM is good. The natural history of early GDM is also well defined because one group we did not treat at all. One group there was decoy group. So we know exactly how the natural history of early GDM is with treatment and without treatment. And then it also showed that there were no side effects. Okay, so it is safe. Now, further tobogam, after the New England Journal paper is published, we have some more papers submitted to ADA, EASD, and others, and to DIP meeting, the Diabetes Pregnancy meeting in Greece next year. Series of publications looking at cost effectiveness, diagnosis, treatment, and various methods, and various papers will come out from tobogam. And I'm very happy that India is part of that. So I'm going to end, ladies and gentlemen, by saying that these are my take-home messages. Early pregnancy blood glucose screening for GDM will now become mandatory. You have to do that. We've always been saying it in India, but now the whole world will start saying it, as it helps in identifying pre-existing diabetes and also early onset GDM. Obviously, more work is needed. Now, this is opening up a whole new field in the case of GDM. So more work is needed. How to screen, who to screen, what method to do, is metformin better, insulin better, which insulin to use, which at what level will start insulin, what happens to them during the later part of pregnancy. All these will need series of additional studies to be done. So early GDM is really going to take off after tobogam results are published. But it's now clear that early GDM must be diagnosed and treated as the pregnancy outcomes can be improved. So my take-home message to you is early GDM is a definite entity, #1. #2, it must be identified. #3, it must be treated. Now you can continue the treatment as you would treat, maybe with diet, exercise, in severe cases with insulin. That is left to you until more guidelines come. But this is my take-home message to all of you, that early GDM or eGDM is now a real entity and it must be identified and treated. And with that, I would like to stop by once again thanking Dr. Vijayakumar for organizing this excellent meeting, and I hope that this talk has been useful to you. Thank you very much.
That's great talk, sir. Just excited, just as we are to learn about TOPO-GM and its results. We are awaiting the very soon also. We will take up the questions. It will be answered by our experts once the session is over. Now,
the next topic is artificial intelligence and digital technology in clinical decision support. I call upon Dr. Lily Rodriguez to be on the dais. As you are all aware, the artificial intelligence and the various technological advances are going to be very useful in the early diagnosis of diabetes, hypertension and various other metabolic diseases. Not only that, they are also going to be very helpful in ensuring patient adherence and also in patient monitoring. To talk upon this, I call upon Dr. Lily Rodriguez, consultant physician diabetologist. Over to you, ma'am.
Thank you for your kind words, Chairman. And at the outset, I would like to thank Dr. Vijayakumar. I really do not know why he has given me this topic, because when I surfed through preparing the slides, it has taken me several days, and I thought it requires more than 2 days to actually cover the entire topic. But I'll try my best to finish it in 20 minutes. Digital technology or artificial intelligence. My talk will be, I'll be introducing the topic, electronic health records, real-time data analysis, artificial intelligence itself, telemedicine, patient empowerment, and then little bit on the challenges that we face. Digital technology has revolutionized the healthcare industry, just like any other industry, transforming the way clinical decisions are made. With the advent of the digital health tools, clinicians can now make more informed decisions based on the data-driven insights. In this presentation, we will explore the impact of digital technology on clinical decision making and how it is changing the landscape of healthcare. So now coming to the electronic health records, we all know, because most of us are using this, electronic health records, I'm sorry for the lot of text in this, electronic health records are digital versions of patients' medical records that can be accessed and shared securely by authorized healthcare providers. EHR systems can contain a range of information, including demographics, medical history, diagnosis, medications, immunization status, allergies, lab tests, and radiology images, and many more things. One of the primary benefits of EHR systems is that it allows doctors to access patient records in real time, regardless of where the patient is living or receiving the care. This means that doctors can quickly review a patient's medical history, lab results, medication records to make more informed decisions about the diagnosis, treatment, and medication management. EHR systems can also improve care coordination among health providers who are living in other parts of the world as well. So we can take help regarding the patients. Now, real-time data analysis is another term used. One of the key benefits of digital technology is clinical decision making. Clinical decision making is the ability to analyze the real-time patient data. Digital health tools such as wearables and connected devices can provide clinicians with continuous streams of data that can be used to inform treatment decisions. So with real-time data analysis, clinicians can identify patterns and trends in patient data that may not have been visible before. So this can lead to the earlier diagnosis, more personalized treatment plans, and better patient outcomes. This also, real-time data analysis in clinical medicine refers to the use of advanced technologies and analytical tools to collect, process, and analyze medical data in real time. The goal of the real-time analysis is clinical medicine to improve patient outcomes, as I already said, by providing healthcare professionals with up-to-date and accurate information that can be used to make informed decisions. Now, improved accuracy is the most important thing, that is artificial intelligence algorithms, because they can analyze vast amounts of patient data and identify patterns that may not be visible to human clinicians, leading to more accurate diagnosis and treatment decisions. Increase efficiency, Increase efficiency with the digital technology can automate many routine tasks such as data entry, data analysis, allowing the clinicians to focus on more complex decision making. Now, so ultimately, better outcomes is the hallmark. Artificial intelligence and digital technology can help clinicians make more informed decisions, leading to improved patient outcomes and overall healthcare quality. So it has been used heavily in COVID times, we all know, and in fact, the telemedicine and digital healthcare has improved a lot because of the COVID and during the COVID and after that. Now, coming to the artificial intelligence, this is another digital technology that is transforming the clinical decision making. AI algorithms can analyze vast amounts of patient data, and then it will provide the clinicians with insights that would be impossible to obtain manually at times. For example, AI can help clinicians predict patients' outcomes even before you start the treatment, identify potential drug interactions, and even suggest treatment plans. As AI continues to evolve, it has the potential to revolutionize the way healthcare is delivered. Of course, it doesn't replace the physicians, it only helps. So it helps in diagnosis. It can, AI algorithms can be trained to recognize the patterns in medical data that may indicate a particular condition, making it easier and faster for doctors to diagnose patients. Treatment selection can be helped, risk prediction can be assessed, and then it also helps in the clinical trials. NLP, or natural language processing, is another term that we should know. This NLP algorithms can analyze unstructured data from clinical notes and other sources, providing clinicians with the relevant information to inform their decision making. And then we have machine learning. Machine learning algorithms can identify patterns in the patient data and predict potential outcomes. So this helps in the predicting the potential outcomes, allowing clinicians to make more informed decisions about the patient care. There are many apps that are available. We all are aware of this. These mobile apps that provide decision support to clinicians, such as drug dosing, calculators, and then clinical guidelines, and many other apps that are available to calculate, for instance, diabetic risk score, or cardiac risk score, and etc., etc. We all are used to it. Now, coming to telemedicine, it's another digital technology, has significant impact on the clinical decision making. Now, can remotely consult with patients, review their medical records, and make treatment decisions without the need for an in-person visit. Now, beneficial for patients who live in remote areas or have mobility issues, and sometimes, it helps patients who cannot be moved or bedridden. Also allows clinicians to collaborate with the specialists from around the world, providing patients with access to the best possible care. Now, telemedicine provides a remote medical care and health services, rapidly growing field, And here are some points to elaborate on telemedicine. As by definition, telemedicine refers to the use of technology to provide medical care and health services from a distance. So using various devices such as smartphones, computers, and other internet connected devices. So most important thing is patient should be internet connected. Then types of telemedicine, we have, there are mainly 3 types: store and forward, remote monitoring, and live video conferencing. What is store and forward? Store and forward telemedicine involves sending medical information such as medical images, videos, or other data from one location to another for evaluation. So patients can send it to us, or we can send it to somebody else and then come to a conclusion. Then remote monitoring allows healthcare providers to monitor and track the patient's health remotely using devices such as blood glucose monitors, heart rate monitors, and other wearable devices. We all know live video conferencing has come order of the day nowadays. Most commonly used type of telemedicine, it allows healthcare providers and patients to interact in a real time through video conferencing platforms. There are various platforms available. Only thing is that we need to see that it is legally accepted. Sorry about this. Now, Government of India has given official guidelines to conduct telemedicine. This has come about particularly after the pandemic. ICMR also says that the framework for telemedicine used in management of cancer, diabetes, cardiovascular disease, and strokes, particularly all the NCDs. Telemedicine practice guidelines have been published in 2020, and we need to know about that. Now, sedatives and narcotics cannot be prescribed during telemedicine consultations. This is a point to be noted. And we all know the story of Riya Chakravarti, who filed consumer complaint against 2 doctors in Delhi in National Consumer Forum for prescribing narcotics on telemedicine consultation to deceased Sushant Singh. Now, coming to the patient empowerment, digital technology definitely empowers the patient with the knowledge in their hand, with the health tools to track their symptoms, monitor their medications, and communicate with their healthcare providers. By giving patients access to their own health data, they can become more engaged in their own care and make more informed decisions about their treatment options. This can lead to better outcomes, as we all want, and improved patient satisfaction and health of the nation. It becomes very personalized when the patient is empowered. Then health monitoring can be done better. Patient education is improved. Early diagnosis definitely is made because of the artificial intelligence that can analyze the medical images. Then health management, artificial intelligence can help patients manage their chronic conditions by providing personalized reminders, medication management, and lifestyle recommendations. Now, there are wearable technology is the thing nowadays. Digital technology can provide doctors with access to clinical trial data, allowing them to make more informed decisions about treatment and treatment options and medication choices. There are various wearable technology tools available. I don't need to go through this. Now, current examples include sensors in monitoring and treating OSA, CGM in diabetes, management of type 1 diabetes with pumps and CGM, COPD management, extensively used in COVID-19, and reduced risk of transmission of infective viruses between healthcare provider and the patient. clinical trial data, the artificial intelligence has become very important, because digital technology and artificial intelligence can provide doctors with access to clinical trial data, allowing them to make more informed decisions about treatment options and medicine choices. So artificial intelligence is being increasingly used in clinical trials nowadays to analyze, to interpret large amounts of data generated from various sources such as EHR, medical imaging, genomics, and wearable devices. And here are some of the ways in which AI is being used in the clinical trials. That is patient recruitment, protocol optimization, and endpoint determination. Data analysis can be done by the artificial intelligence, then predictive modeling can be done by the artificial intelligence, and then overall artificial intelligence has the potential to improve the efficacy and accuracy of the clinical trials, reducing the time and cost involved in bringing new treatments to the market. However, it is important to ensure that the data used in artificial intelligence models is representative and unbiased, and that the models are transparent and interpretable. So, digital technology can provide doctors with access to clinical trial data, allowing them to make more informed decisions about the treatment options. So now, a few words about virtual platforms. Virtual patient simulators are available, which can improve clinical decision making, learning, and engagement, particularly for students. So according to George Brown College research study, students indicated that working with the virtual patient simulator on a wide variety of simulated clinical scenarios provided them with the knowledge, skills, and confidence for making a better learning. Benefits of virtual platforms: feedback, understanding the results of one's performance, repetitive practice, curriculum integration, range of difficulty levels, and then multiple learning strategies, like employing simulations in a variety of settings, including independent learning, lectures, tutorials, and small groups. So clinical variations, controlled experiment, individualized learning, defined outcomes, benchmarks, or simulator validity. All this can be done through the virtual platforms. Now coming to simulator validity, approximating complex clinical situations and tasks in an authentic, realistic manner has to be done. Now there are challenges and future directions. While digital technology has the potential to revolutionize clinical decision making, there are also challenges that must be addressed. These include issues related to data privacy, and then interpretability, and regulatory compliance. So looking to the future, digital technology will continue to play an increasingly important role in healthcare. As new technologies emerge, clinicians and healthcare organizations must stay up to date with the latest developments and adapt their practices accordingly. So, data quality must be accurate, and completeness of the patient data can impact the accuracy of AI algorithms, leading to potential errors or biases. Then bias, yes. Artificial intelligence algorithms can be biased if they are trained on data that is not representative of the patient population, leading to potential discrimination or unequal treatment. So, ethics. The use of artificial intelligence and digital technology in healthcare raises ethical questions about data privacy and security, as well as the potential for bias or discrimination. This we need to take care. So I thank each and every one of you for patient hearing. Thank you.
Thank you very much, ma'am, for your extensive and elaborative lecture upon the role of artificial intelligence and digital technology. So this is just a beginning. We already explained the prospects. We are just in the beginning stage, I should say. Yeah. Still lot to be explored and still lot to be implemented. Thank you.
Thank you.
I would like to welcome our next speaker, Dr. Suresh Damodaran, who is a well-known person in the field of endocrinology. Of course, we are now talking at a time when the population of India is topmost in the world, the infertility in India. Yes, the problems are multifactorial, and I would like to hear from Dr. Suresh Damodaran further. Thank you.
So good morning, everyone. Thank you very much for the wonderful opportunity. I think it's an exciting session. We heard quite a lot from Dr. Mohan and about the technology as well. So this next 20 minutes or so, if I can touch base on the challenges, it's a huge topic what I've been given, diabetes and infertility. It's slightly gross and it's got quite a lot of things that has to be taken into consideration. So what I've done is just about 2-3 case scenarios I've given, and then hopefully we'll learn from that. So this is what my talk is going to be, and one of the challenges, the PCOS, which I will talk very briefly. But this is the case of a male infertility, so a 32-year-old male, obese, and got married 4 years, and I think inability to conceive is the biggest challenge for this couple, and A1C is 8. How do you do it, and what do you do? Normally there is as I mentioned, as even the chairperson was mentioning, infertility is a big problem, and we know the diabetes itself is a huge challenge for our society, and the male reproductive function is definitely affected by that, and that has been proven with quite a lot of data that has been generated over time. And this is the mechanism of diabetes with male infertility. So if you go for the endocrine one, the hormonal challenges will be there. I'll touch base on the last case scenario, and then AG, advanced glycated end products, and then oxidative stress, and also diabetic neuropathy, which will be leading. I'll show a sketch will show how the diabetic neuropathy is affected. So 90% of the diabetics are affected with sexual dysfunction. The one thing we always discuss is the male sexual dysfunction, but the female sexual dysfunction is not being discussed anywhere, and a lot of data is not being generated in that area. And when the country is improving, probably that will come out as well, but we need to work on that. So it is as I said, that there's quite a lot of data has been generated with the male fertility showing the sperm count is down, and then the DNA damage and the hormones are down. So the deficiency or the insulin or insulin insensitivity affect the endocrine pathway, and there are challenges with Sertoli cells, and then hormone sperm production is affected. So effect on sperm, the role of oxidative stress, it has got its own way of affecting it. I won't want to go into the detail, but you have to know that OS is affecting the sperm production. Now this is the thing that I was mentioning earlier. So diabetes leading to all this ROS and vascular endothelial damage, and also that will lead to diabetic neuropathy, and that will eventually, due to autonomic dysfunction and also direct involvement, the nerves will affect the fertility. So the altered nerve function will eventually lead to the damage for the male reproduction. Now this sperm, the diabetes and sexual hormones, I'll come to that in the last case study, but it will definitely get affected with gonadotrophins, and then the hypothalamus, even the secretion is affected. The sperm parameters in type 1 and type 2, so it is not sparing even the type 1 diabetic, so it is got the sperm shape and function is affected. So that is about the male one. As I said, it's a huge topic, but I just given justice to show how the sperm and the hormonal and the RAS pathway and other things affecting the male fertility. And coming to the female one, which is a huge challenge, if you look at it, this is the 31-year-old with PCOS for 12 years. irregular periods and TSH is 7.8 and androgen levels are quite high. So how do you do it? It's a typical LH high and androgen levels are high. So how do you deal with this case scenario? As you know, infertility risk factors or menstrual abnormalities, androgen excess and autoimmunity, sexual dysfunction. You would have seen yourself a lot of ladies come in with infertility challenge. We got timer here? Timer there somewhere. Oh, that, right, fine. So a lot of the ladies would have come with autoimmunity, so you can't find anything else for their fertility challenges except the TPO antibodies or something will be strongly positive. So, and then obviously the sexual dysfunction as a whole will lead to infertility. So this is the hypothalamo-pituitary gonadal axis, this from the hypothalamus to pituitary, and then it goes to the theca cells and granulosa cell and the androgen. So if the wrong signal goes into ovaries, then the androgen will be produced more than the estrogen and progesterone. So this brings us to show that the type 2 is associated with all this, and then association of modern management and sexual dysfunction in diabetes. All these are the 3 parameters that as a gross I want to touch base on. So if you look at the metabolic syndrome and PCOS, it's going to be a bit theory, but I think this is the thing that mentions the insulin resistance will lead to quite a lot of challenges with free fatty acid, also reducing the insulin sensitivity, and that will lead to quite a lot of problems that leads to fertility. Now, depending on the diagnostic criteria, there is in India it's a huge challenge, but a lot of ladies are unreported for PCOS, and even if you consider how many people are reporting, it is the huge challenge for our community. So patient with PCOS associated, and then the thin PCOS are not addressed at all, but there are the weight, insulin resistance and dyslipidemia are the main 3 important factors. So hypertension, the metabolic one is also very important, because even the girls who are in IT field and people are not working sedentary lifestyle, they're getting into big problems because of that. At the early age, you seeing 26-year-old or 27-year-old male coming with heart attack, but similar to that, when you look at the woman, they will have 26 or 27, they'll have PCOS, and then the metabolic challenges already started developing. So that means that the diabetes and the obesity and also leading to metabolic syndrome related dyslipidemia, all causing problems. So by inducing excess androgen with adrenocorticotropic ACTH on the ovaries and adrenal gland respectively, and then the androgen excess further worsen the insulin resistance. So if you look at the relationship between insulin resistance and hyperandrogenism, it's a clear link that will cause the androgen excess. If you look at the metabolic disturbances, that will also lead to androgen like DHEA and other things. So androgens derangement will lead in metabolic syndrome, and then the androgen levels are quite high like testosterone. So that will lead to adiposity and insulin resistance. But if you look at it, there are multiple pathways and multiple relationships are there. So I won't go into the details, but obesity is another challenge that will lead to infertility. So you get a straightforward obese woman coming to your clinic with infertility. This is the 35-year-old married for 7 years, inability to conceive, and postprandially the blood sugar is high. How do you deal with it? As I said, the obesity, it's got a complex relationship. I'll show in the next case scenario, but the outcome of the pregnant women who, or the girls who are getting pregnant with obesity is very, very difficult in managing in terms of maternal side, also the fetal side. So increased BMI affect the fertility in multiple ways, and obese women have got a prevalence of amenorrhea and infertility even without any other explanation. That is because of you see typical PCOS women with LH high and SHBG low levels, sex hormone binding globulin. Again, the same mechanism what I mentioned in the metabolic syndrome applies here. So what happens is the adiponectin, the fat hormones, which is being discussed more in endocrine world with modern generation. If you look at our ancestors and our parent generation, the fat levels may not be that high, but with the modern generation, the fat level is extremely high, and the fat cell has got a lot of hormones coming out. One is leptin, adiponectin. It causes adiponectin is a very good hormone that will help not having the atherogenesis and complex metabolic conditions. So if you look at the ghrelin, which is going to be there, anti-ghrelin, anti-serum, and quite a lot of GLP and GIP, like gut hormones, in the next 10 years or so, even for diabetes treatment, you're going to see that area is the area that is going to be more developing or already in the research around pipeline for the areas where it is all the gut hormone related. So GLP, GIP, ghrelin, and a few other cholecystokinin, quite a lot of other gut hormones have been used as a therapy for type 2 diabetes. So women with PCOS have concentration of ghrelin, that weight matched control, and then androstenedione levels also getting affected. This published in JCM a long time ago. So obesity, I showed you how it affects the insulin resistance and also the metabolic things, but when it comes to pubertal and ovulatory dysfunction, you might have seen your neighborhood or somebody in your family or your friend's circle that juvenile diabetes obesity is associated with early age at menarche, and also they will have multiple challenges once the menarche is attained in terms of irregularity and not having periods for a long time. So androgen status tracked from childhood to adulthood and is directly relating to the fertility. So obesity, PCOS and infertility, as I mentioned already when I spoke about PCOS and stuff, it will lead to all this, and eventually the infertility happens in a woman. They sit in a fertility clinics which are all flourishing in India now, with all the fertility centers all over the place, which you might not have seen about 10-15 years ago. Now you can see board of infertility centers all over the place. So instead it should be, my view, there should be more of obesity treating centers by properly trained doctors, and that is not happening, but it's more of infertility centers, and then the PCOS women and all the women go to gynec and get the things addressed that way. But obese women have insulin resistance, as I mentioned earlier, lower SHBG levels and pulse frequency of LH and attenuated LH pulse amplitude is there. So IVF success rate, I won't go into the detail, but there is big problem when you get a PCOS, and it is not an easy job. So that takes me to the last case scenario. So I showed you about a male infertility case and a female infertility case, and also about an obese woman getting pregnant. So this is a typical type 2 diabetic which you see in the clinic, and A1C is not controlled, diabetic dyslipidemia is there, and the patient is an antidepressant with SSRI, and BMI is there quite high. So patient is on quite a few drugs including Lantus, but is compliant. Before completing the pharmacotherapy, he is hesitantly asking about something about the bedroom, which just means that they are trying to talk about the sexual dysfunction, but further questioning in that area showed that erectile dysfunction ED is there, and pharmacotherapy workup is there, and what is the treatment that you normally give, and whether just explaining and giving a PDE5 inhibitor will be the straightforward answer, or whether there is any, what is the etiology that you could describe in this case scenario. So it is a complex mechanism. Hypogonadism is another thing that happens. So a concept of hypogonadotrophic hypogonadism happens in type 2 diabetics with obesity. What happens is the leptin level, it talks to hypothalamus, and the pulse secretion of the LH-FSH can be affected, and therefore the production of androgen is decreased. It is a complex mechanism with the development of erectile dysfunction. These are all the things that is very, very important. You have to get a history from, and clinical implication. It has got a huge clinical implications in terms of even the psychological well-being. I showed you that case scenario with antidepressant on board. So it has got a huge impact on psychologically, that it might affect the clinical treatment or even the therapy of the patient. So ED will lead to cardiovascular disease, and this has been well proven. So if you got somebody with ED, that means that you have to screen them for cardiovascular disease. Anyway, you have to do it before giving PDE5 inhibitors. A lot of patients with PDE5 inhibitors, if they are on nitrates and other things, should not give that. So in this cohort of men, ED was associated with CVD. ED is part of the problem, but the point is the hypog is also prevalent in type 2. So how the evidence shows that the Dindesta, including 103 males, and it shows almost 33% of the males have free testosterone levels are less. So the percentage of hypogonadal man in type 2, it happens, it's published in JCM. And this is the trial from New York actually. It shows that hypog is common in type 2, and Kapoor is the guy who's done a lot of work along with the Dindesta in this area. And there is another guy when I worked in Lancashire, but the data is from Yorkshire actually. But the Kapoor one showed 75% of the people had got low testosterone, and this is the trial I was mentioning, trial from Yorkshire, showing again the levels of testosterone is less in type 2 diabetic, and the men over the years it comes down. This is the JCM one and published in ADA. So hyperglycemia or age to blame when you get a hypogonadism, but it's clearly showed that directly the type 2 diabetes is the one of the factor that can affect especially when they got more fat. So obesity and metabolic syndrome, I'll skip that because I've spoken earlier about that, but the insulin resistance also will contribute because of that. Then the hypothalamic response, neurons that is affected in the mice model can kisspeptin and other things place. These are all the peptides that's been discussed in endocrine world a lot. So this is the cartoon that I want you to take home if you want to. So that shows that insulin resistance and hypogonadism, this is a complex link that happens with the GnRH release affected, and therefore LH-FSH affected, and then that will lead to hypogonadism. And the leptin also plays a role when the leptin level, I mentioned about the fat cells in the leptin level comes down, and then you get a GnRH release. The leptin level goes up, therefore the GnRH release is affected. So when you think about diabetes causing hypogonadism, what happens when the hypogonadal man, when you get a hypogonadism, a lot of people might have got experience in treating Kalman's syndrome, which is not very uncommon actually, and even the Klinefelter's one where the hypogonadism is there. You see these patients, HH and even IHH, idiopathic hypogonadotrophic hypogonadism cases, they'll have a low testosterone level. This is published data from 2010, and that concluded that these people who got hypogonadotrophic hypogonadism already will go into insulin resistance, and they'll get into type 2 diabetes. So hope you understand, insulin resistance will lead to hypogonadism, hypogonadism will lead to insulin resistance. So it is a complex mechanism, but it will lead to arthrogenesis, and this is the evidence I'm showing, and CRP level also goes up, indicating hypog will lead to cardiovascular disease. And sexual dysfunction is also one of the things. So I would say with this thing, it is very common, and you need to consider that even before treating with PDE5 inhibitors. So almost end of my talk, so it's only one more minute. So so I summarize that that infertility is very common in diabetics, and I've shown you a case of female with infertility where the main factors are all PCOS and obesity, and I've also showed you a male how the sperm and the quality of the sperm and the hormones are getting affected, and Ross pathway and other things. And then the third case scenario I showed you is obesity, but that will lead to infertility, and also the fourth one where the concept of type 2 diabetics leading to hypogonadotrophic hypogonadism, therefore the fertility is affected. Thank you very much for the wonderful opportunity, but lifestyle is going to be the key, and I'm happy to take any questions.
Thank you Suresh for a nice wonderful elucidation, and of course the exhaustive topic you have tried to cover it.
Can you just
as you rightly pointed out, it's going to be a very complex one, and it's not going to be easy to treat. And we'll open up for the discussions. All the last three speakers. Last two topics. Any questions?
Madam, you want to come up? That's the conference I do in Coimbatore. Please do visit. That's in August. Thank you.
Sir, wonderful talk regarding the infertility in diabetes. And most of the young people come with the infertility, that is ED. Even after giving the PD, that is phosphatase inhibitors, right, is not improving, because the underlying cause is a depression.
Yeah.
Once he attains the state of decreased performance, the next day itself having the same similarity. So it can get amplified. So thereby when you give antidepressant small dose along with PD5 inhibitors, probably it might work. That's what I've been doing, but is it okay for that?
It's an excellent question. 2-3 points to that. One, the country is developing and the girls and boys are ready to talk about sex, and that is been a big change from the past. And I'm seeing even my clinic people coming after 1 week of marriage coming and talking about the performance of a male, because the girls, they want to settle in life, but the days of having just so much wealth is gone, but they want everything to be perfect, and that is a good change, number one. And number two, when you work up for sexual performance, as you rightly pointed out, you ought to assess the patient fully. First is the psychological, because 90% of the cause of the performance will be psychological cause, number one. And two, the point what I made in the last case is you have to assess the patient properly, because when you read in a textbook about endocrinology, you read about Klinefelter's or Kalman's and other androgen deficiency state, it won't just come like that. It won't just reach an endocrinologist alone. You might be the people who might be picking up. So open your eyes and do all the investigation, and also think about the science is also evolving. So with all that in mind, investigate the patient before putting on PDE5. That's the second point. And third point is, there are combination of, when you want to give a PDE5 inhibitors, tentelafil or whatever, the long acting ones, it's working very well, but if they got androgen deficiency, correct that and then give it. If you don't do that, then it won't improve. And there are combination of antidepressant dapaxetin with PDE5 inhibitors are available, so you can combine it and do it. And psychotherapy or psychological counseling is very important. Sorry, I took a long time, but it's very important to pass the message. Yes, boss.
I don't know. Mohan is always our boss. See, the problem with the combination is that sometimes it is premature, delayed ejaculation and anorgasmia.
Correct.
It is the side effect of our SSRI. So sometimes it may or it may not even work, but usually the sexologists give in combination. The response in a diabetic population is always poor because of the underlying unique pathophysiology.
So it is the blood vessel, sir is right actually. So diabetes is a micro and macrovascular disease. It's a vascular phenomenon. So if you look at the penis or the blood supply to the penis, it is going to be a blood vessel that is going to be affected. So the underlying mechanism is there. That is why the nitric acid pathway and PDE5 will work well. But on the other hand, if there is a long chronic diabetic with poor control and AGEs or in the roof, and then the challenge is the blockage will be more. Yes, sir.
In creatine cases, the hypothyroidism from pediatric age onwards, they develop libido. So, and psychologically they are not attached.
Yes, sir.
So, in those cases, what is the solution?
So, your question is, sorry, I didn't get that. So,
libido,
in creatine, in a young hypothyroid patients, you are saying that the fertility or the sexual performance is less. Yeah, okay. I didn't know this, but it is from his experience, sir is saying, but hypothyroidism, if you got it, you want to assess, there is a condition called polyglandular syndromes. You have to assess when there is a autoimmune hypothyroidism, hypoparathyroidism will be there, and then hypogonadism might be there as well. So if you want to assess for that, by all means do, but when you get a hormonal deficiency, check for other hormones.
So we have checked all investigations.
Yes, sir.
Including 7 count also is good, only performance is not there.
Sure.
So there is something muscular weakness or libido because of psychological factors. These are the two aspects we have finally come to.
Sure. But muscle doesn't play a role in penis. The muscle that is there may not be affected by hypothyroid, but this needs, as I said, this needs a lot of work, but a lot of things are psychological.
Yeah. IQ is okay. Engineering graduate.
Any other questions, madam? Is there? Madam, you want to say anything?
Regarding EMR, madam, you have explained very well.
Yeah.
And if you are following EMR, routine practice, and government and the ICMR, if these things are mandated, I think we can follow up the case without any repetition. Another thing, and the screening method should be universal and cost effective. Naturally, if the government and policymakers are involved, this EMR helps us a lot. For example, in the UK and other Commonwealth countries, they are following EHS, those NHS. So NHS is having some digital platform. On that they will work. But we have developed technically and everything, but system is not regulated according to the requirement. That is the lacuna in Indian system.
Yeah. The problem is we do not have the uniform EMRs available. So, different states, within the city as well, we have different platforms for EMR, and so we are not really, in that sense, we are not united. Although it gives you, for your clinic and for your staff,
personalized.
Yes, it's personalized.
And recently, RSSDA, they have initiated this, and they wanted to inform the EMR sheets among our population, at least in the physicians.
Actually, to add up to this, sir, actually the government of India is coming out with a unique health number for each and every citizen.
Yeah.
If that's going to be attached to each and everything, no, it's going to be a very, whatever you said, the concern will be really addressed.
Yeah.
Thank you, sir.
Sir, problems are there all systems. Okay, so we have to we have to regulate it.
So thank you very much.
Thanks a lot for all the speakers. Wonderful. Time is well maintained. So thank you, sir.
Early gestational diabetes. Gestational diabetes is why we are defined as 4th month or 5th month, because placental maturation will be there, and this pregnancy diabetes is related to placental resistance. Okay, pre-GDM is equal to early GDM, what I mean to say. Some, because of stress and other things, it is precipitated in the early diabetic stage. So I think I want a clarification regarding this.
To answer your question, sir, previously what we have been doing, when diabetes is being diagnosed or early diabetes is being diagnosed at the time of first trimester, we used to call either IGT during IGT complicating pregnancy or diabetes complicating pregnancy. That's what we've been terming. Now that the terminology, as rightly said, we have to come out with the studies. All the studies should point out whether the intervention at that point of time is going to really improve the outcome. Once we prove it, probably we'll have an answer for that. Thanks to everybody for maintaining time. Thanks a lot, sir. Thanks a lot. Thanks, Dr. Vijayakumar, sir. Vijayakumar, sir.
Thank you, chairpersons. Now we move over to the next symposium, which is on insulin. I now invite Dr. Krishna Prashanti and Dr. N. Kannan as chairpersons and take over the session.
Dear friends, now we are moving to one of the important session which is relevant to our clinical practice, that is on insulin. So we have been using insulin for all type of diabetes from type 1, type 2 and GDM. So which insulin we have to initiate to which patient to avoid hypoglycemia, glycemic variability. To enlighten more on this topic, now we have an eminent speaker, my close friend also, Dr. Karthik Balachandran. Over to you, Karthik. Welcome, Karthik. Best wishes for you.
Good morning, everyone. After that swashbuckling talk by my senior Dr. Suresh, we will be having a rather common topic, which is novel insulins in the management of type 2 diabetes. How they have evolved over time will be the focus of my talk. This is my disclosure slide. And this will be the agenda of today's talk. This is how the talk is likely to flow. The genesis or how it all started, evolution of basal insulins, evolution of bolus insulins, and evolution of premix insulins and co-formulations. This is like a cradle to grave, A to Z, everything talk about insulin evolution. So we'll start from the beginning, the genesis of insulin. There are many ways to talk about insulin evolution and how these four extraordinary men discovered insulin. But I will start with something that inspires me, and I hope which will inspire you. And they say love makes the world go round, and so we'll start with Frederick Banting's love story. Banting was working in France in the World War I, and he was in love with a woman named Edith Roach. So after the war was over, he came back to Canada, and he set up a private practice, only to find that he couldn't get any patients. He worked for weeks, nobody turned up, and his wife, who was a primary school teacher, earned 4 times as much as he did. He was completely frustrated, so he went to MacLeod and asked him for 3 things. Give me some dogs, give me an assistant, and give me a salary. MacLeod said, no salary, but you can have your dogs and your assistant. And because at that time, no self-respecting Canadian man would live off his wife, Banting was in a fix. And eventually the girl refused to marry him, and he broke up with her. So there are 2 kinds of men. When love failure happens, one is the Devdas type. The other, for the purpose of this presentation, is the Banting type. The Devdas type seeks salvation in some liquid, usually a bottle of whiskey or some other liquor. They hang out with dogs. They are basically losers. Banting did not seek salvation in a liquid. In fact, he gave salvation through a liquid to a whole of humanity. He also hung out with dogs, but not as a loser just sleeping with the dog, but he basically killed those dogs, extracted the pancreas, not for fun, but he killed so that he took lives so that he could give life to whole of humanity. So before we proceed further, if there is a love failure, it's better to be a Banting than a Devdas. And that's how the story of insulin started. And then basal insulins were required. Back in 1920s, the insulin was short acting, and people had to take multiple shots per day. Obviously, it's painful to take too many injections per day. So they wanted something that works for a little bit longer time. And that is the reason for development of basal insulin. And at this point, a man named Hans Christian Hagedorn came in. So this was a Danish researcher. He was inspired by some researcher from his own country who 50 years back discovered that salmon sperm had something called protamine. Now, imagine you are a researcher in 1920s and your task is to prolong the action of insulin. Why would anybody just go and mix it with salmon sperm, or just squeeze the fish and bring out some sperm and mix it with insulin? It makes it sounds yuck and it's kind of counterintuitive. The reason is that the sperm contains a very important thing, which is the DNA in a close packed form, and the sole reason for the sperm to exist is to transfer genetic information from one generation to the other, and it cannot happen if there are mistakes in the process. So Hagedorn realized that there must be something in the sperm that keeps the DNA, which is a negatively charged molecule, closely bound together, that is stable. And he discovered that that is protamine. And that protamine is rich in arginine. And you can remember this point, it will come important later on in the talk. And because of the protamine, which is a positive molecule, it binds the DNA together. Positive and negative form a complex which is stable and short, and that is how the information is transferred from one generation to the other. So he thought maybe just maybe we could use protamine to even stabilize insulin, make a complex and make it act for a longer time. Before this, he tried urea, he tried salt, he tried bile salts, all sorts of things. They all failed. Luckily, the salmon sperm came to rescue, and then he added that, and that is how the NPH insulin was born. So this provided a significant improvement in the quality of life, at least 100 years back, because it lasted longer. Since then, several ways of prolonging the action of insulin have been discovered. One is adding basic protein, which is protamine. Next is reducing the solubility at the physiological pH, which is how glargine works. And subsequently, the newer insulins have much more sophisticated processes, acylation, adding immunoglobulin fragments, and other fusion technologies. So what started off with the sperm of a small fish has come to highly sophisticated forms to prolong the duration of action of insulin. And as NPH insulin became available, initially it was animal sourced and eventually it moved on to human regular insulin. And we have been able to prolong the action of insulin for a significant duration of time. But the problem is that with the NPH insulin, like any version 1 of a product will never be as good as the version 5 of the product. Same way, version 1 was of course a breakthrough, NPH insulin, but it was also having some problems. Insufficient basal coverage, couldn't act for 24 hours, need for multiple injections, need for resuspension, and significant day-to-day variability. And just like any other science which moves forward in a quest for excellence to improve things that already exist, insulin research also proceeded in the same format. And then came the analog insulins, which is the U100 glargine, which was a significant jump in quality over NPH insulin, in the sense that there was it was the first insulin that could last for a very long time. Subcutaneous injection of an acidic solution, which precipitates at the physiological pH of 7.4, and after the precipitate is formed, there is a slow dissolution of glargine. This is something we all know, and this is how the protraction of action of insulin happened. And then came detimir, which has a different kind of way to prolong its action, which is albumin binding and self-association. So it binds to itself and to albumin and slowly gets released over a period of time. The whole idea of all of these insulins is to make the insulin last longer and flatter. These are the only two goals of making a basal insulin: make it longer, make it flatter. And by flatter, we mean very less variability. It should be as flat as possible. There should not be spikes and troughs and so on and so forth. So higher day-to-day glucose variability with the NPH was there compared to first generation basal insulins, and subsequent generations of basal insulins have become flatter and flatter and flatter, so that they have reduced the variability significantly. The first generation analogs were not truly once daily, higher variability was there, fixed time dosing, it's not truly peakless, and higher nocturnal hypoglycemia. So there were some difficulties with the first generation basal analogs, even though they were one step ahead of the previous generation ones. And then came insulin degludec, which again, as we have discussed, uses a different kind of method to prolong its action. Injected in a dihexamer formation, rapid phenol depletion after the injection. Phenol depletion after injection results in a multi-hexamer formation, and zinc diffuses slowly. There is no need to know the technical details of how this works, but suffice it to know this is the longest acting basal insulin that we currently have. Not only is it long acting, it is also the flattest insulin that we have, but that does not mean it's a slouch. It starts acting pretty quickly. So it's nearly ticks all the boxes that we want to tick. Its close cousin is the U300 glargine, which is a 3-fold concentrated version of insulin glargine. So the injection volume is reduced, and because of its similar small surface area, its action is prolonged. So that's how U300 glargine works. Now that we have understood how insulins progressed from just adding a fish sperm to highly sophisticated molecules in the form of degludec and U300 glargine, we can see how degludec is safe and effective in patients with diabetes. We have two large rows here. On the bottom we have the teal colored ones, which is the real world evidence, and the top we have the navy blue colored ones, which is the RCTs. RCTs answer a question, does this molecule work? We are not, of course insulin will work. The real world evidence answers the question, does it work in real world situations? So RCTs are closely controlled situations, that's the randomized control trials. We can see that there is, whichever axis we look at, whether it's HbA1c, fasting plasma glucose, dose of insulin, or more importantly the last column that we see, hypoglycemia, there's a significant benefit with this insulin compared to the previous generation ones, which is proven both in randomized control trials, in controlled situations in highly sophisticated hospitals, but also in real world studies in day-to-day clinics and small places and so on. So now that we have seen how basal insulins evolved to make longer and longer and longer acting insulins and flatter and flatter and flatter insulins, we'll now move on to bolus insulins, which are the quick acting ones. So why do we need quick acting insulins in the first place? Because this is how the insulin is released when we have meals. There's a quick first phase insulin reaction, there's a spike of insulin which gradually dips down over a period of time. Any meal we eat is going to trigger this insulin release, and in a patient with diabetes this is not happening properly. So that's the problem, and we need to fix that with an insulin that does what Indian Army did with something like a surgical strike. Get in, do the job and get out as fast as possible. That's what we expect from a basal insulin. So just like we had a different kind of problem, start with an insulin, prolong its duration of action as much as possible with the previous segment of the presentation. Here we have the exact opposite problem. Start with an insulin, make it faster and faster and faster so that it acts very quickly and gets out of the system very quickly. So this is how it is done. Approach endogenous insulin secretion by healthy pancreatic cells. So we had different kinds of methods to do this. We will see some of those. Most of these involve chemical changes to the insulin so that they act fast. So in insulin aspart, B28 proline is substituted with aspartic acid. That's why it's called aspart, reducing the strength of the insulin dimer. So it can dissociate fast and can have a faster onset of action. And because of this greater early insulin exposure, this insulin acts quicker than regular insulin, the one that we start with, and it has an advantage over regular insulin in the sense that it starts acting pretty quickly. So there are pharmacological improvements with, why do we want things to act fast? Because we want improved postprandial control. It can be dosed as close to the meal as possible. That's our goal actually. We don't want a patient to inject an insulin, wait for half an hour, twiddling his thumbs and looking at whether they will bring the lunch or so on. So we want the insulin to be as close to the meal as possible, and that's the reason why fast-acting insulins are there. And low number of nocturnal hypoglycemic events. And this is achieved by having an insulin that goes in and gets out as fast as possible. And just like we had different ways of prolonging the action of insulin, there are different ways of making the insulin faster. And one such thing could be administration tweaks, formulation tweaks, or injection site tweaks. Administration tweaks are basically, it could be a device dependent thing like a sprinkler needle, or the site of administration itself could be something like a pulmonary, the so-called aphresa. We don't have it here in India at the moment. So these are situations where you can tweak the way insulin is administered and cause fast-acting insulin. Formulations include additives, adding some additives. Injection sites include application of heat and hyaluronidase. These are not commonly used. So this ultra-fast-acting insulin uses something called faster aspartate, that is the FIASP, and it uses L-arginine. If you remember, the fish sperm also contained arginine, which was a stabilizer, and this is the amino acid that separates 100 years of insulin history. What started off with an NPH insulin and what ends with FIASP is basically arginine. So its mechanism of action is similar, faster release of the hexamers so that it acts faster. Compared to insulin aspart, we know it is faster. And how do we know it? By these studies, which is 74% greater action of insulin within the first 30 minutes, 147% greater action within the first 30 minutes. So comparing the prandial insulins, this is as it basically fulfills a requirement. It is ultra fast acting. It can be given as close to the meal time as possible. And it is delivered with the device which has flex touch, which is easier to administer. So we move on to the next part of the presentation, which is the evolution of premix insulins. We have seen how insulin is made flatter and longer, and then how it is made faster and faster and faster. Now we have, how can we combine these two things to get the best of both worlds? So premixed insulins have evolved over time to provide what is called total control. With basal insulins, we target the pre-meal. With prandial insulins, we target the post-meal. Why can't we have both in one insulin with one pen? And that is how co-formulation insulins are. Co-formulation insulins and premixed insulins are superficially similar in the sense that two different kinds of insulins are put in the same pen. But they are also different in the sense that, if we have to give an analogy of human relationships, premixed insulins are like marriage. Two entities joined together, and they lose their individuality to form a completely different whole. Whereas co-formulation insulins are a little bit like living together, more flexible. Each person retains his own individuality, his or her own individuality, and that's how co-formulation insulins work. They retain their own pharmacokinetic and pharmacodynamic properties, and they can dissociate anytime they want. So this is the world's only co-formulation insulin, ideg-aspart, with the 30% fast-acting and a 70% long-acting component. The advantage of such a thing is that there's a very long-acting basal component, which is the degludec, which acts guaranteed to act 24 hours, and a quick-acting aspart component, which is, as we saw in the previous section of the presentation, which acts fast. So we have a 2-in-1 insulin that does the job. And how do we know it does the job? By seeing superior HbA1c reduction and better PPG control. So if we want to target PPG and fasting with one insulin, this would be the insulin that we might go for. Not only that, because of its components, there is a strong reduction in hypoglycemia episodes with this co-formulation insulin as well. So treatment with ideg-aspart resulted in lower number of non-severe and severe hypoglycemic episodes. And compared to basal bolus therapy, which is basically like the gold standard against which everything else is compared, basal bolus therapy is good, but in the same instance that it is also much more complex. So if you want nearly the same amount of control with far less complexity, twice daily ida-gaspart would be a good choice to go. Of course, when you compare Photoshop with Microsoft Paint, obviously Photoshop has lots of features, but it's also much more complex to use. You want something that does basic things but does well, then yeah, probably Microsoft Paint is as good. In the same way, ida-gaspart is basal bolus light with one pen. That's all it is. And because of its reduced complexity and improved convenience, there is an impact on quality of life. And let's be honest, we all want things to be simple. We prefer simple to complex and complex to complicated. And that's what ida-gaspart delivers. There is also a reduction in pill burden, which is kind of like, we already expect that with any insulin. After all, if you give insulin and a pill, it will go into reduction. There will be a reduction in pill burden. There is also a cost effectiveness of ida-gaspart. We wouldn't be dwelling too much on this because in a country with a significant out-of-pocket expenditure for healthcare, this all depends on the individual patient's perspective. We don't have a single-payer healthcare system like the NHS or HMOs like the US. Ida-gaspart is a prudent choice for Indian scenario because of lower risk of hypoglycemia, mealtime flexibility, simple regimen, convenience of device, better quality of life, and cost effectiveness. It is also having effective glycemic control. So if it gets most of the things right. So with that, and almost 30 seconds to spare, we end the presentation. Thank you so much for patient listening.
Thank you, Doctor, for your wonderful presentation and wonderful similes of comparison of insulins living together with marriage. And it's a really, I think, how you got that idea of thinking that point with this kind of insulins. Really, it's wonderful. Now the house is open.
Not from personal experience, madam.
Now the house is open for questions. Please circulate the mic.
Only
Thank
thing
you,
is that this is only a basic questions. When you have hyperinsulinemia in type 2 diabetes, what is the concept of giving again insulin?
Yes.
No, I think second. Second, is there any effect of insulin on glucagon release? Because the glucagon is the one is a gluconeogenic. So if you give insulin, will it affect the glucagon release, or thereby it will helps in controlling diabetes? That's the question.
Thank you, sir. First, thank you for the compliment. Second, two very important questions. If there is already a hyperinsulinemia, why do we give insulin in type 2 diabetes? Well, when we mention type 2 diabetes and hyperinsulinemia, what we fail to mention is the second part of the equation, which is the insulin is high, but not high enough to control blood glucose. If it is high enough to control blood glucose, we wouldn't need an extra insulin. That is the problem. There is a significant insulin resistance. Even at the expense of higher than normal circulating levels of insulin, the blood glucose still continues to be high. That is one reason. Second is, as time progresses, there is a progressive beta cell dysfunction, and many patients with type 2 diabetes eventually behave somewhat like insulin deficient diabetes or type 1 diabetes. In the end of the time, they are almost indistinguishable from type 2 diabetes. That's second reason why we would choose insulin in these patients. The second question that sir asked is, how does insulin therapy affect glucagon levels? Insulin therapy may not have direct effects on glucagon levels, but when the blood glucose levels are well controlled, it also has a preferential effect on control of hyperglycemia through, it's not specifically a glucogonostatic effect. It can potentially have, but not, that is not the primary reason why we give insulin.
Just to add about the second question, actually it is intra-islet insulin, intracrine action. Insulin which is secreted in the pancreatic islet cell, that gives signal to alpha cells, and that's how the glucagon secretion is regulated. What we are giving is exogenous insulin. It is not going through the same portal circulation and through same pathway. So it will not have any effect on glucagon. It is only going to give you support plus some rest to already ailing beta cell. Apart from that, exogenous insulin is not going to have any effect on glucagon.
So for the same reason, no insulin therapy, whether we give injectables or even through pumps, will be completely physiological because it won't get into the portal circulation. like what the pancreas does, but yeah, it does its good enough job, and that's not the reason. Controlling glucagon is not the primary reason why we give insulin. Yes.
Actually, sir, this insulin, it's supposed to enter the beta cell. It produces energy by utilizing glucose. The glucose is necessary for the insulin synthesis. So you give insulin to synthesize insulin. No, that's a physiology. That's a physiology. I'm talking only physiology. So you give insulin, enters into the beta cell, and
It comes from the
beta cell. Yeah. No. When you give exogenous insulin, when you give exogenous insulin, because it's insulin resistance. No, insulin resistance everywhere.
See, the professor of medicine will half cooked. See, what the early basal insulin, if you give early in sulfonylurea failure, that is glucotoxicity. Okay, at that time it puts in theory. I don't know about in practice. Okay, in theory that gives rest to the beta cell. So there may be more insulin output initially, but as he rightly said, it is not insulin. Insulin resistance is early phenomena in pathophysiology. Ultimately, they become deficient. So your question, that is why you should come and work in endocrinology for some time, then you will become wise man. Okay, question to the beta cell, basal insulin. It is an evergreening patent. As you rightly know, you are from a Jipmer. This was patented for ₹1. These companies are greedy. Okay, even see this glargine, you don't need any other insulin. With glargine alone, I don't know how often you use glargine. Is like our paracetamol or PPI inhibitors. And our potency is such that we are not unable to regulate them, and they regulate us. That is why in every conference we have at least 20-25% is spent for this expensive insulin. But for beginners, wait. Let the patent come. Let the price come down. With glargine is more than enough for Indian population. At least for type 1, that your degludec may be cost of degludec, you will go back.
Karthi, in chronic decompensated liver disease with elevated liver enzymes and hypoalbuminuria, there are some certain properties regarding the albumin and also the basal insulin pharmacokinetics and properties. So what is the take-home message on comparing with the glargine and degludec?
There are some efforts to do. I would basically describe it as hair splitting. There is hardly any difference between the second generation basal. Both second generation basal insulins are closer to each other than they are apart. I do not personally believe that the hypoalbuminemia should be a decisive factor in choosing one insulin over the other. Both insulins are good enough for practical purposes.
Thank you.
As to the provocative question as to evergreening of patent, that is an interesting question, but we should also realize that in order to even do some good, we have to do some things that may not sound good. So that is one of the reasons.
Need versus need. I'm not saying that they invest a huge amount, but more than that they invest for marketing. There lies the problem.
Yeah, we would probably have a in-depth discussion on after the thing. Yes.
So thank you very much for the wonderful discussion and questions. Everything, science is in the process of evolution. We have to accept the new.
1 minute to clarify that question as to whether giving insulin whether insulin begets insulin question. That is not necessarily true, sir. In the early stages, you are probably mentioning glucotoxicity when glucose is suppressing the insulin release, so that we give glucose reduction, and that leads to an improvement in insulin production.
What I read in this latest textbook of the diabetology, when glucose enters the pancreas, it releases the insulin release. It's an insulin secretagogue. When glucose enters the beta cell, it releases the insulin. When glucose is increased in the beta cell, it causes glucotoxicity. That is glucose toxicity because persistent increase. So it does not produce insulin. But continuously we increase, it damages the beta cell, beta apoptosis. So what happens, the insulin is the one which stimulates the glucagon synthesis, glucagon release. But glucagon is the one which inhibits the insulin release. So bilaterally is acting. So in type 2 diabetes, there is a hyperglucagonemia. So if you give insulin, it suppresses the glucagon release. That's what I meant to mean.
Parandaman, how often you do journal club? ஒரு நாள் ஜேர்னல் கிளப் போயிங்க, ஸ்டாண்ட் மீட்டிங் வராமல் ஜேர்னல் கிளப் போயிங்க. எல்லன்பர்க்னு ஒரு புக்கு சரியா? மோசஸ் வாங்கி எல்லன்பர்க் புக்கை படிச்சா இதெல்லாம் வந்து
will read, sir. Will read, sir.
அதுக்கு தான் ஜெனரல் மெடிசினுக்கும் எண்டோக்ரைனாலஜிக்கும்.
Yes, there is a difference. Yes. Agreed, sir.
So that's that would require a very long explanation, and to unpack that thing, it will take longer time than what I think Dr. Kannan sir and Madam will allow. So we'll take it up later. Yeah.
In the view of time constraints, we'll conclude this session, sir. Thank you very much for being with us.
Thank you.
Thank you, chairpersons and speaker Dr. Karthik Balchandar. Now we have been well ahead of time. We will break for lunch and will reassemble again at 2 o'clock for the post-list session. Thank you.
Good afternoon, friends. Welcome to the interesting post-lunch session. Now we have the interesting topics on understanding therapies in the management of diabetes. For this, we have the eminent chairpersons, our past president RSSA, Dr. Vijayakumar sir, and our organizing chairman, Dr. GVK sir. Welcome, sir.
Good afternoon, friends. I hope you are okay after lunch. I am sure you will be having some slumber after lunch. So you are welcome, but you will be under the lights, you know. So one instruction is that you should not snore while you are sleeping. Number one. Number two, you know why you are not supposed to snore? You know why? No. So that you will not disturb the next person who is trying to sleep. And that's the reason. Anyway, Dr. Vasant Kumar will be joining. He just came from Hyderabad. He's already arrived and he's going to join us. Meanwhile, we'll start the session. He'll be joining in any time with us. I hope you're all enjoying the program from morning. Today we have, as Dr. Kannan was telling, we have two interesting sessions actually. One is that is the understanding therapies. One is that is the beyond the frontiers of glucocentric approach with a newer molecule recently introduced about a year ago, that is oral semaglutide, that is GLP-1 receptor analog, which is introduced just a month ago. All of us know that all these years we had GLP-1 analog as an injectable form, either daily or once in a week. Now there is an innovation. It is actually innovative therapy which has come as an oral tablet, and that's very important that we need to think. That is one thing. And then we also having, that will be delivered by Dr. Usha Ayagari, and we'll put her introduction slide. And after that we'll have one more eminent speaker, Dr. Sivakadaksha, my favorite speaker. He is going to speak on cardiologist speaking in a diabetology meeting. His perspective about diabetic heart disease, especially cardiac failure, how is it we can manage. This is Dr. Usha Ayagari. I don't think she needs any introduction without any time. She is in the sense that she is always with us in all our academic endeavors, both in journal club, what we have every month, and also we are all together actually. She is part of our team member in this organizing as well. Dr. Usha.
We will be forced to do a stop bank score on you and then start treating your sleep apnea if you snore. So there we go. So first thing, I'm speaking on behalf of Novo, and I have no other conflicts of interest to declare, and I have no conflicts of interest as to the scientific content of this talk either. So do we have a laser pointer? Excellent. Okay. So I'm going to break down my talk into a few sections, talk about why we need to think about weight management in diabetes, then talk about the pioneers studies with semaglutide, talk about the benefits with semaglutide in terms of glycemic and extra glycemic benefits, and then sum it up. So our approach to diabetes, and we do it well, has always been to manage the glucose. But if you look at the natural spectrum of, forget diabetes, the cardiometabolic disease that we are now facing, the problem starts much further upstream, where we have obesity multifactorial, obviously, environment, genetics, diet, lifestyle, everything else. But if we manage this obesity, we are managing the root cause of the problem. If we leave it further downstream, we then start seeing the downstream cascade of hypertension, diabetes, coronary artery disease, and everything else. As I said, the sleep apnea. So snore away and we'll evaluate the liver-related NAFLD and NASH, arthritis, dyslipidemia, the cancers, infertility, PCOS, all the downstream effects of PCOS depending on, obesity, depending on your weight and stage of life. The glucocentric approach has worked well for us, but we know that with the glucocentric approach, we haven't really made any major changes, for example, to cardiovascular outcomes. Whereas treating upstream and having a weight-centric approach, if it's early diabetes, will help us modulate the course of the disease. And if it is not yet diabetes, being aggressive with weight management may actually allow us to modulate the whole spectrum of cardiometabolic disease for any given individual. So more and more we should be thinking of the wasted opportunity of trying to manage upstream and address the problem there. So if you look at managing the weight, number one, as I said, you can actually disrupt the underlying pathophysiology, and if it is early in the disease, you may be able to reverse or slow down the progression of the disease. The second thing is, even by the time we have dysglycemia, whether it's diabetes or just at the state of, let's say, pre-diabetes, you can certainly improve the markers of blood glucose, and you'll be able to modulate the cardiometabolic risk factors, the dyslipidemia, the hypertension, and the other factors. What this means is that downstream, you will be able to improve or prevent the micro and macrovascular complications of this pathway. So if we treat weight, at least at the stage of diabetes, if not earlier, we know that we can make a huge difference to the outcomes for any given individual. Once we get to the stage of diabetes, we have multiple drugs that we use for glycemia, but not all of them are equal when it comes to the extra glycemic risks and benefits. So if you look at efficacy, you know that insulin is perhaps the most efficacious. Insulin is perhaps the most efficacious, for your money, it gives you the best A1C reduction, followed by sulfonylureas. But if you look at the hypoglycemia risk, exactly because these are very effective molecules, you have a high risk of hypoglycemia with both sulfonylureas and insulin. And when it comes to weight, we know that although they're effective, insulin and sulfonylureas are both quite bad in terms of being offenders for weight gain. CV benefit, it's only in the last decade or so that we're actually looking at CV outcome trials and looking at the CV benefit of the molecules that we're using, and we certainly have the wealth of evidence exists for SGLT2 inhibitors and now GLP-1 receptor agonists. But if you put this all together, if you're looking for molecules that are fairly effective, intermediate to high efficacy, with a low risk of hypoglycemia, with a low risk of weight gain, or better still, benefit, you want to see weight loss and good CV outcomes, then you're effectively looking at your SGLT2 inhibitors and your GLP-1 receptor agonists. But more importantly, with your GLP-1 receptor agonists, because you get good weight loss. In fact, with the newer agents, may be equivalent to bariatric surgery, with a low risk of hypoglycemia and established CV outcomes. So in one molecule, in one group of molecules, you have good efficacy, low risk of hypoglycemia, weight loss, and CV benefits. So why do we go on about weight loss? Because in people with diabetes, if you get them a minimum of 5%, but up to 15% weight loss, you can see a huge improvement in their quality of life, a good effect on disease modification. As I said, you can alter the path of these cardiometabolic disorders. You will see metabolic improvement, and you will see a reduction of their cardiometabolic risk. So as little as 5% will start you off, but obviously the more you get, the better. When you're looking at improvement in, say, NAFLD or sleep apnea, you do need at the higher end of this, you need the 10 to 15% or even more, but you will start seeing cardiometabolic benefits from about a 5% weight loss. So how do we how do the GLP-1 receptor agonists give you this benefit? Well, number one, we talk about the effect at the gut level. We know that it slows down gastric emptying, it improves satiety, but they also have a direct effect on the brain in terms of appetite regulation and weight loss. The GLP-1 receptor agonists, so they actually stimulate your pro-opiomelanocortin pathways and your CART pathways, and they decrease your hunger and energy intake, and they decrease cravings, and so they decrease your snacking and grazing between meals. On the other hand, they inhibit neuropeptide Y and AGRP, and what this does is it promotes satiety. So on the one hand, they decrease hunger and they decrease calorie intake. On the other hand, they improve satiety so that it prevents overeating. So from both points of view, they actually leave people feeling full, not craving, not snacking, and help weight loss. So if you look at weight loss therapies, you want sustainable weight loss with effective glycemic control, something that addresses the long-term glycemic risks with a minimal risk of hypoglycemia. And this is the space in which your GLP-1 receptor agonists perfectly come into play, that addresses the gap between these three requirements for weight loss. So if you look at clinical efficacy, they're highly effective in terms of A1C reduction. In fact, the higher you start, the better the A1C reduction. They're excellent in terms of body weight reduction. You see a minimum of 4 to 5 kilos, but with aggressive lifestyle management, you can see more than that. In fact, just yesterday I saw a couple, between them they've lost 15 kilos since January. The husband lost about 8 something and the wife lost about 7 kilos. So between them they've lost 15 kilos. This is the kind of effects that you can see. Although the clinical trials tell us 5, you push on the lifestyle, you can get more. They have a very low risk of hypoglycemia. The main risk of hypoglycemia comes from combining them with SUs or with the insulin. And they have established CV benefits, and I'll show you the data for that. The other benefit for these agents is once you up titrate to the correct dose, and I'll show you slides on how to start and maintain this particular molecule, the semaglutide. You don't need to dose adjust any further. There is an attenuation of side effects. So the nausea, the GI side effects that you see in people, with adequate counseling and with management of those symptoms, they actually attenuate, and they're quite well tolerated. So the titration is stepwise and easy. Once you get them to dose, there is no further titration or adjustment required, and they're quite well tolerated as long as you do the counseling and dose titration appropriately. So when you look at this kind of a molecule, you could say, why aren't more of us using it? In India, we don't have the data, but this is data from the US. And what you can see is that a majority of people with type 2 diabetes would qualify for using GLP-1 receptor agonists. However, less than 10% are actually using it. So there is a huge gap between who would be eligible and who's actually getting the molecule. Part of this can be cost, part of this can be our comfort level with prescribing and adjusting, and part of this can be multifactorial. But we should really be thinking of using these molecules early on and giving the patients the benefit of the long-term cardiometabolic risk modulation. So now coming to the evidence. Now, you know that, even with liraglutide, the lead program with Levemir, Novo has this very strong pathway of building up the evidence, and that's no different for semaglutide. Pioneer 1 tests semaglutide against a placebo, Pioneer 2 against SGLT2, Pioneer 3 against DPP4, Pioneer 4 against liraglutide. Pioneer 7 actually reflects what we do in real life. Not everybody is going to go 3, 7, 14. What happens if you have a flexible dose? What if they only get to 3 because of other reasons, nausea, GI side effects, or only get to 7 and they can't increase beyond that? Well, Pioneer 7 addresses that. Pioneer 8 is an add-on to insulin. Pioneer 6 is with renal impairment. Pioneer 5 with renal impairment, and Pioneer 6 looks at CV outcome trials. Now, both the Pioneer 8 and Pioneer 6 have a decent proportion of Indian patients in them. Pioneer 9 and 10 look at outcomes in Japanese patients, and the SOUL study, which is their CV outcome trial, is ongoing, and again it has just under 800 patients from India. So I'm going to show you benefits from A1C, weight, and blood pressure and other effects. So if you look at A1C, so I said monotherapy. Now you might say, will we really use it as monotherapy? In diabetes, we are probably going to use it along with metformin, let's be real, but it's good to have that data with monotherapy. You can see that semaglutide 14, which is the maintenance dose, gives you an A1C reduction of 1.5%. Versus empagliflozin, about a 0.5% extra, 1.3% in terms of absolute. You can see versus sitagliptin versus liraglutide, even when you compare it head to head with another GLP-1 receptor agonist, it still gives you a little further, another 0.3 extra reduction of A1C. For all of you taking photographs, please don't mind me saying this, but I'm happy to send the PDF out, and I'm sure that Novo will be happy to give a PDF for the slides. So please don't bother taking photographs. You can have the presentation. I'm happy to give it to you right here. Email me or take it from here, and then I'll give it to you, no worries. And with insulin, this is again a scenario. I quite often combine GLP-1 receptors with insulin, because not only does it mitigate the weight loss, it gives you another additional A1C benefit and additional weight loss. So both from an A1C point of view and from a weight point of view, combining it with insulin and having the evidence, as you can see over there, is quite useful. So that is the A1C reduction. Now, sorry, that's moving, not moving. No, it didn't move. My slides are stuck. Okay, now it's moving. Okay. So, in total, you see an average of 1.5. It's moving now. In total, you see an approximate 1.5% reduction in A1C. Now, looking at, remember where I said if the A1C is higher, it works better. So if you start with an A1C over 9, the proportion of patients who started with an A1C over 9 uniformly have an approximate 2 to 2.5% reduction. As monotherapy and elsewhere, 2 to 2.5 reduction, even when combined with insulin. So the higher you start, the better the bang for your buck with this particular molecule. So baseline about 2.5% if you use it as monotherapy, and otherwise about 2 to 2.2%. Now, weight reduction. So if you look at weight as monotherapy, you will see compared to placebo, there is a weight reduction of approximately 4 kilograms with semaglutide at the dose of 14 milligrams once daily. Versus empagliflozin versus liraglutide, because these are two agents which we know already give you weight benefits, 3 kilos, 3.5 kilos on their own. Even over and above that, you will see an extra reduction in weight when you use semaglutide. And this is what I was saying, when you combine with insulin, where the usual scenario is weight gain when you introduce insulin, if you introduce it along with a GLP-1 receptor agonist with semaglutide, you see approximately a 4 kilo weight loss. So on its own, on a background of diet and exercise, in combination with various OADs and on a background of insulin, you can see that semaglutide gives you consistent weight loss of approximately 5 kilos. But as I said, this is clinical trial experience. In real life, if you're aggressive with the weight management, you can do more than that. You can do approximately this in 3 months, and then you can keep going to do more. So a 1.5% reduction in A1C, approximately a 2 to 2.5% reduction in A1C if you start with an A1C above 9, and approximately a 5% reduction in weight. This is the efficacy as far as weight and A1C is concerned. Now looking at other things. We know that if you have a 5 to 15% weight loss, as I said, you will see an improvement in all of these. But how many patients actually get there? Well, 50% of patients get to a more than 5% weight loss, and about 20% of patients get a 10% or more weight loss. So while we know the metabolic benefits, it's important to know how many people get there. Well, 50% will get to a 5%, and about 20% will get to more than 10% weight loss. The more important thing is when you talk about weight loss, you want to see fat loss and not muscle loss. So with semaglutide, when you see a weight reduction, as you can see, what you see is fat loss, body fat mass, not lean mass. So comparatively, you preserve your muscle and you lose body fat. So that's the other advantage with semaglutide. Part of how that happens is that there is less, as we showed you, the appetite goes down, there are less food cravings, and there's a better control of their eating behavior. And there is a lower preference for energy dense fatty foods. In fact, if your patients get nausea, one of the ways of telling them is actually to try and avoid those fatty foods. The nausea improves. So these behavioral changes and dietary options, if you will, their choice of diet, actually helps them lose more fat and preserve the muscle mass. So again, looking at extraglycemic, we want to see that metabolic improvement, right? So let's show you. You will see that there is an improvement in blood pressure with systolic improving by about 10 to 12 and your diastolic coming down by 2 to 4 to 5. You also see an improvement in your triglycerides and an improvement in your HDL levels going up by approximately 4 to 6 and your LDL levels coming down equally. So there is an improvement in your lipid profile. And this then translates to an improvement in your CV risk over a period of 10 years. So, other metabolic factors, your HSCRP, which we know is a marker for cardiovascular disease, comes down. I've shown you the improvement in lipids and the improvement in systolic blood pressure, but your waist circumference as a marker for visceral adiposity comes down by about 5 centimeters. So 4.7 centimeter reduction in your waist circumference. So, consequence of all of these, there is an improvement in quality of life. For every 1 unit in BMI that they decrease, there is an improvement of approximately 0.02% in terms of your quality of life. Then coming for, remember where I said the earlier we start, the more benefit we are giving our patients? Well, if we start early, a higher percentage of patients achieve goal. So if you look at the composite outcome of the number of people that achieve an A1C under 6.5 plus the amount of people that lose more than 5% body weight, if the duration of diabetes is less than 1 year in the darker color versus more than 1 year, you'll see that at every dose, a higher percentage of people actually achieve goal if you start early. So start early and give them the benefit. This is Pioneer 1, which looked at semaglutide at the diagnosis as monotherapy. So give them the benefit of improving all these cardiometabolic outcomes. And 8 out of 10 people achieve goal overall. You can see less than 7% of A1C, 80% of people, and weight loss more than 55%, still about 50%, 44% of people achieve this. So the earlier you start, the better your results. More patients achieve an A1C of 6.5, under 7, 80%, and weight loss more than 5, at least about 50%. And then we know that early treatment, the legacy effect if you will, actually improves your outcomes longer term. Good glycemic control reduces, we were talking about this just a few minutes ago in at lunch, how we don't talk enough about the benefits of reducing your healthcare costs. So early glycemic control, reduction of your diabetes related and cardiovascular related complications longer term actually improves your healthcare costs and reduces your healthcare burden. So over the course of your Pioneer trials, what we've seen is that there's a large database of patients, nearly 6,000 patients, 5,700 patients who've used semaglutide. So there is proven safety. The most common side effects are gastrointestinal, but these are mild to moderate, and with adequate counseling and changes in diet, they're easily tolerated. Well, not easily, but they are tolerated, and you can counsel your patients through them and manage them symptomatically. As with other GLP-1 receptor agonists, this molecule is associated with a very low risk of hypoglycemia. And with semaglutide in the oral format, there have been no new surprises compared to the other GLP-1 receptors in terms of safety signals, and it's equally well tolerated. So good tranche of safety and tolerability data with proven combinations across the Pioneer trials, with proven efficacy against various other OADs and in combination with insulin. You can use it safely in the elderly, in patients with hepatic and renal impairment, and in patients with upper GI tract disease. So there's no dose adjustment required across any of these spectra of diseases. Now comes the practical bits. This is very, very, very important. How do we tell patients to take, I still have 9 minutes. How do we take patients to take semaglutide? They must take it in the morning with no more than 120 ml of water. This is important. So you must tell them 1 to 2 sips of water at the most, and after that they need to stop eating or drinking anything. Tea, coffee, water, everything for exactly 30 minutes minimum. So take it with 1 to 2 sips of water, and then don't eat or drink anything including water for at least 30 minutes, and then eat normally. We say eat normally, we mean eat healthy, but you will find that patients automatically, their pattern and their preferences for food changes with semaglutide. So 1.5% reduction in terms of A1C, 5 kilo weight loss, 5 mm of systolic blood pressure, improvement in your lipid parameters, and improvement in your waist circumference. This is what I've shown you so far. So to summarize, semaglutide is the first oral GLP-1 receptor agonist that we have. I've shown you data in terms of efficacy, glycemic efficacy, and weight across comparators, including head-to-head against SGLT2 inhibitors and liraglutide. It works better in terms of A1C and weight reduction. I've shown you the benefits of weight reduction, and I've shown you the sustained weight loss modulating cardiometabolic risk factors with this use. The extra glycemic benefits in terms of weight loss, in terms of adiposity, reduction in waist circumference, and improvement in the other cardiometabolic parameters. And finally, I've shown you the safety for using again in a spectrum of disorders in the elderly, across renal and hepatic impairment, and in people with upper GI tract problems. But most importantly, please remember how we dose this. Empty stomach, half an hour, nothing after that, 1 to 2 sips of water. Thank you very much.
Thank you, Usha. It was wonderful. You know, this is one topic which has been dealt very often, being a very exciting molecule. I'm sure there would be a few questions which you are ready to take. Before my colleagues ask any question, I would actually like to you to elucidate on one point which has often been missed, is that what are the drugs that we combine with semaglutide, the other oral anti-diabetic drugs which are more often used? Because that's not really mentioned in most of these things. Yeah.
So you obviously don't use it together with other GLP-1 receptor agonists, injectables, and there is no point in using it with DPP-4 inhibitors because you're already delivering a supraphysiological dose of GLP-1 to the patient. But other than that, this can be combined with all other agents. When you're combining with insulin and sulfonylureas, please keep in mind the enhanced risk of hypoglycemia and proactively reduce and down titrate. But otherwise, you can combine this with any other class of drugs. The only thing to say is that the dosing, this is the first thing you take in the morning on an empty stomach. If I may just expand a little further on that, the other common question that comes up is what about other drugs that are taken on an empty stomach? So PPIs and thyroxine mainly. What has been shown in the clinical studies is that the absorption of semaglutide is not altered if you take it with thyroxine, but the dose requirement for thyroxine may be altered. Now, in theory, the correct way if you want to tell them is to take the semaglutide, wait for half an hour, take the thyroxine, wait for another half an hour, and then do what they're doing for the day. In practice, this isn't ever going to happen, or your patient's going to stop one or the other, or the gap isn't going to be enough, so something will go wrong somewhere. What I'm doing practically in clinical life, I will tell them with the same 1 sip of water, take both your thyroxine and your semaglutide. For all practical purposes, it doesn't affect the semaglutide. Yes, it may affect your dose of thyroxine, but we'll monitor and adjust it accordingly. So that's the lesser of the two problems. Adjusting the thyroxine dose is easier. It doesn't really affect the semaglutide absorption. So if you want to be pedantic, you can tell them, take, wait half an hour, take, wait half an hour, then get on with life. In reality, that half an hour may end up being curtailed, or in reality, they may end up skipping one or the other. So if you want to be practical, monitor the thyroxine, give them together and get on with life.
Thank you.
Yeah. Thank you. Yes, please.
As
long as you continue semaglutide, or initially it reduces and becomes static?
So, okay. With semaglutide, we have data out to 2 to 4 years, and it does, the magnitude of weight reduction is less, but it does continue to go down slowly. But practically, in obesity management, there is no drug that gives you indefinite weight loss. The best we can hope for is that after they lose the initial, that you at least maintain it and that you can get them to plateau. My main target when I use semaglutide is, one, to achieve the initial weight loss, and then it's a discussion with the patient as to how they manage to maintain that weight loss. If they can manage it without medication, I still use semaglutide because it has extra glycemic benefits, extra weight reduction. Other than weight reduction, it has other benefits. If the pocket can afford it and the patient is willing, then I would prefer to continue the semaglutide. However, reality is that for most of my patients, after they've used it about 6 months, they will inevitably ask for a break. And then you negotiate how you maintain that weight loss and continue to get that blood glucose and other blood pressure related benefits. But I think we should move away in these drugs as looking at them with a short, sharp weight loss target and start thinking in terms of them from a cardiometabolic perspective and start thinking of introducing them early to modulate it. But let's be practical. Pocket realities. You use them for as long as the patient is willing to take them, and then do your best to maintain the weight loss. That's the pocket economic reality of India.
Once you stop the medicine, there will be rebound phenomenon of weight gain, no?
Not a rebound phenomenon as long as you can maintain the lifestyle changes. But again, it is inevitable. Even with bariatric surgery, you see a tend to, even in successful bariatric surgery, even in successful weight loss interventions, so where people have lost an initial amount of weight, a 10 to 15% weight regain with some stabilization is inevitable. When you do weight management, this is the reality of life. You see a little bit of weight regain. If I can manage to help them keep off 80% of what they've lost initially, I think in the obesity game, that's a success. When you're doing weight management, if you can manage to keep off most of what you've lost long term, because if you look at even bariatric surgery, over the 10 years after bariatric surgery, there's slow weight regain. So there is no pain-free, long-term, failure-free solution to this, I'm afraid. It's an ongoing. See, this is why obesity is a chronic disease. Just like any other chronic disease, it needs lifelong management. You lose the weight, hopefully you can stabilize it. If you regain, you go back to it. You readdress the weight loss.
In that case, I think you need to think about this molecule more than weight reduction as an anti-diabetic drug and which cardiovascular benefit probably. Yeah. Because as I said, bariatric surgery also after some time they'll put on weight. So let us not look into as just weight reduction, probably temporary weight reduction, but good glycemic control with weight maintenance with cardiovascular benefit.
They're giving us good weight loss, and we know, I mean, look at the look ahead data, look at all the other data. We know that weight loss itself gives you long-term benefits. We do need to look at the weight loss, but we also need to look broader at the other benefits. Yes, sir.
Yes. See, huge discounts, you may not believe, 80% and 90% coupons are available in the North America. Have you ever used coupon in this country? What is, have you got any message from the, because it's prohibitively expensive. That is why, okay? So you don't have coupons in India, because the same Novo Nordisk subsidized insulin during the corona epidemic. In India, what we had is the seminars. People like you, anyway, eminent, good. So Novo Nordisk discriminates developing country, that is undoubtedly. Number two is that long-term safety and efficacy is not even rebound, is well documented. Maybe you are a honorary speaker for them, so you just, as an academician, I don't know. So long-term safety is not proven. So you wanted to use early. What do you mean by early?
Okay. So long-term safety and efficacy, the data is coming. After all, the molecule certainly in, even worldwide in its injectable form has been available for less than a decade. In its oral form has been available for even less time than that. We, you know, I might be standing here talking on behalf of Novo, but I'm not a Novo speaker.
You are an endocrine. Who are you first?
Usha Ayagari.
Ah, see, that is why our commitment is for the see. So Novo Nordisk will hire you and fire you. That don't worry. The other thing is that you said about end-stage renal disease in all, who is going to use in stage 4 or stage 5 your drug, and hepatic failure. This drug is notorious for gallstone and biliary disease. So again, many of these people are alcoholics. Hepatic failure.
See, if we are talking about gallstone disease, weight, okay, with obesity, if I remember correctly.
Data from them, ask them to put it in the domain.
Okay.
You are promoting a drug, he says that you can give it for hepatic failure. Where is the data? You are misleading us on behalf of them. So it is not ethical.
Dr. Karnani, thank you and I are old friends, so let us discuss this.
No, is not our friend, remember this.
Not them, you and I are old friends.
I don't know about that. I don't know.
No,
we never had interaction.
There are many participants here. Thank you, sir.
More information is not suppressed here.
Thank you. Dr. Shah, I think that should be fine. Thank you very much. Now it's the time for us to move on to the next important topic, which will be dealt by Dr. N. Sivakataksham, who is well known to the people of Tamil Nadu as well as Chennai. He is a very leading cardiologist. He is going to speak to us on this topic. As you know, this topic is always important for most of us who are practicing in diabetology, because we need to detect cardiac failure at an early stage so that they don't end up in more complications. Sir, it's yours.
Good afternoon, my dear friends and my teachers. And I think this one molecule, SGLT2 inhibitors, have made cardiologists and diabetologists come together. And diabetologists all over the world have controlled diabetes efficiently to prolong life. And when you prolong life, a lot of people think we die of cancer, but more than cancer is the deadly disease, cardiac failure, which is much more common in diabetic than in a non-diabetic elderly person. So we will have to now learn more and more things about how to reduce the incidence of cardiac failure, how to reduce the recurrence of hospitalization for cardiac failure, and especially so in diabetic. So today the topic is going to be only around that. Let me go with the first slide. Now all of us know it's a very serious life-threatening disorder. Most of the time it knocks the door in the middle of the night. Patient goes dyspneic, breathless, and questioning. They complain of fatigability. So the forward failure causes fatigability, and the backward failure causes dyspnea and pedal edema. And lot of times when we were students, we were told only about congestive cardiac failure because of congestion in the lungs. Now it has been redefined several times again and again, and mostly we talk only about chronic heart failure, acute heart failure. Acute heart failure may be precipitated time and again in a patient with chronic heart failure, and HFrEF and HFpEF and HF with mid-range ejection fraction. What are they? Any person, the common garden variety of congestive cardiac failure is a HFrEF, that is heart failure with reduced ejection fraction, and they have set up a line that is 40% ejection fraction, below that is HFrEF. And more than 50%, if the patient comes with features of cardiac failure, echocardiogram shows an ejection fraction of more than 50%, but the BNP or the NT-proBNP is very highly elevated. You call it as heart failure with preserved ejection fraction. There are people who come with reduced ejection fraction. They may improve, especially like peripartum cardiomyopathy. They may improve from 40%, below 40% to 45%. So anything between the 40 to 50% range of ejection fraction, and who is on treatment for cardiac failure, we call them as heart failure with improved ejection fraction or heart failure with mid-range ejection fraction. So these are the varieties of heart failure that we are coming across today. And 1 minute, let me see how to use it. Yeah. Damage to cardiac myocytes and extracellular matrix leads to changes in the size, shape and function of the heart. And what happens immediately is neurohormonal overactivation. The sympathetic system gets overactivated, the RAS system gets overactivated. And this leads to vasoconstriction, fibrosis, apoptosis, hypertrophy, cellular and molecular alterations and myotoxicity, leading on to maladaptation and remodeling, which causes the morbidity and mortality with arrhythmias and pump failure. And you get the symptoms of heart failure. Now, when a patient comes with heart failure, there are about this is the Western data, there are about 7 to 8% mortality in the hospital. And if they survive the hospital, they go out and they may get admitted. 25 to 44% of patients are readmitted to hospital within 30 days to 1 year. So today's problem is how to reduce the expense for the government and for the patient. In countries where the patient has to spend, you will have to reduce, because every time he goes into the ICU. Anywhere, whether it is a mediocre city or it's a hi-fi city, the one-day ICU charge is so high, it is better to prevent cardiac failure or to treat it better so that they do not come with hospitalization for heart failure again and again. And the patients who have survived the first incidence of cardiac failure, 7% of patients receiving guideline-mediated therapy died due to sudden cardiac death. And the mortality is about 50% in 5 years' time. So it's a deadly disease, much deadlier than cancer. And this is like frequent flyer. Many patients come out of hospital just to get readmitted. So we have to effectively prevent, for which we should understand the pathophysiology. Based on the pathophysiology, all these years we have been having treatment. As we have told in the previous slide, there is an overactivity of the sympathetic nervous system. When we were students, we were told if you write a beta blocker for a cardiac failure patients, we are failed. Today, if you do not write a beta blocker, again we are failed. The reason is very simple. The pathophysiology is very much understood. Because of the overactivity of the sympathetic nervous system, there is tachycardia, and when there is tachycardia, there is myocardial oxygen demand is increased, and there is further worsening of the failure. So to improve that, we had found out a beta blocker as a group of drugs which can reduce the overactive sympathetic nervous system. The RAS, renin-angiotensin-aldosterone system, gets overactivated and retains sodium and water, and therefore worsens cardiac failure. So we have started using from 1990s ACE inhibitors, and recently for the past 20 years ARBs. And an improvement over this is a combination of an ARB with what is called a positive system. These are almost negative system, even though they are compensatory systems. This is a positive system which produces against vasoconstriction. This produces vasodilatation, and therefore it improves the quality of life in a patient with cardiac failure. This also gets activated, but unfortunately this gets very frequently, at a very fast rate, it gets metabolized. The brain natriuretic peptide and the atrial natriuretic peptide, even though they are positive for the patients with cardiac failure, they get metabolized. And why not we inhibit the metabolization of the peptides? And therefore a drug was found called the naprolysin inhibitor, because naprolysin inhibits the naprolysin inhibitor inhibits naprolysin, so that more amount of natriuretic peptides are available in the circulation to improve the cardiac failure. So all these years, till at least 2013-14, we have been using beta blockers, RAS blockers, or ACE inhibitors or ARBs, and in 2010, after the Paradigm HM trial, we have started using ARNI, which is a combination of angiotensin receptor naprolysin inhibitor, and which had reduced the hospitalization for heart failure 17% more than using only an ARB. This is a borrowed slide from GVK, who in 2019 in the same 3D conference spoke, SGLT2 inhibitors, will it find its way in cardiovascular medicine? And he said, let us wait and watch. Now we have waited and watched, and over these 3 years, it has almost become the #1 agent for the treatment of cardiac failure in majority of patients that we see. Now how it has become? Because SGLT2 inhibitors are a unique class of therapies that show beneficial effects across the cardiovascular risk continuum in patients with type 2 diabetes. Starting here, it can reduce the systolic pressure and minimally diastolic pressure. There is body weight reduction, there is HbA1c reduction, there is progression of kidney disease is retarded, 3-point MACE is reduced, that is cardiovascular death, non-fatal MI and non-fatal stroke, and reduction in hospitalization. This is what has highlighted in majority of the trials. It has reduced anywhere from 30 to 35% reduction in hospitalization for heart failure and all-cause hospitalization, and there is cardiovascular death. Different studies have quoted cardiovascular death to be reduced from 2 to 18%, and totally definitely reduces. If a drug can produce all these things, why not we use it in the management of cardiac failure? SGLT2 inhibitors have been shown to improve cardiovascular risk, as we have already seen. There is weight loss, systolic and diastolic is slightly reduced. And in CVOTs, SGLT2 inhibitors have demonstrated multiple cardiovascular benefits. And what are the cardiovascular benefits? As I told you, in EMPERAG outcome, there is a 35% reduction in the heart failure hospitalization. In the CANVAS, again, there is a 33% reduction, and in declaratomy, there is a 27% reduction. Cardiovascular death, even though minimal in declaratomy, you can see this sizable reduction in cardiovascular death in the other programs, and 3-point MACE is definitely reduced in all the trials. And in EMPERAG outcome, the effect of empagliflozin on heart failure hospitalization was consistent in patients with and without heart failure. Suppose the patient has had a no heart failure, it is still useful from the median line. And if he has had a heart failure also, it is still useful. So even if the patient has been included with a high risk of diabetes, high risk diabetic patients, it definitely prevents the onset or delays the onset of cardiac failure. And whatever be the HbA1c, number one, within 12 weeks time, there is a reduction in HbA1c. And whatever be the level of HbA1c, there is a reduction in cardiac outcomes. Canagliflozin, again another glyphosine in the CREDENCE, has retarded the progression of the end-stage renal disease to the end stage by 30%, cardiovascular death or hospitalization for heart failure for 31%, 3-point MACE by 20%, and heart failure hospitalization by a phenomenal 39%. And when you look at the DAPA-HF trial, worsening of heart failure or death is reduced by 26%, heart failure cardiovascular death by 25%, and composite kidney outcome by another 29%, and all-cause mortality by 17%. So the adverse events were very similar between dapagliflozin and placebo. And in the DAPA-HF trial, the effect of dapagliflozin on cardiovascular and heart failure outcomes was generally consistent between patients with or without diabetes at baseline. So you can give it to patients without diabetes also, but if they have cardiac failure, that is why this molecule has become the drug of choice among cardiologists today. And suppose the patient has been having the other 4 pillars of treatment for cardiac failure. He is taking ARNI or ACE inhibitor or ARB, beta blocker, MRA, and still the patient can benefit in all the segments. So even if you are adding on this drug to persons who are taking all the other drugs, it is still a very useful addition. Several SGLT2 inhibitor mechanisms may have beneficial effects on heart failure. When the drug was introduced, people thought it is causing improvement because of its diuretic effect. Later they had proven that it is not due to a regular diuretic effect, but due to a selective diuretic effect. We will come to it now. It causes natriuresis. It increases natriuresis because of proximal convoluted tube inhibition of SGLT2, and reduced preload and afterload, reduction in interstitial edema, and improved kidney function and cardiorenal physiology. How does it do? It does it through an sodium-hydrogen exchanger dependent pathways. It inhibits the sodium-hydrogen exchanger pathway, and therefore the renal sodium mechanism and the microvascular and macrovascular complications are definitely reduced, and because of this, the progression to heart failure is also reduced. So one of the main mechanisms has been attributed to the sodium-hydrogen exchanger independent, which is sodium-hydrogen exchanger 1 in the heart and vasculature, and sodium-hydrogen exchanger 3 in the kidney. SGL2 mediated blockage of sodium-hydrogen exchanger, and reduction in intracellular sodium load, and restoration of mitochondrial function, and reduction in glomerular hyperfiltration and intraglomerular pressure. And as I told you, how does it differentially affect the volume overload? it reduces the SGLT2 inhibitors. If you look at this particular thing, they reduce the sodium, they reduce the interstitial volume, but the intravascular volume is maintained, which is responsible for having a patient with cardiac failure at least an acceptable BP. Whereas when you give a loop diuretics only on a chronic basis, the intravascular volume falls down. So what is important is relieve signs and symptoms of interstitial congestion, provide some relief of elevated cardiac filling pressure, prevents harmful effects of excessive blood volume depletion, including neurohormonal activation. Our patients will say, complain very often of severe postural hypotension. And this is how it affects cumulative urine output and fluid balance in patients with acute heart failure. You can see that there is a great reduction compared to the placebo in the volume. And what is unique about the diuretic effect? Selectively reduces the interstitial volume with minimal change in blood volume, no counter-regulatory stimulation. Suppose the blood volume is reduced, there will be counter-regulatory stimulation of tachycardia and RAS coming into play. No hypokalemia, improved renal function, reduction of uric acid levels, no hyperglycemic effect. So all these things are very, very important when you give a drug to cardiac failure patients. And we have already seen how it improves. Cardiac preload is reduced by natriuresis and increased diuresis, and LV diastolic function and the LV mass is reduced by, and therefore there is metabolic efficiency, oxygen supply is improved, fibrosis is lessened, epicardial fat is lessened. There are several papers which had shown the reduction in LV muscle mass, especially the epicardial fat, and therefore there is improvement in the cardiac function. And cardiac afterload is reduced because of endothelial function, arterial wall stiffness, and vascular resistance is improved. See, these two were the main principles that were used before we started getting ACE inhibitors and ARBs. We used to have cardiac preload reduction as a method of treatment of cardiac failure and cardiac afterload reduction. And that is how you had the combination of isosorbide dinitrate with hydralazine. So people who cannot afford very costly drugs, we used to give digoxin diuretics and then a combination of hydralazine with sodium isosorbide dinitrate. The reason is isosorbide dinitrate will reduce the preload by capillary dilatation, and afterload is reduced by hydralazine. Even today, many of us are using that in poor patients who can't afford. EMPA heart study showed a meaningful reduction in LV mass index, that is the muscle mass, from baseline with empagliflozin versus placebo, and this is one of the major mechanisms by which it causes an improvement in the cardiac status. This all of you should be familiar as diabetologists, and this is suppose a person's life is 72 years, it gets reduced when he gets diabetes by 6 years, and if he has had a coronary artery disease also in the form of an MI, it is reduced by another 12 years. And when we use drugs like this for cardiac failure, what we had found is reduction in relative risk mortality versus placebo. When we used ACE inhibitors like ramipril, the cardiac failure mortality is reduced by 16%. ARBs reduced the CHARM alternative trial by 23%. Beta blockers, the metoprolol, bisoprolol, and cardivolol reduced by a phenomenal 32 to 34%, and the mineralocorticoid receptor antagonists reduced by 30%. Now, if you come to the glyphosins, SGLT2 inhibitors, you get a 3-point reduction of 14%, cardiovascular death of reduction of 38%, hospitalization for heart failure by a phenomenal 35%. So why not we add on all these things and give a better lifestyle to the patients with cardiac failure and a prolongation of life. Now, number needed to treat, as long as the number needed to treat is less, that means the drug is very, very effective. When simvastatin is given for 5.4 years, you require 30 patients to reduce the number needed to treat is 30. And when it comes to ramipril for 5 years, the number needed to treat is 56 years. But when it comes to empagliflozin for 3 years itself, if you treat only 39 patients, you are able to reduce the mortality. So what is important is, in addition to the other drugs, you can use an SGLT2 inhibitors. So when we started treating recently from 2018, we started saying there are 5 pillars for the treatment of cardiac failure. ACE inhibitors or ARB. If the patient is ACE inhibitor ARB naive, we used to go to neprilysin inhibitor straight away, that is ARNI, and then beta blocker, MRA, and SGLT2 inhibitor. Time and again, people used to ask it in most of the meetings, sir, which one to start, which one to go, there are complications, patients come with hypotension, how do we go about? One of these things that we should understand is there are 5 pathways. As I had told you in the beginning itself, the sympathetic nervous system pathway, norepinephrine, the RAS pathway, angiotensin 2, the MRA, that is aldosterone, again RAS pathway, aldosterone, and neprilysin and SGLT2 inhibition. So 5 pathways, 4 drugs. We all know SGLT2, MRA, beta blockers, and ARNI. And 3 others are in patients in whom you have used all the 4 pillars of treatment of cardiac failure, we can still reduce the heart rate, because reduction of heart rate in a cardiac failure patient has been proved in SHIFT trial to improve their quality and quantity of life. So ivabradine, suppose we are able to use a maximum dose of beta blocker, still we are not able to control the heart rate, or we are not able to use the beta blocker because of low BP, we can straight away add or use ivabradine without any cardiac effect. It can reduce the heart rate and prolong the life of the patient. This I have already talked to you about afterload reduction and preload reduction, hydrolysin nitrate combination, and Versigouat is a recent drug which acts on the mitochondrial level to improve the contraction of the heart muscle, and we are getting it. It is like semaglutide in diabetology, Versigouat in cardiology, very costly, but when all the other 4 pillars fail, we can still start using that and try to give them some relief. Now, which one to start first? As I have told you, a lot of people ask us questions. Sir, a patient comes with hypotension. How can we use an ACE inhibitor or ARNI? After you stabilize the drug, you can start using it. So what happens is Milton Packer and McMurray, both of them said, why not we start with SGLT2 and beta blockers once the patient is unloaded. You cannot give the volume loaded patient beta blocker. Once the patient is unloaded in the ICU, you can start on beta blocker and SGLT2 inhibitor, because cardiac failure, you are going to give a lot of diuretics. You may have metabolic parameters getting altered like high potassium, low potassium. So safest is to start with these 2 and then slowly add on ARNI, and then if still it is not controlled, mineralocorticoid receptor antagonist. Only thing is, when you give these 2 drugs, you should be careful enough to monitor their potassium very frequently, as early as 2 weeks. You should do this. So simultaneous initiation of beta blocker and SGLT2, then addition of ARNI within 1 to 2 weeks of step 1, and addition of MRA within 1 to 2 weeks of step. You add this only if you do not find improvement with these 2 steps. And as I told you, McMurray and Milton Packer in circulation had talked about this step. And old sequencing was, we used to start with ARNI because that's what we had, and we had proven that it has reduced hospitalization for heart failure. And then we used to add beta blocker, then MRA, then ARNI. Now SGLT2. Now, having been treating patients over the years and having had a lot of biochemical imbalance and hypotension, one of the best methods that has been suggested by them in 2020 circulation is, why not we try like this, safer for the patient and for the cardiologist who treats. Now, estimated clinical benefit in heart failure with reduced ejection fraction is greatest for which combination? Is it for ACE inhibitor, beta blocker, or MRA, or for this? You can see very well in this one, ARNI, beta blocker, MRA, and SGLT2 gets the greatest benefit. That means hospitalization for heart failure is reduced to the maximum level. Thank you.
So I have a couple of questions regarding this HFpEF, preserved ejection fraction. How do you diagnose clinically? Is it always pro-BNP is necessary, anti-pro-BNP is necessary to diagnose? Third is it ARNI indicated in this stage?
So far, the only drug indicated in the management, he just wants it from my mouth, he is my teacher. So The only drug that is indicated in, so far, proven to be of use in heart failure with preserved ejection fraction, that's why I had never gone into that, is so far only SGLT2 inhibitors. Because of the so much of advantageous effects on the metabolism of cardiac muscle. And ARNI has not been found to be useful, though even though people have started using ARNI even in uncontrolled hypertension. I don't know how far it's going to be successful. So in heart failure with preserved ejection fraction, how do we diagnose it? As Hutchison used to say, what the mind does not know, the eye does not see. 3 years, 4 years back, we never had a condition called heart failure with preserved ejection fraction. Now we are seeing it because many patients come in the middle of the night with the same features of cardiac failure. You do an echocardiogram, their heart ejection fraction is more than 50%, and then we go and do a NT-proBNP, it's phenomenally high. Here is a patient with cardiac failure. And then we started seeing these are people who have got comorbid conditions like hypertension, diabetes, or some other condition, SLE type of condition. So people who have got symptoms, classical features of cardiac failure, severe breathlessness, in whom you find a very much elevated NT-proBNP, that is how we diagnose, because majority of ICUs in hospitals today have echocardiogram. When a patient comes, we put the echocardiogram and find the ejection fraction more than 50%, ask for NT-proBNP, and then segregate them, treat them only like cardiac failure, unload the patient, and then following up is treating the primary condition, hypertension and diabetes, and adding SGLT2 inhibitors. Yes, sir. You have answered also. The contraindications are in summer. The advantage of using this drug is we can reduce the dosage of diuretics. In established cardiac failure, during summer or when we introduce SGLT2, we find the improvement in the next review after a month or two, we reduce the dosage of diuretic in majority of patients. And if we are not able to reduce the dose of diuretics, we are failing there because we are going to lead him on to get complications. And if you ask me, can you just start on any patient who is a diabetic? I think ADA says yes. So we'll have to, as 3 years back, GVK has asked a question, will this become a drug of choice? I think it will. In my opinion, I consider SGLT2 like aspirin, digoxin, and warfarin. This drug will stand the test of times.
Sir, there is also saying that initially there is a lot of studies to say that in your practice, like to know your experience. Those people are already, as you said, that diuretics dose is coming down. Similarly, antihypertensive drugs, by using SGLT inhibitors, is there any reduction in antihypertensive drugs that they are already using?
I think it should happen theoretically, but we have not come across. But because immediately we will jump when the patient's BP drops, we will try to reduce the diuretics. But in hypertension with diabetes, I think if it comes down, it's a long stand, we will have to find out. In only hypertension and diabetic combination patients, which is the common garden variety of a patient that we all see, I think we should be able to observe and try to reduce the dosage of antihypertensive.
I think it is in the systolic hypertension.
Yeah.
Systolic hypertension will come down immediately.
Yeah.
As you said, diastolic it takes time.
Yes.
And the next thing is about glycation process. Oxidation will be altered by the SGLT2 inhibitors. Okay. That is the process mainly responsible for the improvement in GFR or kidney filtration.
In the cardiac
Kidney
metabolism
filtration.
also.
That is the molecular basis for this molecule. That is the success of SGLT inhibitor.
Thank you. And then we had an excellent discussion as well. Thank you, sir, for your excellent talk. And let us give a big hand for Dr. Usha Yagari and as well as Dr. Sivakadar.
Dear friends, now we have the very interesting and impactful session regarding our clinical practice, that is rapid fire sessions on diabetes. For this, we have a cluster of topics on the galaxy of speakers. It's a great pleasure to invite my mentors and my teachers, Professor Madhavan sir and Professor Anand Moses sir, along with my friends, Dr. Dhanamithran and Dr. Sai, to the dais.
Dr. Kapoor is here. Sir, you have your slides? So you, without, no slides. So we'll start the rapid fire symposium on diabetes, and that is about 10 minutes for each speaker. And the first speaker, I welcome Dr. Ghafoor, infectious disease specialist from Apollo Hospital. Thank you for coming, sir. In spite of Eid, you are here. Thank you. And he is going to talk ex tempo without slides.
As always.
Yeah. Huh? Yeah. His topic is antimicrobial resistance.
Good afternoon. Antimicrobial resistance, otherwise we call it as AMR, or the superbug crisis, is one of the biggest challenges in the world that faces today. In 2019, more than 1 million people died directly because of the superbug crisis, directly. And indirectly, more than 5 million people died due to the problem in just 1 year across the world. And we all believe it's because of irrational antibiotic usage. It's partly because of irrational antibiotic usage, because we use antibiotics. When we use antibiotics, the bacteria become resistant, and then the bacteria spread. But that spread of the bacteria is much more relevant than probably just the generation of bacteria or resistance. So antimicrobial misuse is one of the several causes of antimicrobial resistance crisis. One of the recent publications based on the resistance rate in various European countries revealed that the volume of antibiotic usage is not directly proportional to the antimicrobial resistance rate. The volume is not directly proportional to the antimicrobial resistance rate, but the socio-economic indicators of the country, like the sanitation, the GDP, the governance, the corruption, poverty, and all other potable water, all these are directly proportional to the antimicrobial resistance rate, where the volume of antimicrobial usage is not. There's no doubt the generation of resistant genes is related to the antimicrobial usage. No doubt about it. But the level of antimicrobial resistance is related to the socio-economic and governance standard in individual country. If you look at the per capita antibiotic usage, the per capita antibiotic usage in Canada or US or Australia is several times more than the per capita antibiotic usage in the country. We are a country with 1.4 billion population. Yes, we are one of the largest users of antibiotic in the world. But that's not because of our per capita antibiotic usage is high. That's because of several other socio-economic indicators. When we talk about correcting the antimicrobial resistance, we need to take these issues into consideration. Just because we doctors change our prescription, the AMR scenario is not going to change. But of course, we need to change our prescription pattern, our rational antibiotic usage pattern, because even though it may not have a big impact on the resistance level in the country, it will have a direct impact on the outcome of the individual patient. No doubt, rational antibiotic usage has direct impact on the morbidity and mortality of the individual patient. If you look at the antibiotic usage, 70% of the antibiotics manufactured by the pharmaceutical industry in the world is used in the animals for growth promotional purpose, to make them grow fat and fast. 70%. This is not used to treat infections in animals, prevent infections in animals, no, to make them grow fat and fast. Even in India, you know what's the most popular antibiotic used as a growth promotional agent? Colistin. The antibiotic that used in the hospital, the precious antibiotic, is the one that's most rampantly misused anywhere in the world. And India, we banned that usage in 2019 because of the data we gave to Indian government. The data from Chennai we published and submitted to Indian government. We convinced all the stakeholders, and government banned the growth promotional usage of colistin in the poultry and other animal farming. So the AMR crisis is much more complex and not just related to the antibiotic usage in animals. And when we look for a solution, we need new antibiotics. We need new vaccines to prevent infections. We need new diagnostics for rapid diagnosis of infections. We also need novel methodologies. And for you diabetologists, we need to explore the bacteriophage option. The bacteriophages are the virus killing the bacteria. They have got a great role to play in treating diabetic foot infections. The bacteriophage therapy started in 1915. And Alexander Fleming discovered penicillin in 1928. Several years, 2 decades before Alexander Fleming discovered penicillin, scientists were using bacteriophages to treat infections. We have to remember electron microscopy came 10 years after the penicillin discovery. So people were not seeing the virus bacteriophage, but they knew it's killing the bacteria. But then the antibiotics introduced. Penicillin came, cephalosporins came, carbapenems came, and the bacteriophage therapy disappeared from the Western world. But due to the Cold War, the Russians and Eastern Europeans did not have enough access to the new antibiotics of the West. So they were forced to continue the research and treatment with bacteriophage therapy. And then because of antibiotic resistance, the West got interested in bacteriophage again 10 years ago. By that time, the Russians and Eastern Europeans were far ahead in bacteriophage therapy. Now the British, the Europeans and Americans are doing, Australians are all doing clinical trials on bacteriophages to treat various infections. Russians inject bacteriophage into the blood. They do randomized control trials in sepsis because of bacteriophages. They have published hundreds of trials on other infections, especially diabetic foot infections, especially burn infections, cystic fibrosis, pneumonia. You can tell any infection, they use bacteriophages. It's time for our country to explore the bacteriophages as a treatment option for sepsis, burn infection, especially diabetic foot infection. We have got regulatory restriction. Our bacteriophage research methodology in the country is not advanced to have our own Indian phages for extensive clinical usage, but our scientists are doing good job in developing bacteriophages. In the next few years, and we have the facility for bacteriophage therapy in the country because of collaboration with Eastern European countries, we must explore such options. Thank you.
Discussion at the end. Can you are leaving. Yes, so any questions? Any questions from the audience? The speaker has to leave.
Yes, Dr. Karan.
In 2011, we banned over-the-counter sale of antibiotics. But within few days, we withdrew that rule because of political reasons, the right reasons, because in a country like India, where village there is no doctor, you can't ban over-the-counter sale of all antibiotics overnight. That's not possible. In 2013, after the Chennai Declaration, the DCGI brought out a new rule, the modified H1 rule, where we included only 24 antibiotics. Even that is not implemented anywhere in the country. But we included ATT as well, the tuberculosis drugs as well. And that is implemented to a great extent. So even though we could control the antibiotic usage, we are to a good extent we are able to control the TB drug. And then the quality of drugs you asked. India has got the second largest FDA approved manufacturing firms in the country, world-class standard. At the same time, there are 7,000 functioning pharmaceutical companies in India. Only 1,350 of them are the GMP, the good manufacturing practice or WHO compliant. Rest of them are not GMP compliant, but are they bad? Not really bad, because GMP practice needs more investment, better effluent treatment plants. We don't have the money to invest that much in the small pharmaceutical companies. And if these pharmaceutical companies become GMP compliant, the manufacturing cost will increase, the price of the drug will increase, and our poor Indians won't have access to medicine. So of course, but this is a serious issue, the pharmaceutical effluent. They're just releasing antibiotics into the environment. That is one of the reasons of antimicrobial resistance in India. We know the reasons. 2 years ago, when the Drug Control and Health Ministry had a detailed discussion on this, we had to balance the access to the medicine for our poor Indians. And we thought that's much more important than antimicrobial resistance. But AMR is a serious issue. Government is working on it. We need to, step by step, we need to improve the standard of manufacturing. Thank you, sir. Nano antibiotics, yeah, but we need better technology. But we don't really know. What we need is, yes, nanotechnology is good. What we need is the better GMP of the existing manufacturing.
All GPs, they prescribe the latest antibiotic on the first day of fever itself. That is the reason why we are developing the resistance.
We need rational usage of antibiotics. There is a better 10 years ago situation was far worse than this. Situation has changed in the country. There is awareness. We need rational antibiotic usage and antimicrobial stewardship in every Indian hospital. Family medicine should be a specialty. Yes, it is a specialty, but we need to encourage all specialties.
Yeah, thank you, Dr. Kapoor. Dr. Ghaffur, thank you. One thing is, that Dr. Ghaffur could not say no to me. In spite of today's Ramadan, he came just for my sake and requested. And second thing is that he is a crusader for AMR. The so-called Chennai Declaration became world famous is done by him.
Next topic is Vijayakumar. No introduction. He is talking on vitamins.
Respected chairpersons and dear delegates, good afternoon. I'm not supposed to speak now today actually, but I'm like an upma, If everything is over during a marriage, the easy thing to make is upma to feed people. So I'm just like that, I'm coming, because my friend Dr. Jayaprakash, I did not make it, I'm coming in there. You know upma? You don't know? Okay. Upma is something like a khichdi, which is easy to make. So even upma will take some time to make, I think. I know. Yeah, it has come. Upma has come. Upma has come now. Okay. See, we all having a problem, There are a lot of vitamins in the market, and then every day I'm sure a lot of you are facing that, use this vitamin, it will be very nice, this vitamin, like nice like that. But what is exactly the role of vitamins in management of diabetes? Is it really useful or it is not useful? Let us look into that in a very practical and pragmatic way. Now, what exactly, the reason why we also need to know is a balanced diet is that it should have, a balanced diet should have all the vitamins within that. So it is just called as balanced diet is the one which contains the qualities and proportion of nutrients that includes vitamins and minerals needed to maintain good health and sustain life. That's one. What is nutrition supplement, that is vitamins and minerals, is that is a preparation intended to supplement the diet and provide nutrients such as vitamins, minerals, fiber, fatty acids, amino acids that may be missing. You see that red letters, may be missing. If they're not missing, don't use it. May be missing or may not be consumed in sufficient quantities in a person's diet. So if you have a balanced diet, if you have everything, you don't need to supplement. That's what it means actually. So those people who are deficient, yes, you can think about that. Now, is there any rationale for using these supplements beyond these definitions? We can see that because of a recommended dietary program, like we say that low fat diet. So fat soluble vitamins may be low, and you are on a fluid restriction. Even water soluble vitamins may be low. We don't know about that. So in diabetic patient, because a recommended dietary program, diabetes patient may become deficient in a few essential micronutrients, and then a diabetic patient, because of metabolic abnormalities, there is a possibility of reduced absorption and increased excretion of the vitamins which are given through food. So like gastroparesis. No, it can happen actually. So there can be lack of absorption and there is an increased excretion as well, is a possibility that can happen. And then if you can see that so-called, we think that we are taking a healthy diet, the so-called healthy diet. Actually we are not eating healthy diets. For example, the lunch and dinner is provided today is not a healthy diet. So many are not eating a healthy diet, and even if we think we are, many of the so-called healthy foods we are eating have been processed, genetically altered or mishandled, leading to significant loss of their natural nutrient potential. So the way we cook the food is also very, very important to preserve the nutrients and vitamins, and if we don't do that, there is probably a need for replacement. And apart from that, what is happening is that so you can see that agriculture land is shrinking over the years. You can see that especially in the last 50 years or so. I think the agriculture land is shrinking, and the same land we are using for centuries for cultivation, and again we are using pesticides, we are using fertilizers, we use everything so that yield will increase, and genetically altered. So these things, usually what we used to have in a normal, usual, natural food, this can become deficient, and that is the reason probably not only in a diabetic, in anybody, there probably is a role for vitamin replacement. Now, if you look into the diabetic, this is one slide I am just showing. There are several such things available, but it's a short topic, so I am just thinking that you could see that there is a possibility of a reduction both in type 1 and type 2 diabetes about the zinc, and then you can see there is a possibility of reduction in magnesium in type 2 diabetes, and there is also selenium is increased in type 1 diabetes, and there is probably not deficient about vitamin B complex, and there is probably vitamin D is also reduced. It can be possibility there actually. This is only thing actually, and not many, you can see that. And off late, you can see that most of the labs are doing B12, and everyone has got high B12 without even replacement of B12. That's what is happening. In the labs we are looking at that. Now, okay, suppose if at all you require a supplementation with vitamins and minerals, what you can do, it should supply daily requirement of nutrients, number one. It should improve the insulin resistance. the reason, very important, it should improve the insulin, or increase insulin sensitivity of the tissues with these vitamins and minerals, improve metabolic abnormalities, reduce inflammation, and so that you can prevent complications, both micro and macrovascular disease. This should be the aim of real replacement of nutrients. And some people say that it is cheaper, so that you can think about that. Now, if you look into that, this is the number of molecules that you have where you would like to replace, and you can see a masala preparation happens in the market where they say that we have 82 micronutrients and vitamins in this one capsule, they say. You know, there's so many things. Not only these things, there are so many other things are also available. But what you need to know is that there are certain beneficial and maybe beneficial, but not beneficial and harmful as well. Look at this. Be careful about these things. There are beneficial ones such as chromium, zinc, magnesium, alpha-lipic acid, methylcobalamin and vitamin D. And it is not very sure whether they are beneficial, but not harmful definitely. As far as omega-3 fatty acids, coenzyme D, Q10, and beta-melon, fenugreek, aloe vera, they may not be helpful but not harmful. I am not going to touch upon these other things like maybe beneficial. I will touch upon beneficial as well as not beneficial, rather harmful molecules. Now, chromium. If you can see that chromium has been found to have an important aspect, especially in the insulin resistance syndrome. And then by replacing chromium, over the time you could see that both fasting and postprandial blood glucose coming down with replacement of chromium. And in a meta-analysis with chromium, you could see that overall estimate, you can see that the chromium supplementation in people with diabetes was statistically significant, and when there is when the HbA1c reduction is much better with chromium supplementation. Frankly speaking, about 2 decades back, chromium came with a big bang in our country and it went away immediately. See, all these things may be possibilities, but when you really look into that, it may not be beneficial. You should understand. These are all theoretically we can think about that. It came into market and it went away immediately within 1 year. Zinc, again, is a different molecule. If you look into that, approximately about 0.5% of the crystalline insulin is zinc. And very high or very low zinc plasma content may impair insulin secretion. Very high or very low zinc in the plasma can impair the insulin secretion. Now, where is it you get the zinc deficiency? Is most often happens is because of and prolonged glycosuria and diuretic therapy is the time when you can have zinc deficiency, where we can give temporarily about 220 milligrams 3 times daily for some time, and this should be initiated for no more than 3 months, because prolonged zinc supplementation may inhibit copper absorption and adversely affect lipid profiles as well. So be careful. If at all it is there, don't do it too often. Magnesium deficiency may result in disorders of tyrosine kinase activity on the insulin receptor and increase intracellular development of insulin resistance. So you can see that both zinc, chromium and magnesium, you could see that these are all involved in insulin resistance only. And then if you can do a lifestyle modification, if you can reduce it, you don't need them actually. And then magnesium deficiency could be involved in triggering of low-grade inflammatory response as well. And about 13 prospective cohort studies involving more than 5 lakh patients and had 24,500 cases detected a significant inverse association between magnesium intake and risk of type 2 diabetes. And there's some association. Again, look at this terminology, association. By replacing or improve it, we don't know. There are no studies to state that. Now, this is, I think, probably in neuropathy symptomatic relief, alpha-lipic acid can be a good choice to be given along with B12 for 6 to 8 weeks, not more than that. And the dose that you need to give is very, very important, because people come and say that I got 50 milligrams alpha-lipic acid and 5,000 micrograms of this B12 and all. Don't believe in that. We need to give minimum 600 to 800 milligrams of alpha-lipoic acid per day for 6 to 8 weeks along with methylcobalamin to get symptomatic relief of symptoms. That's only thing that we can, especially for those people who are unable to tolerate painful neuropathy, pregabalin. So its side effects may not be there with these two drugs. It's quite safe to be given. Now, I'll finish in 2 minutes. Yeah. Vitamin D, I think you must have known many times. The only thing is association of vitamin D deficiency and various metabolic disorders is well accepted, but whether replacement would improve is not well established. No, it is associated with every disease you name. You name cancer, immune diseases, and everything except rickets. I think everything is so can be considered probably when person has got some musculoskeletal pains, probably. And morning, I think Dr. Sriram Mahadevan was also asking whether is it worth doing vitamin D testing. He said no need, you just replace it because it is cheaper to replace rather than whom to be replaced? Those who got symptoms, not everybody. And India, almost everybody has got a vitamin deficiency. I am vitamin deficient, but I am not replacing. I am quite okay. I don't have any musculoskeletal pains. So I think beware of this testing, that everybody goes for vitamin D testing. Patients are coming and asking, I got a vitamin D deficiency, please replace it. So we need to convince them about that. Now this is about the so-called beneficial vitamins. Let us go into the harmful vitamins. Selenium is one of the factor in those days. It's become a what do you say that a buoyant molecule supposed to be, which is supposed to have pancreatic benefits and increase serum production, and pregnant women, the healthy fetus development, so many things. And later on it is found that you can see that selenium supplementation does not seem to prevent diabetes, rather it may increase the disease. So be careful, don't use it. And then vitamin E supplementation, all of us, you think, you could see that in this heart outcomes and prevention evaluation study investigation, which is published in New England Journal of Diabetes, clearly said that in patients at high risk for cardiovascular events, treatment with vitamin E for a mean period of 4.5 years has no apparent effect on cardiovascular disease, doesn't prevent it at all. In fact, high dose, that is more than 400 milligrams per day, vitamin E supplements may increase all-cause mortality. Look at this, all-cause mortality, and should be avoided. And this is a Cochrane collaboration. It clearly said that very important point that they have said is that replacing with antioxidants such as vitamin E, beta-carotene, vitamin E, and other things together is not going. It's only there is no evaluation before marketing, and then it is more harmful than giving them. So avoid all those things to be given. So that is the reason ADAS came down with a recommendation stating that though there is increased inflammation in diabetes, there is no clear evidence to state that by replacing with the antioxidants like vitamin E or vitamin A and other things, it is not going to. There is no clear evidence, sufficient evidence rather, to say that replacement will reduce the inflammation. The association is there, but replacement there is no sufficient evidence to say that. So friends, take home messages include that if the balanced diet is deficient in essential nutrients due to decreased absorption and increased excretion, supplementation is needed. And then goal for nutrition supplementation is to improve metabolic requirements so that it will improve the metabolic disturbances, improve immunity and reduce the inflammation. The beneficial molecules you should recognize, non-beneficial harmful molecules you should also recognize. Please take note of benefits as well as harms of supplements. Thank you for your patient hearing.
Thank you. Vijayakumar, since the topics are varied, we thought we'll have 1 or 2 questions. Yes, sir.
One small comment actually, because there is another important overprescription of aspirin in diabetes patients, And there is a study which has shown that high more than 400 milligram intake of vitamin E plus aspirin intake in long term increases the risk of hemorrhagic stroke. So therefore, injudicious use of all these supplements should not be done.
Dr. Vijayakumar, I was looking forward to you talking about chronic metformin usage, and somehow I thought, I think it may be useful for the chronic,
especially vegetarians.
Yes, sir. The so-called metformin usage, we can get B12 deficiency as well as folate deficiency. But as long as you use metformin, there's no point in replacing orally.
That's very important. I think most of the time we give oral.
Yes, sir.
I think because it produces a malabsorption like syndrome, I think it should be in the injectable form.
If we are using more than 1 gram of metformin for more than 5 years of age, patient is elderly, there are studies which have shown clear risk of vitamin B12 deficiency. And vitamin B12 deficiency, they have found to be related to absorption is some calcium dependent. So that is why in market, some metformin tablets are coming along with these supplements also. So one paper which is published way back in JAMA, they clearly recommend that in patients who are going to get it metformin more than 5 years, more than 1 gram of dosage, along with use of many PPIs which patient take over the counter medications, yearly injection of one injection of vitamin B12 will prevent vitamin B12 deficiency in diabetic patients.
Sir, there's no point in giving oral.
No.
Because,
Orally will not
given as injection.
Yes.
No, sir, actually, thank you for bringing this point, sir. Actually, I have my own experience regarding this. Suddenly, we see people having anemia with unknown anemia. Then initially, I used to send to the hematologist for analysis. They spend about a few thousands of rupees and come out with nothing. Then I was realizing about this about 15-20 years ago. I stopped metformin in these people, and most of them have improved on hemoglobin.
Vijayakumar, what is your favorite?
Dr. Vijayakumar, having a balanced diet is a big question. Most of the people don't have, especially elderly diabetes who are dependent on children for surviving, and also in IT professionals. They take burgers, pizza, and then KFC chicken. So balanced diet is it's a question. So is it not mandatory to prescribe vitamins for these people?
I agree with you, sir, but it may not be mandatory, but we need to improve their dietary habits before prescribing the drug. That's what I am trying to say.
You cannot improve because that man is living on his children.
That's why I asked him what is his favorite. See, Supradine, Batragali or Supradine is a well-known product. It's cheap. See, the message is that don't overspend on multivitamin. They are very, very prohibitively expensive, like if not like incretins, and people may not have money to buy your insulin or something. That is the
and gold. Sir, as you say, if it is, see, in fact, what is exactly said is that if it is inexpensive, there is no harm in replacing, but you should not overdo anything. That's one thing. Huh?
And many of the vitamins are expensive than
regular medication. You're right.
Thank you, Dr. Vijayakumar. This extra time is specially for the organizing secretary. For others, it's only 10 minutes.
Now we are doing good for the diabetic community.
Sir, there is sufficient time in discussion time.
Anyway, good topics. We don't mind spending more time.
Vijayakumar, yes, this balanced diet should be accompanied with the exercise. That's very important. Without exercise, balanced diet won't work.
Dr. Vijayakumar, one more area, the excitement about vitamin D. I think again, there's not much from your.
You are right.
That is again, so much of confusion about vitamin D.
So much of material is there, sir. And we have seen in ADS some poster presentations. By giving vitamin E for about 200 to 300 milligram, there is a benefit. When it crosses 400, it is supposed to give harm actually. So it's very difficult.
Vitamin D, Dr. Vijayakumar, not E. D, vitamin D.
Vitamin D, yeah. Okay. We can. If you want, we can.
Pharma driven or?
No, sir, there is a. No. Do you know that the vitamin D has been estimated in the doctors' community? 99.99% are vitamin D deficient. If you check all of you, everyone will be vitamin deficient. But how many have got any pains, musculoskeletal pains? Nobody.
So Indian population, genetically I think they are deficient in spite of 9 months of sunshine.
I think
that's
probably we are accustomed to low vitamin D, probably.
Yeah, it's true, but in the context of diabetes, now it is thought to be a panacea for everything. Pathophysiology of diabetes, complications of diabetes, everything.
Association, sir. Replacement may not improve it actually.
Correct. I think, thank you, Dr. Vijayakumar, very nice lecture. We'll go to the next topic. This is about management of diabetes during steroid therapy, and that will be by Dr. Ranjit Unnikeshnan. I don't think he requires any introduction.
Thank you, sir, for kind words of introduction. Let me thank Dr. Vijayakumar and organizers of 3DCon for allowing me to speak on this topic. I know that this is somewhat like taking coals to Newcastle to explain this simple topic to this august audience, but I'll try my best. So, we all know that steroids are very commonly used drugs, and they have been used and misused widely, especially in the context of COVID pandemic. We have had lots of misuse of steroids and all the adverse effects inherent therein. But what's to be remembered is that all glucocorticoids can cause glucose intolerance, and it is basically dose dependent. And what is the ceiling dose beyond which you get glucose intolerance? It is 7.5 milligram per day of prednisolone or its equivalent. I'll show you the equivalent dose of various steroids in a moment. And now we have to discuss this under two headings. One is steroid use in somebody who is not known to have diabetes, in whom a deterioration in glucose tolerance can happen, and people with diabetes in whom the glycemic control can deteriorate. So we will discuss this under two heads. And when you give a steroid to somebody with diabetes, the deterioration of glycemic control that occurs is rapid. In fact, if you give an IV steroid, it can start happening within 2 to 4 hours. When you give an oral steroid, depending on the time action profile, it can vary from anywhere between 6 to 24 hours. But in those without diabetes, when or whether they will get hyperglycemia depends on a multitude of factors, such as the family history, the beta cell reserve, the level of obesity, and so many other risk factors. There are some people who never develop hypoglycemia on steroids also, although that is quite rare. And in most of these people, when you stop the steroid, the hyperglycemia resolves. Unless it has been, it is a latent diabetes which has been unmasked. In olden days, people used to have the steroid stress GTT, something similar to that. And what type of steroid can cause hyperglycemia? It is basically the systemic steroid. That is the oral preparation and the IV preparation. It's very rare with inhaled preparations, very rare even with intra-articular injection. We have people with periarthritis shoulder who come to us and say the orthopedician has asked for steroid, what will happen to my sugar? Usually nothing happens. Another point to note is that when you use topical steroid, application of steroid cream over a large area of the skin and you cover it with an occlusive dressing, that can actually lead to systemic absorption of the steroid, and especially in children in whom the proportion of the area covered as a percentage of total surface area is high, that can actually lead to deterioration of glycemic control. So these are the relative strengths of glucocorticoids based on their anti-inflammatory potency. Please note that the anti-inflammatory potency is not the same as the diabetogenic effect. This is just a table to show you the relative doses, equivalent doses of the various steroids, taking hydrocortisone as 1. And also remember that difluzacort, for some reason people seem to think that difluzacort is a very benign steroid. Nothing of the sort. It is as bad or as good as any other steroid. So what leads to the hyperglycemia? Use of glucocorticoids. Basically, the main mechanism is impaired insulin sensitivity. And it can occur at the level of both skeletal muscle as well as the adipose tissue, and they mainly augment the gluconeogenesis, not so much the glycogenolysis. And to what extent the plasma glucose rises with steroid use depends on your beta cell reserve. Same mechanism as what happens during pregnancy. Everyone's insulin resistance will increase during pregnancy, but those people in whom the beta cell is capable of overcoming that resistance do not develop gestational diabetes. Just like that, somebody has got a very robust beta cell reserve. Whatever the dose of steroid you give, however long you give, your sugars are not going to increase to any great extent. So how will you monitor and manage a case of steroid-induced hyperglycemia? Now these are all guidelines from the British societies which have been adapted by the RSSDA. Just last year we had the meeting for RSSDA guidelines, and these have been adopted by the RSSDA. So somebody without a diagnosis of diabetes who is being initiated on steroid, you should check A1C ideally. And that's a mistake most of us used to make during the COVID pandemic. When you're starting steroid, we don't think of checking the HbA1c because we have other things to worry about. What is going to happen to the patient due to COVID pneumonia. But in any case, when you start steroid, especially if the patient is older, has a family history of diabetes, obese, such cases you should check the A1C. At least you will be forewarned that you have to do something about it and you have to monitor more frequently. At least once daily you need to monitor the CBG. And ideally you check it pre or post lunch or towards the evening meal, because the normal usual steroids we use such as prednisolone are intermediate acting steroids. The sugars will not go up immediately after the steroid dose. It will only start going up towards the evening. So if you just do a fasting sugar or a fasting and post breakfast, you may miss the increase in glucose levels. And the values are below 200. They're saying 216 because remember this is taken from the British guidelines, so it's all in millimoles. So we can say as a rule of thumb, the values are below 200. Keep monitoring once a day. If it's below 180 consistently, you can probably stop monitoring, because that patient is very unlikely to develop hyperglycemia later on. But the values are persistently above 200, at least 2 occasions during 24 hours. We have to increase testing to 4 times a day and probably think of initiating medications. And what are the therapeutic targets? Just as for any other hospitalized inpatients, a target of 140 to 180 is appropriate. Most stringent targets can be utilized if these can be achieved without occurrence of significant hypoglycemia. So what are the therapeutic options? Oral agents may be used in mild cases. Do we have any evidence? Of course, we have some evidence for sulfonylureas, especially glycoside, and we also have some evidence for metformin. Most of these drugs are considered safe, but efficacy-wise, there is not much of data. See, things like thiazolidinedione, there's no point starting a thiazolidinedione when you're starting somebody on steroid, because this is a slow-acting drug. By the time the drug starts working, the steroid is stopped. Similarly, drugs like GLP-1 receptor agonist, SGLT2, they say you should best avoid, not because it doesn't work, but because these are generally sick patients, especially those who are admitted with COVID and all. We don't want to give them a drug that can cause nausea, vomiting, dehydration. So these are best avoided in acutely ill, only because of the nature of the illness, not because it has anything to do with steroid. But majority of patients will require insulin. If you give enough dose of steroid for enough period of time, they will require insulin. And 2 options are given for initiating insulin, a prandial-based regimen and BMI-based regimen based on the dose of steroid, which is considered to be more physiological and can be more easily titrated. So what insulin to use? You just remember, hydrocortisone is similar to rapid-acting or regular insulin. Prednisolone, methylprednisolone are similar to NPH or Detamir. And dexamethasone is very similar to Glargine or Degludec. If you remember that, you will know which insulin to start. If you are taking hydrocortisone, you have to give it multiple times a day. You may have to give multiple doses of rapid-acting insulin. If you give prednisolone, methylprednisolone, sugars will go up towards the evening. By next day fasting, it will come down. So give a dose of intermediate-acting insulin or a Detamir along with the dose of steroid in the morning. That will cover the hyperglycemia. Dexamethasone, probably the hyperglycemia will last for 24 hours or even more. You may require even once daily Glargine or even twice daily Detamir or NPH. Of course, all only rules of thumb. We'll have to adjust the doses by frequent monitoring. So this is the BMI-based regimen based on the prednisolone dose and the insulin dosage per kilogram. This is only a starting dose. Of course, nobody's sugar is going to be controlled with the starting dose. We'll have somewhere to start somewhere. So this is the starting dose. So in somebody with the previous diagnosis of diabetes, review the glucose control, do an A1C, review the present therapy. Those drugs which need to be stopped have to be stopped. Targets again between 100 to 200. We have to monitor CBG 4 times a day. But if CBG remains stable, which is unlikely, you can reduce the frequency of monitoring to maybe twice a day. Somebody is on parenteral feeds, ICU patient, you have to monitor CBG every 4 to 6 hours. Somebody is on IV insulin, you may have to even monitor half to 2 hours, because these people tend to have wide fluctuations of glucose levels. And this is what the British guidelines state about how to adjust the anti-hyperglycemic therapy in people with diabetes who are on steroid. Target again 6 to 10, as I mentioned, around 100 to 200. Increase the monitoring, give education to the patient. If hyperglycemia is there and the patient is on OHA, they are saying glycoside you can increase up to a maximum of 320 milligram daily with a maximum of 240 milligram in the morning. It's a huge dose. We generally don't give these sorts of doses of glycoside. Metformin you can increase to a maximum 1 gram BD, which we generally do in our patients. They don't give any option for giving any other non-insulin therapies. If the sugar is not under control with that, you will have to switch over to insulin. Patient is on insulin and still having hyperglycemia, you may have to, first of all, you move the evening dose of insulin to the morning, because towards the evening only glucose will go up. If still uncontrolled, you may have to transition to a basal bolus regimen. So points to note are that steroid-induced hyperglycemia can be difficult to control. Oftentimes what we do is we are playing catch-up. Sugar goes up, we try to bring it down, next day again the sugar goes up, but at least you are limiting the damage. The worst thing that can happen is that you and the patient not being aware that they are taking a steroid. That often happens. They go to some doctor, some GP, some quack even, who gives some steroid. They don't know it contains steroid. Sugars go sky high and you see them after 2 or 3 months with all sorts of complications. It is difficult to control not because of the steroid, but many a time because of the severity of the underlying illness. Patient is sick, is in the ICU, having systemic sepsis or something of that sort. Then even if you don't give a steroid, it is difficult to control such patients even with insulin. So large fluctuations can be expected in severely ill patients, those who are post-op, and those who are taking complex immunosuppressant regime, like those who are post-renal transplant or post-liver transplant. So in such situations, let perfect not be the enemy of good. Just because you cannot get your glucose levels to 100 fasting, 150 postprandial, do not give up. Let us keep a range of 100 to 200 and try to get the patient within that range as soon as possible. And remember that this too shall pass, because after some time definitely they will stop the steroid and the patient will get back to normal. That brings us to the last point. Do not forget to step down the anti-diabetic therapy when the steroid dose is tapered. Otherwise you will have people in severe hypoglycemia. Thank you for your attention.
Thank you, Dr. Ranjit. You can take up some questions. Any question from the...
Sir, Lakshman, sir.
Dr. Lakshman.
Ranjit, you are coming from a very big center. During COVID time,
yes, sir.
How often you have come across hyperosmolar non-ketotic state, the diabetic having COVID with steroid therapy?
And not too many, sir, for the simple reason that by the time somebody comes to a stage where we had to give steroid, we were not allowed to treat those patients in those days. Of course, now the situation is different. But retrospectively, after the COVID pandemic is over, I get a lot of history from patients that these things have happened. So personally, I have not seen, because whenever somebody is tested positive of COVID, we give them the option. We tell them, boss, you can stay here or you can go to here. They're so scared. Can't blame them. That time, nobody knew about COVID even. So most of them used to go off. So we hardly saw any HHS or DK for that matter, but that is there in the literature, and now when they are coming back to us, we are hearing all these stories. And we don't know how many of them have passed away because of that also. So obviously such people, we cannot get the history. It has been a major issue, sir. And unfortunately, most of the steroids that were given were not indicated. I've seen people being given steroid in home care. It's clearly mentioned steroid should be given only for hospitalized patients who need oxygen. It is not for any other patient. We are giving preventive steroid. That leads to a lot of problems in our patients. We have seen that happening.
Steroids.
Yes, sir.
Twin-edged weapon. So it is
yes,
not
sir.
only simple hyperglycemia, osteoporosis.
Yes, sir. Absolutely right. Avascular necrosis.
Yeah. So insulin is recommended than OH.
Better, sir. Absolutely better.
And it can cause induce hypertension or precipitate existing hypertension,
lipids,
sleep disturbances,
tendon rupture.
Yeah. So what is your experience about, that is why we lobby for a full-fledged endocrinology rather than merely diabetology. You are a self-styled diabetologist. So what is your experience?
What we generally find is that the course of steroids which we have given in these conditions, they generally don't lead to these sort of problems. But we see people taking steroid for other indications. And what they do is they start steroid, they don't go back to the doctor. They keep on taking it, thinking that they are feeling so much better. It's like a pick-me-up.
So in general medicine, what we do is that if you give steroid, you give PPI. But it is more than that. And
yes, sir.
Yes, sir. In a diet. Thank you.
Dr. Chandrasekhar, I think he has huge experience.
I think we had a lot of cases of these
yes, sir. You must be
hyperglycemia. occurred during the COVID time. So we have seen a lot of these cases of non-ketotic hyperglycemic coma. So the two things which we had a difficult time in confronting this, mitigating this hyperglycemia, number one. Number two is when you are giving insulin as well as the steroid, in steroid recurring patients, hypokalemia was one thing like which was not been addressed in the initial stages, and we have lost quite a few patients, and we were a little bit baffled, and retrospectively when we investigated, their ECG showed some kind of the hypokalemic abnormalities. So these are all two situations which we have encountered, and finally we made these to the advisory committee also, and we have incorporated some changes pertaining to the electrolyte abnormality also. So that also we have seen, sir.
What is the age of the patients? Because hyperosmolar is very common in elderly and with multiple comorbid condition. In your Stanley's.
Yes, sir. Yes, sir. Yeah, middle age to elderly, all the people they had. Commonly, we have seen it with middle age, sir. So 40s and 50s, like we have seen.
Mortality?
Mortality is like definitely hyperglycemia patients. We had more mortality, sir. So patients with yes, of course. Yes. Sir. Yep. Yeah, definitely hyperglycemic patients, they had more mortality, sir.
60%, 40%, roughly.
They're roughly only, sir. Yes, sir.
Thank you, Dr. Kannadi. I think they will go to the next speaker. Thank you very much, Dr. Ranjit.
Now I invite Dr. Rajesh Rajput, and he'll be speaking on declining EGFR. Yes, sir. Good evening, friends. Well, at the onset, I must declare I am not a nephrologist. I am an endocrinologist. But obviously, before becoming endocrinologist, I am an internal medicine specialist also. So Vijay has given me the responsibility of discussing about EGFR. So I am going to discuss briefly about EGFR. Now this is schematic diagram of two kidneys, nephron, Bowman capsule, which all of us know, have read during our first and second professional examination. Now there is a renal plasma flow which is around 600 to 720 ml per minute. Normally GFR is around 120 ml. Remember, there are three mechanisms which are responsible for auto-regulation of GFR. Myogenic mechanism, which involve relaxation of afferent arterioles, and tubuloglomerular feedback, and third, activation of RAS system. And why I have shown you this diagram, because when we come to the therapies to preserve EGFR, there are some drugs which act on efferent side of the tubule. There are drugs which act on the afferent side of the tubule, and it is best to use combination of drug which will act on both efferent and afferent side of the tubule. Also, there is a mesangium where structural changes takes place which will damage your glomerular tuft. So there are now drugs which will handle this structural part of the tubular pathway. Now if we see, there are many equations which are available. We always tell from last 5 to 7 years since the advent of SGLT2 inhibitor that please calculate EGFR of all your patients. Do not simply rely on serum creatinine. There are many equations which are given. If you does not want to use, all of you are now carrying smartphones. There are free apps available where you have to simply put serum creatinine, age of the patient, gender of the patient, and you will have an automatic EGFR available to you. So just try to use them. Now why I am saying serum creatinine alone should be not measured? After 4th decade of life, even in healthy individual, there is a gradual decline of EGFR to the tune of 1 ml per minute per square meter body surface area per year. Which means by 70 years of age, more than 40 ml per minute per square meter body surface area of GFR is physiologically lost. Therefore, if you are seeing a 70-year-old gentleman at same serum creatinine in comparison to a 40-year-old gentleman, the purpose of serum creatinine or the interpretation of serum creatinine will be different. So a 0.9 milligram per deciliter serum creatinine at 40 years of age carries a different connotation similar to a 70-year-old gentleman. So therefore, do not only rely on serum creatinine, always calculate EGFR, take into account age of the patient, gender of the patient, they are going to decide about eGFR. Coming to the causes of decline in GFR, when we were students, we were told glomerulonephritis is a leading cause for decrease in eGFR and CKD. But now currently worldwide, diabetes is a leading cause for glomerulonephritis and decrease in eGFR, followed by glomerulonephritis, then hypertension and others, which include number of other diseases. This is in a diabetic patient, typically initial stage of hyperfiltration, then GFR decreases gradually. If we will not control hyperglycemia aggressively right from day one, at the same time there is gradual increase in protein excretion from normal excretion to increased micro and macroalbuminuria. What is the prevalence of CKD? This is our own pan-India study, prevalence of chronic kidney disease in type 2 diabetic patients, where across country we have collected samples, and in this population we have seen, we have enrolled 3043 subjects, 3000 were eligible. We have shown 47.8% have mildly decreased eGFR, 15.1 has moderate, and so on. And not only that, we have assessed microalbumin. So when it comes to eGFR, also assess urine albumin level. Now based on these two parameters, eGFR and albumin level, you have to risk categorize your patient. Now based on eGFR, there are categories of CKD. 3 and below is defined as CKD, that is less than 60. Similarly, albumin excretion is A1, A2, A3, where A1 is less than 30 milligram per gram, A2 is 30 to 300, which is a microalbuminuria stage, and A3 is more than 300, which is macroalbuminuria stage. Now this is a table which is nowadays available on net. You can keep it on your table. Now why it is important? Both the parameters are important. If whatever is seen is green is good, and whatever is shown in orange and red is bad for the patient. Now it is very simple. You have calculated eGFR, you have assessed albumin excretion, and see at same level of, how to move it back, at same level of albumin excretion, if your GFR is different, patient is in different risk category. How to highlight this? Okay, I got it. So say for example, patient eGFR is 60 to 89, but patient albumin excretion is in A3 stage. Patient is in macroalbuminuria stage. Now this patient has come into a risk zone. In contrast, even with an eGFR of 60 to 89, if albumin excretion is in A1 stage, patient is in green stage. So it's risk categorization based on eGFR and based on albumin excretion in a particular patient, change the therapy. What are the factors affecting progression of kidney disease? Number of factors. Simple obesity is a risk factor for development of CKD. Age, I have told you, as we ages, there is a decrease in eGFR normally. Diabetes, race, ethnicity, smoking, hypertension, hyperglycemia, cause of CKD, dyslipidemia, presence or absence of cardiovascular disease. So lots of diseases are responsible for causing CKD. So when it comes to prevention of decrease in eGFR, there are two approaches. These two approaches are indirect approaches, which means you target risk factors like aggressive control of hyperglycemia, hypertension, hypervolemia, dyslipidemia, and direct targeting the renal dysfunction, which will decrease your eGFR, which will slow down the decrease in eGFR, and which will reduce albumin excretion. And this is how, based on staging of and natural history of the disease, we can do screening, risk factor modification, diagnosis and treatment of the patient. Now the first is, we will discuss only direct, the drugs which are acting on kidney directly. If we see last 20 years, from 2000 onward, we have ACE and ARBs. I will not discuss in detail about these trials, Renin trial, IDNT trial. These are standard of therapy for all patients who have developed CKD. But remember, ACE and ARBs act only efferent side of the tubule. They does not act on afferent side of the tubule. they does not have any effect on structural damage which is going in the kidney. So lots of unmet need is present when it comes to prevention of CKD and reduction of EGFR in diabetic or non-diabetic kidney disease patients. So next evolution comes with SGLT2 inhibitor. And this is a diagram to show the projection that if at the age of 63, EGFR of 56, if you prescribe SGLT2 inhibitor, irrespective of presence or absence of diabetes, what is going to happen? A patient of diabetes, the projected decline in EGFR is 4.59 per year, which means in next 10 years, this patient will require renal replacement therapy in form of dialysis or transplant. But when you add SGLT2 inhibitor timely, what is going to happen? The decline in EGFR is reduced to 1.85 ml per year, which means patient will get an additional 15 years before he is progressed to renal replacement therapy. So SGLT2 inhibitor after 20 years is a new drug which is acting on afferent side of the tubule. ACE and ARBs are acting on efferent side of the tubule. SGLT2 inhibitor are acting on afferent side of the tubule. So now we have another drug, and these are number of mechanistic pathways which I will not discuss in detail, but have a look on this slide. There are large number of reasons because of which SGLT2 inhibitor has to be used in a patient of CKD irrespective of glycemic status. Remember, irrespective of glycemic status, and they are recommended to be used in all patients with EGFR up to 20 ml. We have now studies and data that up to 20 ml they are safe, effective in reducing progression. But despite use of SGLT2 inhibitor, still large number of patient still progresses. So there is a unmet need to address the structural defects. So there is another drug, Finrenon. There is an entire lecture on this. Finrenon is a non-steroidal mineralocorticoid receptor antagonist, and it has been shown there is an overexpression of mineralocorticoid receptors which are responsible for fibrosis, apoptosis, inflammation in renal parenchyma. And based on Fidello study, Finrenon is now approved for use in patients of CKD to reduce progression of the study. So friends, we have now 3 different class of agent. I am going to stop in next 1 minute. We have ACE and ARBs which act on efferent side of the tubule, hemodynamic effect. We have SGLT2 inhibitor which act on afferent side of the tubule, have hemodynamic as well as number of other benefits. And we have Finrenon which has anti-inflammatory, anti-fibrotic effect in preclinical model and are found to have reduction in albuminuria independent of changes in BP in patients who are having type 2 diabetes and CKD. So all 3 pathways are blocked if we are using combination of drug. So the future, what are the gaps? If we see, can we use combination of Finrenon and SGLT2 inhibitor? In the trial, very small number of patients were assessed who were having both Finrenon and SGLT2 inhibitor. But understanding their different pathophysiological mechanism, it seems combining them is going to be beneficial, but we do not have any large-scale randomized trial to answer this. So dual therapy has a role in current treatment guidelines. Can 3 drug class means combining RAS inhibitor, SGLT2, MRA in patients of CKD and type 2 diabetes are going to provide further benefit? Again, this question is going to be answered by future randomized controlled trial in this. So I will like to stop here by showing this quote, fresh thinking rather than predetermined or predictable thinking is required, because practicing medicine is an art of interpretation of science and its application to human health, behavior and disease. Thank you very much.
Thank you, sir. The floor is open for discussion.
So, sir, there is no difference in Indian guidelines as compared to Western guideline. Always remember one thing, I am not against any Indian guidelines. In our country, there is a lack of robust data because of which whatever society we belong, we simply replicate or copy paste the Western guideline and try to adapt to some extent to our own local circumstances. So Indian guidelines done by Nephrology Society of India are not different from Western guidelines.
So between ACE and ARB and finerenone, where do you place the two? Which one comes first?
No, there is nothing like first or second. There is a different mechanism of action. So if we see a patient of CKD nowadays, there is no confusion. We have to start directly ACE or ARBs plus SGLT2 inhibitor, as you have listened in heart failure lecture. There is no doubt about it. There is an additive benefit. The benefits of SGLT2 inhibitor are over and above what has been given by ACE and ARBs. Both are cheap drugs, generic drugs nowadays, so no patient should be devoid of the benefit of two drugs until and unless there is a contraindication or side effect to one drug. Coming to finerenone benefit currently is only shown in type 2 diabetic patient with proteinuria, which is not controlled by these two different class of drug. These two, ACE and ARBs plus SGLT, can be used irrespective of glycemic status. But finerenone is to be used only in patients of diabetes, because non-diabetic data we do not have still to us. So we do not know whether they are effective in non-diabetic patients or not.
Thank you.
Absolutely. Potassium level has to be monitored. Any patient who is having hyperkalemia or who is having eGFR less than 30, we have to be cautious when we are using finerenone. In contrast, such type of contraindications are not there when we have to start and give SGLT2 inhibitor.
You talked about the apps to calculate the eGFR.
Yeah.
So which is the
large number of from Medscape to any application which we currently are using, they have GFR apps. They calculate your eGFR according to MDRD also. They give option whether you want to use MDRD equation or CKI MDPP equation. So you can choose all apps. I have in my phone 2-3 different apps, and they are free of cost.
They're both not the same. They don't give
No,
the same
for
values.
diabetes, CKI EDP equation is preferred in contrast to MDRD equation.
Sir, in practice, what do you do in private practice? How do you monitor eGFR? What you did in your PCR?
No. I see. We know gender of the patient. For that, no big science is needed. We know we have to measure weight of all our patients. If we are not doing, it is our fault. We measure serum creatinine of all our patients. We have smartphone with us. So we have to put down all these values. eGFR is automatically calculated. On the flip side of it, if your patient has lots of money, nowadays private laboratories, you write down serum creatinine and eGFR, they will do this calculation for you and they will charge 500 rupees more. So both the ways, whatever way we are comfortable, we can do it.
One more thing is that in your practice, the incidence of analgesic nephropathy among diabetic women and the acute kidney injury, because these people are at vulnerable. So we talk.
Right. I have already told I am not a nephrologist by profession, but I does not see analgesic nephropathy. So I cannot answer this question with certainty what is the prevalence in my practice. So I does not have much experience, sir.
In the cardiology sector, the diabetics are more prone for acute kidney.
Sir, Karnadi sir, please, no time.
No, please.
Have you worked in the cardiology department or nephrology department? Diabetes, see, in practice.
No, बताइए क्या पूछ रहे
1 or 2 minutes, we are not going to lose anything.
Okay, Dr. Karnadi.
Denigrate yourself. Let me tell you again. Let us start.
Yes, क्या पूछ रहे थे सर, बताइए please.
Yeah, in case in the cardiology practice, diabetics are more prone for there is a subsection.
Yes, definitely. In cardiology practice, because patient often have heart failure, low ejection fraction, so there is a cardiorenal syndrome now entity established. So that is why they are more at risk to develop renal disease. Similarly, renal disease patients are more at risk to develop cardiac disease. So there is a crosstalk between specialties.
That is why we want the endocrinology as a super specialty. You got the point? This is the only specialty where general practitioners are giving lectures. This is very, very...
Right. So if there are any questions, message from this lecture is why I think GVK must have kept. We are teaching that kindly start calculating eGFR of all your patients which you see in your routine practice, irrespective of glycemic status. Now you have drugs where you can change the natural history of CKD patient. So this is a basic message which you should do in your clinical practice. Thank you very much.
Can I invite Dr. Chandrasekharan to give a talk on neuropathy, painful neuropathy?
Yeah, good afternoon, ladies and gentlemen. Thanks to GVK sir. This is my topic, painful neuropathy. This is a very basic slide, like where you see the kind of different types of nerves, the motor and sensory nerves and the autonomic nerves. It's very simple that like many times the diabetic patients, they do get a lot of sensory symptoms. That is because most of these nerves are they are having some kind of unmyelinated, so it's unmyelinated or thinly myelinated, whereas motor nerves are thick and they are myelinated. So that's the reason why you get more often these kind of the glycemic excursion and oxidant injury, reactive oxygen injury, all these kind of thing like a chronic inflammation that can lead on to small fiber neuropathy. So these fibers are otherwise called the C fibers. They carry most of the time the nociceptive information, that is pain and heat. So that's why many of our patients, they do feel some kind of dysesthesia, the burning type of pain, lancinating type of pain, pricking type of pain. These kind of thing are more common in such individuals. That is because of the involvement of the sensory nerves, which are either unmyelinated or thinly myelinated. So we know that like 8% of the diabetes, they can have peripheral neuropathy at diagnosis, and over a period of time, depends on the duration of the diabetes, more than 50% of the patients, they can develop this neuropathy. Of course, put the patient on a lot of the morbidities like deformity, foot ulceration, neuropathic pain and so on. So I'm going to talk about a little bit on the neuropathic part of it. But before that, this is a very important slide. Like, so whenever a patient is having a hyperglycemia, it can go to several pathways. So one such thing is through the aldus reductase pathway. It can get converted to the sorbitol and it decreases the nerve growth factor and can result in neuropathy. So people have tried a lot of aldus reductase inhibitor, but it all unsuccessful. Like so, the other pathways were like the exosomal pathway and protein kinase pathway. Again, people tried a lot of PKC inhibitor and other things to mitigate the oxidative stress. Again, end up with failure. So this is a kind of thing like where the patient who are having a long-standing diabetes, they are at risk of developing neuropathy over a period of time. So there are some signals about these, the changing concept with regard to the diabetic neuropathy. So we all know that like the mitochondria is one thing which can convert, utilizes glucose and lipids and converts the NADP and FADP to ATP. So this we all know that. So that what happens in patients with diabetes is there is a bioenergetic failure happens, because of which like despite glucose, like there is a disruption of the electron transfer, these NADP and FADP, which can result in increased accumulation of the reactive oxygen species, and as a result like small fibers again are at risk of vulnerable to develop a neuropathy. So this is characteristically, it occurs in a distal to proximal fashion, so which we all clinically we see. So this is a chain. So not only the diabetes, but also the kind of hypertension, dyslipidemia, obesity, all these things like which results in bioenergetic failure and decreased utilization of these ATP and resulting in oxonal failure and neuropathy. So what are all the risk factors? So we do have a lot of risk factors, of course, hypertension, dyslipidemia, obesity, all these things. Remember that like these things are again a cardiovascular risk factor. Of course, the duration of the diabetes, the alcohol, patients with low socioeconomic strata are some of the risk factor. So this is a thing which we are looking at is the peripheral neuropathy or painful neuropathy. So not only the control of the blood sugar, but also the control of the metabolic syndrome, which we are aiming at with the recent literature, with the recent literatures available. And another thing is like the exercise, which has got a moderate evidence of benefit to all our patients with neuropathy, particularly the supervised exercise, the aerobic exercise, weight training exercise, balance exercise. So these things are very much important under supervision for these patients. Of course, the recent ADA also has given lot of emphasis on these the exercises under supervision. So coming to my topic proper, so I have given you an overview of the diabetic neuropathy. This is acute painful diabetic neuropathy. So this still we do see in up to 8% of our population. This form of sensory neuropathy is quite moderate to severe. Typically, we do see these kind of cases after the normalization of the glucose. Many patients comes to us after they get optimal levels of blood sugar. They come and say that they get neuropathy symptoms are getting worsened. And this can also follow a DKA, more common in females, more common in people with eating disorders. Of course, the prognosis is good and it's self-limiting. It may last for 3 to 6 months, maximum up to 1 year of time. Previously, it was called insulin neuritis. Now, the terminology is treatment-induced neuropathy of diabetes, because insulin is not only the cause, there are other things are also there. Coming to the common form which we see in our clinical practice is another presentation of this painful neuropathy, which can present with lancinating pain, dysesthesia, pricking type of pain, burning sensation, particularly worsening at night time, involving the lower limb. Sometimes it can involve the trunk, and patient can present with ANS features also. This is again quite common in patients with weight loss and on patients who are on diabetic treatment under control. Now coming to the pharmacotherapy, there are very few drugs which are available to treat this painful neuropathy. One such agent is pregabalin, which acts on the calcium channel alpha subunit ligand. The dictum is we need to start slow and low. Start with BD dose to we can up titrate to TAD dose. Of course, 300 to 600 milligram is the maximum tolerable thing which we can go for. These drugs are excreted unchanged in the urine. So we need to exercise again some caution when the patient is having a eGFR of less than 45. Of course, these patients who are on pregabalin, when we step up the dose, they are at risk of developing somnolence, drowsiness, and pedal edema, particularly with a higher dosage, and in patients who are elderly. The practical thing what we can do is most of the symptoms they occur only at evening or night time. We can do the asymmetric dosing. So we can give 75 milligram in the morning and 150 milligram at evening time. So this asymmetric dosing can be done, and of course it does have some anxiolytic actions which can benefit patients who are anxious. The next one is the selective norepinephrine serotonin reuptake inhibitors. Of course, venlafaxine is not not indicated for treating painful neuropathy. So this duloxetine is a very good drug, which is available as once daily dosage. The maximum tolerable dose is 60 to 120 milligram. Of course, it does have some similar efficacy. It can be combined. It can gel with pregabalin also in patients who are not responding. Of course, it also produces some kind of somnolence and dizziness. And in addition, it does have some antidepressant activity, which can benefit patients with depressive symptomatology. The third one is amitriptyline. It's an age-old drug. It's a good drug, but we need to be cautious about its side effects. That is dry mouth, urinary retention, and drowsiness. We need to exercise caution in patients with ischemic heart disease and in patients with glaucoma. We can start with 10 milligram or 20 milligram, and we can escalate it up to 75 milligram. This is another anti-epileptic drug, which has got a shorter half-life, since can be given thrice daily. Again, you need to exercise some caution in patients with low GFR. The opioids, it has got varying actions. Tramadolol still can be used. And paradoxically, the naltrexone also can be used as given in the recent literature. Generally, these drugs, we can start with pregabalin or gabapentin. Then we can add up the SNRI. The TCA comes as the third line of agents. The opioids again comes little bit later. The duration of these drugs to treat painful neuropathy, it varies. Generally, it's usually up to 6 months of duration. The other group of drugs are topical nitrate and capsaicin, which should be given repeatedly, and sometimes it can cause unpleasant burning sensation that one has to keep it in mind. Of course, these are all other things, SCS, FRAMS, stents, and NMS, or other modalities to treat patients with painful neuropathy. Of course, much has been discussed by Dr. GVK about the nutraceutical products. So, ladies and gentlemen, this is a very commonly prevalent chronic complication of diabetes. One has to screen for these patients. Of course, I didn't dwell much on the screening part of it because my topic is on the management of painful neuropathy. Early diagnosis is more important, not only the blood sugar, the other parameters, hypertension, dyslipidemia, weight loss, and graded exercise under supervisions are very much important to treat these patients with painful neuropathy. Of course, it needs some multi-level management, and the treatment should be individualized. Thank you for your attention. Thank you.
Thank you, Dr. Chandrasekhar. You can be here to take up questions. Any questions from the floor?
Venlafaxine, the duloxetine is the one which we have. So the problem with the duloxetine is like, it's a good drug like which can combine with patients with the pregabalin or gabapentin. It's a very good drug, and it does have some antidepressant actions also. But the thing is, there are two things with as far as the side effects are concerned. One is somnolence, and it is known to cause sexual dysfunction. That is more common in patients with SSRI and SNRI. So that is another thing. Very rarely it can predispose a person to develop arrhythmias also. So in a patient elderly and patients with ischemic heart disease, we need to exercise caution.
See.
Yes, sir.
Yeah, agitation, see, the thing is, you are a professor of medicine. In elderly, it can cause hyponatremia.
Yes, sir.
So one has to be. So sexual dysfunction is, that is why people don't, tolerability is not much. It's a delayed ejaculation or what is it, dysargasmia. So in young people may not tolerate. But other thing is that there are number of drugs, cardioprotective, which one is a neuroprotective drug, which you think? You market all the drugs, renoprotective or cardioprotective. What is the drug which you will teach to your students for?
Anti-diabetic.
Yeah. Yes. In diabetes we talk only, general medicine we talk about everything.
Still, metformin is a good drug, sir. So don't worry. See, the thing is, metformin, I don't say that B12 deficiency, don't...
if you give, in acute neuropathy, if you give insulin, the sense of well-being. Okay?
Yes.
That is why you should work in diabetic department.
In fact, Dr. Shanmugam, Dr. Chandrasekhar, older literature used to mention that one of the treatment options for very painful diabetic neuropathy, which is very resistant to the conventional drugs, is insulin. In fact, you can give insulin for a short period.
Yes, sir.
Yes, even intravenously as.
See, the message to the general physician is that come and work with us for 6 months. Chumma inga vandu pesikite irukadinga. Work with diabetes is a very simple specialty. 3 மாசத்துல நீ படிச்சிருவ. புரியுதா?
Dr. Karnanidhi, come on.
This is the
please.
Inga vandu ellarum enna you call yourself as a diabetologist. You come and work.
Sir, don't say that. Yeah, I put it as physician only. Like.
And but on the other hand, it is also well known that when you start patients on intensive insulin therapy, neuropathic pain will increase initially. You have to always assure the patient that later the pain will come down.
Unfortunately, we don't have a drug, this aldolase mechanism. Okay. யாருக்கா ஒரு ஸ்டூடண்ட் இருந்தானா அதுல ஒரு இது பண்ண சொல்லு சரியா
yes sir so one point sir
theory and practice is very
yes sir the practical point which I tell you sir like yes it's a good point which you said it's
you are all good people the industry ruins us புரியுதா
yes sir so the insulin is like whenever the patient is on insulin when they get a good glycemic control. The problem is that neuropathy can paradoxically worsen. This is practically we do see many times. Yeah, temporary thing. So that is because of the regeneration of the nerve fibers and even fluctuations in the glucose level.
Unmyelinated.
Yes. So where apoptosis can happen, can increase the pain. So that is in an acute setup like it's a very challenging thing, sir.
So one more point I would like to practical thing. Many of neuropathy is a function of duration of diabetes. So many of these elderly patients also will have prostate, and both carbapenem and the other one is known to produce acute retention of urine. Have you ever come across such?
Yeah, it's quite common we see with TCAs, like tricyclic antidepressant. Of course, these drugs also, SNRI and
I
other
think one
things
warning
also
has to be given because
Yes,
some
sir.
elderly people, already they have a prostate, they can have problems.
In such patients, like pregabalin may be a good drug, but the problem again with the pregabalin is the tachyphylaxis. So we need to keep stepping up the dose of the pregabalin.
Thank you, Dr. Chandrasekhar. Wonderful talk on the topic, given topic. There is a slight change in the order. Now we'll go to the topic on type 1.5 diabetes by Dr. Balamurugan.
Good evening, everyone. At the outset, I would like to thank the organizing chairman, Dr. GVK, for this opportunity. Respected my professor teacher, Dr. Madhavan sir, is also there. And happy here to talk for 10 minutes on type 1.5 diabetes. This start with a case study. It's a 29-year-old female. 29-year-old male with a polyuria and weight loss in the previous 4 months, no recurrent abdominal pain, no family history, BMI 20, urine ketones negative, and glycemic control for the first 1 year was achieved with OAD, required insulin thereafter. The GAD antibodies are highly positive, and normal imaging of abdomen as well as fasting C-peptide was low. So the diagnosis is very obvious to you, and we are going to talk about none other than the 1.5 diabetes or LADA. The latent autoimmune diabetes of adults is a form of diabetes with features of both type 1 and type 2 diabetes, and as they had before been termed as type 1.5 diabetes. In Japan, the synonym used is slowly progressive insulin dependent type 1 diabetes mellitus, and the American Diabetic Association lists LADA as type 1 diabetes that evolves more slowly than the classic disease and does not recognize it as a specific type of diabetes mellitus. On the other hand, the Immunology for Diabetes Society has specified 3 criteria for the diagnosis of LADA. 1, age greater than 35 years, positive autoantibodies to islet beta cells, and insulin independent for at least initial 6 months after initial diagnosis. And the LADA itself is a heterogeneous disease. Some patients have high antibody titers, a low BMI, and progressive to insulin therapy faster. On the other hand, you can see there's another spectrum who have a low antibody titers, features of insulin resistance like higher BMI, and progress more slowly to requiring insulin. So it's a heterogeneous disease. And what is the etiology of that? The risk for acquiring the LADA is highest in carriers of certain HLA haplotypes. The HLA genes code for the major HLA which have important immunoregulatory function. There is a paucity of studies investigating the role of environmental factors like lifestyle in LADA, the reason for being the need for antibody measurement in every newly diagnosed adult diabetic patients to identify and classify the patients as LADA, unavailability of the lifestyle information antecedent to the diagnosis of LADA, the absence of comparable cohort groups, and the inadequate sample size of the LADA patients in the studies enhances the power of the study. So there are some factors like increased physical activity, moderate alcohol use, and the intake of fatty fish have a protective effect on the risk of LADA. 2 or more cups of coffee daily increase the risk of LADA. I again tell you that there's only the studies are very limited. And how do we diagnose LADA? Age at least 30 years or older, the positive for at least one of the autoantibodies found in type 1 diabetes, free from insulin treatment for the first 6 months after diagnosis. You can see the 20% of the persons diagnosed as having non-obesity related type 2 diabetes may actually have LADA. So it becomes a more and more responsibility for us to make a diagnosis of, not to make a diagnosis of type 2 in everyone. And when you suspect such a lean patients, that age group, and you think, that we need to work up for a LADA. So LADA versus type 2 diabetes, the C-peptide levels, LADA have low levels versus normal or high in type 2 diabetes. The glutamic acid decarboxylase antibodies common in type 1 diabetes, early age of onset, non-obese individuals, no family history of early onset diabetes, the ketosis prone may require insulin after initial 6 months. This is a differentiation. Epidemiology, it's also the most prevalent form of autoimmune diabetes as a whole. When you take the autoimmune diabetes as a whole, the LADA comes as the most prevalent form. And there are geographic and ethnic differences in incidence. In the multicentric action LADA study of the group in Europe, almost 10% of the 6,000 adults with adult onset diabetes had islet cell autoantibodies. In the UKPDS study, the antibody positivity among the presumptive diagnosis of type 2 were approximately 12%. So the 10 to 12% compared to the European and UK. And most patients with LADA are positive for a single islet autoantibody, and glutamic acid decarboxylase antibody is the most predominant. And the pathophysiology is very detailed, and the islet cell beta cell autoimmunity antedates the onset of LADA by several years. This is followed by insulin resistance that causes overt hyperglycemia and the diagnosis of autoimmune insulin independent diabetes mellitus. And so the predominant macrophage CD68 infiltration was shown in the islet cells as opposed to type 1 diabetes. And again, there's a proliferation marker of nuclear antigen and anti-inflammatory cytokine interleukin 10 were elevated. And again, looking at the regulatory T lymphocyte produce protein-like transcription factors called forkhead box protein 3, that's FOXP3, which suppresses the autoimmunity. And again, the IG4 class of GADA is more prevalent in LADA than in type 1 diabetes. This yields a T helper 2 lymphocyte immune response, which may be one of the explanation for the delayed onset of diabetes in LADA compared to type 1 diabetes. A variant of the insulin autoantibody 2A, that is more frequently found in LADA and may be useful in its detection. There is a positive correlation between the BMI and interleukin 17, a pro-inflammatory cytokine from peripheral beta B lymphocyte. History and diagnosis, symptoms of polyuria, polydipsia, nocturia, fatigue, visual changes, tingling in the feet, weight loss may be present or can be asymptomatic also. A personal family history of autoimmune disease. A history of low birth weight is also a strong indicator. History of smoking and alcohol consumption. A diagnostic screening tool with the 3 criteria was used to identify LADA in diabetic patients over 50 years of age, like low or normal BMI, a high fasting blood sugar of 270, A1C 10% or greater despite good compliance, and loss of weight despite a diet constant in calorie content. So patients with LADA are usually ketosis resistant at first diagnosis. How do we evaluate it? A positive antibody to any one of the islet antigens is the hallmark of LADA. The IA2A, which is associated increasingly with the LADA2 phenotype, insulin antibodies, and zinc transporter isoform antibody. The glucagon stimulation test and mixed meal tolerance test have been validated and found to be useful, and the C-peptide is a cost-effective when used as an initial test to distinguish LADA from type 2 diabetes. The outline investigation for the other diabetic patients should be employed in LADA, which include the glucose, A1C, and they measure the glycemic variability, lipid profile, and other GFR. How do we manage it? Therapies which will preserve the beta cell function are a priority. Sulfonylureas are a poor choice for LADA as they deplete beta cells. Metformin may help initially in glycemic control in patients with LADA with higher BMI. Thiazolidinediones have anti-inflammatory effects on the beta cell and can prolong their survival and can be useful if used in the earlier stage in LADA. And the GLP-1 receptor agonist, dulaglutide, has shown improvement in beta cell functions in patients with LADA. Addition of vitamin D to insulin or DPP-4 inhibitors improved glycemic control and preserving the beta cell function. SGLT2 inhibitors have not been well studied in patients with LADA. There is a novel immunomodulating treatment with alum-formulated recombinant human GAD65. By administering 3 injections of 4 micrograms each into a lymph node in the groin along with a daily oral vitamin D is in the phase 2 of the trial, GAD in LADA trial. And differential diagnosis, the main challenge is to differentiate from type 2 diabetes. The first degree relative having an other autoimmune disorders like Hashimoto's thyroiditis, Graves' disease, and rheumatoid arthritis might give a clue. On the other hand, type 1 can present type 1 we cannot miss it. It presents dramatically explosive with most of the time with ketosis, and more than one autoantibody is easily differentiated from the LADA. Again, sometimes the maturity onset of diabetes of the young is mistakenly diagnosed as type 1 diabetes and type 2 and LADA. And the prognosis, the patients with LADA have a mortality as high as type 2 diabetes despite having more favorable metabolic parameters. In the Hunt study, it was shown that hyperglycemia was the only significant influencing factor and not the component of the metabolic syndrome in determining the mortality. That was chiefly due to the cardiovascular disease. It is therefore goes without saying that strict glycemic control is the key to improving the prognosis of LADA. The complication again, small fiber neuropathy has been found, and more often than with the age and duration of type 2 diabetes. Again, long-term follow-up patients with LADA reveals a lower risk for the first 9 years, but higher risk in later years for microvascular complications. Patients with LADA has got a much carotid artery atherosclerosis as in type 1 and type 2 despite a better vascular risk profile. Increased cardiovascular disease and mortality in LADA similar to type 2 diabetes. Bone resorption is reduced in LADA, but the mechanism is different from the type 2 diabetes. And so to conclude, when do you suspect LADA in any adult patient with diabetes with ketosis? LADA shows destruction of the pancreatic beta cell, insulin, and LADA is sometimes ketosis prone. LADA shows low C-peptide levels and the positive autoantibody, and then again insulin will be the treatment of choice later. Thank you very much.
Questions, Dr. Purvi? Can you give a mic?
Excellent talk, sir. Often patients are well conserved even on oral anti-diabetic agents when they come and you're still suspecting LADA. Would you initiate them on insulin even before the C-peptide actually goes down?
No, if you ask me frankly, many times, what I see, I have not diagnosed so many patients with LADA, and I have not treated so many patients with LADA. So I have tried to learn also from the day, and we do not advise all patients. First of all, all these C-peptide levels, autoantibody levels, probably the endocrinologists have a more passion in ordering this test, and probably we also need to, I do not disagree, probably we also definitely need to classify all patients, young diabetic patients, into what type. So ideally speaking, when the C-peptide level is 1 point, if you are very sure that the patient has got a residual, very less C-peptide, and probably you were thinking that it's a slowly evolving type 1 diabetes, probably one aspect of giving insulin to them is to give the pancreatic beta cell a rest and trying to conserve whatever the beta cells possible. That's my suggestion.
Thank you, sir. I'm also learning.
Obviously, Karnanidhi has asked a question and given an answer. Yes, sir. Venkatraman, sir, you want to say something?
Dr. Rajesh wanted to say something.
Purvi, can give it the mic to sir.
Just what Purvi is asking.
Excuse me, please listen.
If what Purvi is asking, if LADA is there, treatment of choice is insulin therapy and glitazone therapy, which have proved to preserve beta cell in some of the studies. Any drug which is stimulating pancreatic beta cell, more antigenic expression, faster destruction of the remaining beta cell.
So, but in case you are not able to, do not have the facilities to diagnose, till that time what do you do?
We are discussing science.
Yes.
If we are not diagnosing according to the science, then whatever we are doing is non-science.
Probably Anand.
Yes. So there is no answer to non-science.
Anand, probably what he wanted to say is, when you make a diagnosis of LADA,
yes,
what we are going to do.
Yes.
My personal view is, I want to conserve the beta cell and try to manage
Dr.
it.
Moses,
Venkatraman sir wants to say something.
Just wait, before I end, if you are not making a diagnosis, how we are sure this is LADA? This can be MOD.
You are right, you are right.
This can be other variant of type 2 diabetes. So then we are treating patient empirically, which is not a correct as far as scientific basis.
Scientifically, it may not be correct.
See, that is why now that everybody is here, we should have a young diabetes registry in a government setup, both in the institute as well as in the pediatrics.
True,
For
true.
obvious reason, our ICMR, they bribe the ICMR, it is in a private setup. None, have you ever referred?
No.
I don't know how much they charge. You people, you keep mum. Because of our inaction, science is being sold to...
What did you say, Karnanidhi?
Venkatraman sir.
Diabetic registry should be in our institute. In Madras Medical College, institute. See, the first I met all of you is that you all came to Thuthukudi, the MDDM. Malnutrition, this is how I don't know, sir. He is very quiet. See, that is because we are, my observation is that India minus politician IAS, diabetes minus Sheshaya Mohan, let us do that. I don't know, Karnanidhi minus diabetes also lalata irukum, but Karnanidhi diabetes minus Mohan and Sheshaya is much better. This is what my observation. Thank you.
Venkatraman sir, you wanted to say something? Yeah.
Yeah, thank you. I think what I'm going to say is in tune with what Karnanidhi says. There was a, when there is a rationale, certainly, always.
Okay, sir.
Right. So, there was recently a symposium on young diabetes. So, in that symposium, some really practical suggestions were put forward. Possibly in the guidelines, they may be captured in years to come. There, the message is, like we all discussed, a scientific workup. Even in the presence of GAD antibody positivity, if the C-peptide is good, you are justified in initiating and continuing OHA. What they say is, there are evidences, yes, beta cell preservation is there, but at that point of time, probably this sort of a suggestion will also take into consideration that a diagnostic workup may not be uniform across the spectrum of the disease that is being witnessed by the clinicians. So, even in the presence of GAD antibodies, if the C-peptide response is good, clinicians are justified in continuing, initiating. You remember this paper we read in our journal club?
Yes,
I mean, this is a conference suggestion. This conference was attended by a lot of people who cater to the needs of the young diabetics. Young diabetes is a huge spectrum. It just includes everything. Your MODI, LADA, and early onset type 2 diabetes mellitus. This was the message. What I'm trying to say is there is a certain amount of rethinking with respect to the therapeutic approach to the young diabetics. Be it LADA, be it MODI, be it type 2 diabetes. I just thought I'll share this with you.
LADA itself manifests heterogeneously, sir. We have one group with a reasonably good C-peptide and less antibodies. On the other hand, we have a group with a very low C-peptide and higher antibody levels. Probably we can decide case by case if you are able to investigate. Thank you.
I think a good thing is to suspect a patient on the inspection. The patient has no markers of resistance at all. Very lean diabetics, adult diabetics, absolutely no markers of insulin resistance. We can suspect LADA in these patients. And rightly, Venkatraman said 3 days of sulfonylurea give, and then similarly to C-peptide is still less. Today only I decided a patient with the GAD antibodies elevated with a negative C-peptide, even after 3 days of oral sulfonylurea. He is on basal bolus therapy. Clinical suspicion is the must. In 40, 50 years old guy, very lean guy, no markers of resistance at all, suspect LADA. He has been taking OHA for a number of years, to more than 3-4 years. All the time the sugar was at 300, 400, 450.
Sir, but then one important, as you have said, patient is on sulfonylurea for 3 days and then assessed. No patient on sulfonylurea C-peptide should be assessed. That report will be false, because whatever type of diabetic patient we are giving sulfonylurea, that are stimulating pancreatic beta cells. So basically, when we are going to assess C-peptide,
I'm only going to check the beta cell reserve in this guy.
Off from sulfonylurea.
Since we suspected the patient LADA, he started on insulin. He asked me whether I should continue tablets also. So we gave 3 days of oral sulfonylurea plus metformin. The C-peptide was still very, very low. So showed him that may not be a candidate for your OHS, only on insulin. He was 64.
So that's a very valid point, because especially when
We
the
see
patient
type
is
1
young.
diabetics even at the age of 70 now.
80 years, up to 80 years.
So the index of suspicion should arise from the clinical examination.
Thank you.
Then
I think we had a wonderful discussion. Maybe go on to the next topic. That is erectile dysfunction in type 2 diabetes. Sanjay Reddy is not here. Dr. Kumar Velu, endocrinologist from Madurai. He is the current president of the Endocrine Society of Tamil Nadu. He is going to talk to us on erectile dysfunction in type 2 diabetes. He also has another talk, beta cell regeneration at the end.
Respected chairperson, co-speakers and my dear friends, now I am going to discuss about the management strategies in erectile dysfunction. So man is considered to have erectile dysfunction when he cannot acquire or sustain an erection of sufficient rigidity for sexual intercourse. Though it may be a problem with the men, remember both the partners in the relationship are affected. So I think this message has to reach everyone. And the first description of erectile dysfunction was in 2000 BC, where they tried to describe erectile dysfunction as natural impotence and supernatural impotence. So the natural impotence, where a man was not able to accomplish a sexual act, and supernatural impotence, they thought it is due to influence of evil spirits. Aristotle was the first person who suggested that nerves carry the spirit and energy to the penis, and erection was due to influx of air. Even that time they thought the penis was like a balloon. They never knew penis had a blood in it. Leonardo da Vinci suggested blood in the penis was responsible for the erection. So this is the first time they thought there is a vascular component which was involved in erection. But after that, over years, we have now understood an erection requires a very coordinated interaction of multiple organ systems. Psychological aspect is very important, endocrine, vascular and neurological aspects. All these things should be integrated and coordinated. And this ultimately leads to desire, arousal and orgasm. When you have a problem with this arousal and other things, you develop erectile dysfunction. And the incidence of erectile dysfunction is age dependent. It is 2% of seen in men age less than 40 years, 20% of men in age 65 years, and more than 75 years, at least 75% of men have erectile dysfunction. And it is not necessarily occurrence of aging process alone, it could be due to other pathological process also. So the causes of erectile dysfunction includes, it could be organic causes like vasculogenic, which could be arterial, cavernous or mixed abnormality. You can have a neurogenic problem, you can have an anatomical problem in your penis, you can have an endocrinological problem. As endocrinologist, that is where we are more concerned, because many forms of erectile dysfunction, if it is due to hormonal abnormality, it could be easily treated or cured. Hyperprolactinemia is one of the most common cause of erectile dysfunction, and hypogonadism is again yet another cause of erectile dysfunction which could be easily handled. Of course, you have psychogenic, which is generalized type, or which could be situation type, which could be partner related or performance related. Of course, drug-induced forms a major form of erectile dysfunction, especially in patients with diabetes, where polypharmacy is more common. Patients are exposed to various drugs like beta blockers, and you have various thiazide diuretics, you have various antipsychotics and neuropathic medications which can lead to erectile dysfunction. So ED in diabetes, predominantly it is due to endothelial dysfunction, autonomic neuropathy, hypertension, large vessel disease, medications like I discussed before, and the prevalence of erectile dysfunction in diabetes, even in people below 50 years, is reported to be 55%. It is a very common clinically apparent complication of diabetes in men. And ED again, it does not have impact only in sexual problem, it has linked to a vascular risk also. So it is very, very important for us to evaluate the reason for erectile dysfunction and treat it accordingly. So evaluation of erectile dysfunction, you have a multifactorial model where you have to look at the mental health is very important. You look for various other medical histories pertaining to the patient, whether the patient has suffered from an illness, what are the medications patient is on. Look for external stressors, and another thing which is commonly ignored is what is the belief, cognition, or what the patient has.
and partner relationship, partner's sexual functioning, and early sexual experiences, all these things contribute to erectile dysfunction. Of course, Peyronie's disease and absence of secondary sexual characters, which could point out to hypogonadism, and Peyronie's disease, you can have a painful erection, which is definitely possible. So, a multifactorial model where a thorough history pertaining to his hormonal status, mental status, family status, social well-being, everything is important for us to decide what could be the cause for this erectile dysfunction. So, your aims of the history should help you to define the problem and find the cause or most of the treatable causes what the patient would be having. We should try to understand the concerns and expectation. Even if you diagnose erectile dysfunction, if that is not a concern with the patient, it's not necessary it has to be treated. And when I say concern, it is a concern of both the partners. Many a times it may not be a concern of the men, but it could be a concern of a woman. We have seen this very commonly in our clinical practice. They keep on asking questions, they don't get up. When we know they are asking so many irrelevant questions, we directly ask them whether you have erectile dysfunction. Or many times the women, when she walks out, they just try to leave the men. And I think that also has to be, the concern is very, very important. And before treating, you try to assess the fitness for resuming the sexual activity, because they could have not been in the sexuality for a long time, to assess the fitness and assess the need for more detailed examination. And diagnosing sexual dysfunction or erectile dysfunction, apart from what the patient says, you have various questionnaires to suggest how severe is the erectile dysfunction. So you can follow any one question. You have various published questions which are available, and one such questionnaire is a sexual health inventory for men from IAEF, where you have various questions pertaining to the confidence in erection, the strength for penetration, and how exactly they are able to maintain the penetration, the intercourse satisfactory. So when the score is less than 7, it suggests severe. When the score is more than 21, it suggests there is no erectile dysfunction. And evaluation of erectile dysfunction, as I said before, the primary level approach is to have a detailed medical and psychosocial history. Then you do a physical examination, hormonal and basic laboratory tests, and then based on your clinical findings and based on your patient or partner goal or preference, you look at your second level approach, which could be a psychological counseling, which could be a nocturnal penile temescence when you are suspecting a patient to have organic erectile dysfunction. Advanced neurological studies, functional arterial and venous studies when you are suspecting some vascular abnormality. Then you can have a therapeutic trial, oral medications, phosphodiesterase inhibitors, intracavernous injection, and vacuum constriction device. The treatment options available, you have non-pharmacological approach like lifestyle modification, changing medications or altering the medication which could precipitate erectile dysfunction in the men. Counseling and psychosexual therapy forms the mainstay of therapy. Pharmacological, hormonal therapy is useful when the patient is having hypogonadism or associated hyperprolactinemia. So if nothing is there, hormonal therapy may not have a major impact when you try to look at the risk-benefit ratio. So other drugs, oral, intraurethral and intracavernous drugs are available. You have non-invasive vacuum constriction devices, minimally invasive or invasive devices, penile prosthesis is available, and you have various revascularization procedures when you are suspecting some vascular abnormality. Testosterone in patients with documented hypogonadism definitely improves your erectile function. It is available as parenteral, oral and transdermal preparation. It has patch, gel, any form of preparation is available. So whenever you use testosterone, erythrocytosis, cardiovascular, and assess the risk for prostatic whenever you are seeing elderly people, and testosterone in young people can decrease your sperm count. So if infertility is a major issue with a normal sexual function, be cautious in using your testosterone. So the most commonly used drug for your erectile dysfunction is sildenafil citrate, which is the first phosphodiesterase inhibitor. There's no direct smooth muscle relaxation, and it is ineffective in the absence of neural activation. Just taking sildenafil is not going to improve your erection. So you should have a adequate neural stimulation to have your sildenafil or any phosphodiesterase inhibitor to work. And phosphodiesterase inhibitor basically acts by inhibiting your PDE5 enzyme, whereby it acts through a cyclic GMP where your erection is more prolonged. So the treatment scheme, usually you start with 25 to 100 milligram. Elderly, you start with very low doses. The usual starting dose is 50 milligram. Initial as a trial, we tell them to take at least 4 tablets, which they can take it in a month, and if it works, you try to increase the dose, and patient is reviewed. If successful, then he is told to take at least 10 tablets in a month he can take, and it is effective in 70% of the patient. The efficacy of drug depends on two factors. One is the drug, and second, the confidence in which you counsel the patient. Because even in the sildenafil trial, even people with placebo had a positive erection. So you counsel them adequately. Even you give a neurobion fort, many times patient can have a erection. So psychological factor forms a primary role in erectile dysfunction. So sildenafil, it is commonly what we use. Tadalafil is a long acting. It is especially useful when you have an unscheduled sexual act. We say sildenafil has to be taken 1 hour before sexual act. This scheduling the sexual act itself gives a stress and it pulls your erection. So tadalafil is useful in unscheduled sexual act. And whenever you are using this phosphatase inhibitor and nitrates, which is a very common concern, absolutely contraindicated in men taking long acting or short acting nitrates. Sildenafil in men with nitrates at least 24 hours before or after should not be taken, and men with long term without sexual act consider treadmill testing to assess the risk for cardiac ischemia during sexual intercourse. It is not for the drug. Other drugs, you have alprostodil, which stimulates your cyclic AMP, and it can be used as intracavernous or intraurethral. Other agents, yohimbine, trazodone, L-arginine, VAP, intracavernous papaverine. Of course, you have varying data with this. And you have vacuum evacuation device, 90% it has shown to be benefit, but the issue here is that because of the vacuum, the penis, the blood is staying there, you have a cold penis, which may not give a satisfaction to a woman with this sexual, and it is contraindicated in bleeding disorders. Penile prosthesis, which is again available. And just to summarize, erectile dysfunction, you detect erectile dysfunction, which could be doctor initiated or patient initiated. Then you evaluate your erectile dysfunction. Management of erectile dysfunction, you assess your fitness for your sexual activity, modify the reversible factors, then only you should consider drug. Without modifying the reversible factors, don't consider medical management. First line could be a oral drug or vacuum or predominantly counseling. Second line you can use an intracameral injection. Third line could be a penile prosthesis. And follow up these patients with erectile dysfunction. Just prescribing a drug is not going to do wonders. And thank you so much.
As we are running out of time, we'll have the detailed discussion at the end of the session. There will be one question from Dr. Rajesh.
What is the role of tablet apomorphine? It is now available.
Yeah, it's a
apomorphine.
I have not used tablet apomorphism, but the data, you have varying data with this apomorphine.
Please say your patients are not used, not
I'm sorry. I have not prescribed. I'm sorry.
I just not prescribed.
I have not prescribed apomorphine.
Actually, apomorphine is very useful if patient has decrease in desire. So it acts at the central level. So whenever there is a sexual dysfunction, whether there is a decrease in desire or desire is there, but patient is not able to sustain the erection. So we have to differentiate. Sometimes both the things are present.
Yes.
So if it was only lack of desire, then tablet apomorphine is very useful.
Okay. Dr. Karnathan, if you don't mind, we'll have the question at the end of the session. We'll give time. Please. Okay. I think we'll go to the next topic. That will be by Dr. Purvi Chawla. She will talk on skin and diabetes.
Good afternoon, everyone. Thank you so much, Dr. GVK sir, for this honor, and honorable chairpersons as well. So I think you were really testing me when you gave this topic to me, because to complete skin in 10 minutes is really a very tall order. So anyway, I think we all know what skin is, the structure of it, what the integumentary system is. But what we fail to acknowledge is that it's really a reflection of inner health or inner disease, and it can really give us a lot of hints as to what's going on within. So your skin is the fingerprint of what is going on inside your body and all skin conditions. Very rightly said so. At least 1/3 of our patients or people living with diabetes have skin manifestations of different kinds at different stages in the disease process. More often, infections are seen with type 2 diabetes, and then autoimmune conditions with type 1 diabetes, as you can imagine. In fact, these skin manifestations of conditions that develop may be the first indicator of disease, and besides aesthetic concerns, actually we need to be concerned about the inner complication that it's indicating. And it's really it may be secondary to metabolic effects on microcirculation as well as the skin collagen. These are the key defects that we see in most of the skin conditions associated with diabetes. So the key is to recognize them and then prevent them, of course manage them well. So I've just enlisted some of the most common or well typified conditions seen in type 2 diabetes as well as in type 1. And I'm just going to walk you through some of them, highlighting some of the important features associated with them. So periungual telangiectasis, as the name suggests, we've seen it in up to 49% of those with diabetes. It arises in the nail bed after the loss of capillary loops and the dilatation of the remaining capillaries. How it presents is that there is a lot of tenderness around the nail bed, and the erythema is very visible, also ragged cuticles. And no treatment is really necessary for this because it improves with good glycemic control. The next is necrobiosis lipoidica. This is rare, but again more common in women as compared to men, and again seen in more with type 1 diabetes as compared to type 2, and it usually is a marker for diabetes. So if you see this condition, you should evaluate the patient for sugars, and usually it's multiple, bilateral, pretibial, and has these non-scaling plaques which I've shown you in the picture with an atrophic center, surface telangiectasis, and then a violaceous raised border. Pathophysiology, like most skin conditions, not really known, but then again precipitated by localized trauma, microangiopathy, immunoglobulins, and then metabolic changes as well. It does not correlate very well with how well the diabetes is controlled somehow. But it also is prone to ulceration, and hence trauma needs to be prevented. We also have this bullosis diabeticorum, which is slightly more common than the previous two I described. These are distinct, spontaneous, non-inflammatory blisters on the acral skin looking like burn blisters. And they are more seen in men as compared to women, especially when there is long-standing diabetes and also peripheral neuropathy in tandem. Again, cause is multifactorial, and three main types have been seen. One is a very common type that I've shown you here, another is a hemorrhagic type, and then there is a non-scarring type as well. These are self-resolving. If you feel that the patient is really inconvenienced, they can be aspirated without breaking them. Vitiligo, again this is a very common condition, but more so in type 1 diabetes as compared to the general population. Again, combination of biochemical, cytotoxic, neural, autoimmune, and genetic factors for vitiligo, and all you see is hypoachromic macules surrounded by healthy skin, ranging from a few millimeters to even large patches. And this is due to the loss of cutaneous melanocytes. May be treated very well with topical steroids as well as UVB light. Lichen planus, we often struggle with the diagnosis of this condition. These are inflammatory keratotic dermatitis causing condition with an unknown origin. What you see is polygonal erythematous flat lesions. And when it occurs in the mouth or the oral cavity, you will see a white lacy pattern, which probably if you once see, you will never forget. Again, may respond very well to topical or intralesional steroids, systemic steroids, or even phototherapy. One of the commonest conditions that we see is yellow skin and nails. Almost 50%, 40 to 50% of all our patients have this if we really take the time to observe. Even more so in our elderly patients, and most evident at the distal end of the hallux, caused by hypercarotenemia and protein glycosylation end products. Diabetic thick skin is equally common in both type 2 as well as type 1 diabetes, and heralds as a marker for diabetic retinopathy as well, Who would have imagined that? Well, it's because of increased stimulation of insulin with the background of insulin resistance, and then non-enzymatic glycosylation of collagen, which causes the collagen to form these cross linkages and is not amenable to the degradation process. So there is increased amount of collagen collecting in the skin at localized forms, localized regions, and then there are three main forms identified. Besides the general asymptomatic ones, the most severe form is the diabetic scleroderma, which again, few of us might have seen them. Acrocordons, these are nothing but the skin tags. And again, family history, obesity, inflammation, and hyperinsulinemia are the hallmarks of these. This is because of hyperinsulinemia due to insulin resistance that ends up activating the IGF receptor, leading to keratinocyte and dermal fibroblast proliferation, and that's how you get these. But mind you, if there are more than 3 skin tags seen collecting at a spot or at multiple sites, do look out for the sugars of this patient, because this is a forerunner for diabetes. These are mostly benign, however, they may change into a malignant form, and again there may be abrasion or necrosis seen as well. These are commonly seen in the axillae, eyelids, neck, groin, and again, I think mostly for cosmetic purpose, the patients may seek help for the same. They can be either removed with forceps or even more sophisticated procedures like using the photocoagulation, cryosurgery, or even the lasers. Diabetic dermopathy. This is one of the most commonly seen skin manifestations associated with diabetes. They are pigmented pretibial patches or skin spots. Approximately 50% of our patients live with this. What you see are multiple asymptomatic, round, brown, dull red to pinkish papules or plaques ranging from 1 centimeter to even 2.5. They may be benign, and the underlying mechanism is not really known, but definitely associated with other microvascular complications, and it is due to the hemosiderin deposits. More than 4 lesions, or at least 4 lesions at a time, indicate diabetes. So again, we need to screen these patients if the skin condition has come up even before they know they have diabetes. It is associated with the duration of diabetes and poor glycemic control. These seem to heal and disappear, leaving atrophic hypopigmented patches at the site. Acanthosis nigricans, I think this we all are absolutely familiar with. It heralds indicates insulin resistance, and again it's because of the excess circulating insulin that binds to the insulin-like growth factor receptors and stimulates the keratinocytes and dermal fibroblasts, pretty similar to the pathogenesis underlying the skin tag formation. These are hyperpigmented, velvety thickening of the skin folds and seen especially in the intertriginous areas. Although largely asymptomatic, these can become painful, they can actually become macerated or even ulcerated, and they can emit a foul smell as well. The dark color is attributed to thickened keratin containing superficial epithelium. These are reversible in nature provided there is intense weight loss, improvement in the lifestyle, and also reduction in insulin resistance. Acquired perforating dermatosis. This is again a condition not very commonly seen, marked by small umbilicated dome-shaped papules and nodules with a hyperkeratotic plug on extensor surfaces which are very, very itchy, and also there may be Keebnerization. The patient may say that the minute I hurt my elbow or I hurt my the skin surface to another object, I start getting these lesions all over. The pathogenesis is unknown, but defective differentiation of the epidermis and dermal epidermal junction due to alteration of glycosylation and diabetes are known factors. It is associated with diabetes and even chronic renal failure. Some of the other common conditions that we see with diabetes are as follows, and I'm not going into the details because these are not as commonly seen, but the commonest are cutaneous infections. I'll finish in a minute. We all know why, because of associated with poor glycemic control and because of poor microcirculation, peripheral vascular disease or neuropathy, and even the decreased immune response. Candidal infections are commonest, and again we know where they thrive and how they feature, but a special mention should be made to Candida paronychia, intertrigo, and onychomycosis. These are fairly difficult to treat and they take much longer to actually heal. Dermatophyte infections are very common in the Indian setting with all the sweating, uncontrolled sugars, and poor hygiene. Again, these are very common in the skin OPD. Bacterial infections may not be as common, but worthwhile knowing because they need to be differentiated because the treatment will depend on the same. So in summary, diabetes is a systemic disease with manifestations affecting every organ system. We know that. Skin lesions or manifestations may be a marker for underlying metabolic complications, pre-diabetes, or a forerunner to diabetes itself. It's important to ask leading questions about skin diseases and infections and either test, treat, or even refer to the correct physician for the same. Investigations for a thorough evaluation of skin conditions as systemic implications are far-reaching. And early detection and consistent glycemic control are key to preventing complications with skin disease. These are the references I used. Thank you very much.
Thank you, madam. The questions will be at the end of the next two speech. I now invite Dr. Usha Ayagari to have the next topic, monitoring of blood glucose levels, time in range, and self-monitoring of blood glucose. Over to you, madam.
So, I was given this topic, monitoring. Now, we all do it. We monitor because we need some metric by which we can talk to our patients, educate them, and make changes to their treatment. HbA1c has long been accepted as the gold standard for monitoring for the last 2 to 3 decades at least, but we know that it comes with several limitations. We know that ethnically, for example, we have differences, hemoglobinopathies, anemia, pregnancy, other comorbidities can all affect your A1C levels. And we also know that A1C is a very coarse metric, day-to-day fluctuations, hypoglycemia, these things aren't picked up by A1C. So what next? We progress to SMBG, these self-monitored blood glucose levels. They're very good because it allows you to interact with your patients and it allows people with diabetes to take control. They get real-time data and they can actually promote behavioral changes as well as improve their understanding of the diabetes, of their own diabetes. Equally, it helps us look at patterns, make an assessment of their glycemic control and encourage them to optimize therapy. We can do it intensively, moderately, or low intensity. But the point of monitoring is to make sure that we get enough information to promote a dialogue with our patients to help us bring about behavioral change and change in therapy. A value that's not looked at, a value that's not leading to some kind of a change is of no value to either us or to the patient. So please look at their books when they bring in their monitoring. However, SMBG comes with limitations. Any one reading gives you a snapshot, but what you really want is the full movie of the whole day, which an SMBG doesn't give you. If you look at these readings, you might think, not bad, right? Nothing's too bad, maybe the dinner time one looks a little high, but actually it doesn't tell you the full story. What you may not see is that one of those readings was on the way up, one of those readings was on the way down to a hypo, and this whole detail of what happens in between the readings is missed. You can have the same A1C by having fluctuations this big. Remember, 40 to 120 will still average out to 80, or you can have the same by having readings between 80 to 120 averaging out to 100. So you can get to the same reading having huge fluctuations, also called glycemic variability, with troughs, hypos, and peaks, hypers that are unpicked up, or you can get them with a much narrower band like that. Okay, hang on. Okay. Never mind. So, a narrower band like that. The contribution to the A1C can all be within range, or you can have an average because of readings that are much above and much below. And this is the concept of time in range. How many of your patients' values are actually riding in a band where you think their control is good and optimal for their care? Guidelines have developed over the last decade, a little over a decade, to the point where we now have this concept of a time in range, the percentage of time we want any one of our patients to spend in that range, and what we define as time above and time below range. Broadly speaking, we must individualize the time in range to every patient, but broadly speaking, for type 1 and type 2 diabetes, we consider a target range of 70 to 180 for most people to be in range. Elderly, more vulnerable people with comorbidities, maybe you might accept either a narrower range or less time spent in range. So the time in range is two factors: the value of the blood glucose and the amount of time that you spend in that. So you can relax the time, you can relax the range. Whereas in pregnancy, you really want to tighten up both. You want the pregnant woman to spend much more time in a range that is suitable to guarantee good outcomes for pregnancy. And pre-pregnancy planning, type 1 diabetes, the ranges can be set. If you acknowledge that there is an ideal time in range, then we have two things. There are always going to be readings above range, there are always going to be readings below range. So this is time above range and time below range. Again, you individualize it to the patient, to the condition, and to their particular vulnerability and their clinical outcomes. However, the priority is always going to be to minimize time below range first and then fix the time above range. So always get rid of the hypos first and then work on the highs. And again, this must be individualized, especially for the elderly or vulnerable population. The time below range should be less than 1%. Remember that when you're looking at 24 hours, even 1% of that is a good 14 to 15 minutes. So spending a hypoglycemia of 15 minutes is significant for a vulnerable patient. Time in range correlates really well with HbA1c. I'm okay for time. Really well with A1C, and an approximate 10% improvement in time in range translates to an approximate sort of 0.5% improvement, 0.3 to 0.5% improvement in your, 0.8% improvement in your A1C. This is significant because when you're looking at patterns that are wildly fluctuating, you don't need to firefight on every single front. Supposing you have a postprandial excursion that's high, fix that after lunch. Fix that after dinner. That 2 hours that you improve is a 10% improvement in a day. Out of 24 hours, you improve one postprandial reading. That's a 10% improvement, and that will improve your A1C by about 0.8. The reason this is important is because we've started understanding over the last decade or so that improving time in range, both in type 1 and type 2 diabetes, has a significant improvement in terms of outcomes. So look at somebody who spends 60% of their time in range versus 80%. And remember, this 20% is probably just literally fixing maybe an after lunch and an after dinner excursion. 2 hours here, 2 hours there. That will be a 40% improvement in your time in range. And that will take your myocardial infarction from 3.3 to 2.3, for example, your risk of end-stage renal disease, visual loss, and amputation. So every single metric is improved by improving your time in range. We know that for every 10% that you can improve your time in range, the risk of retinopathy decreases by 64%, nephropathy by 40%, and neuropathy by 25%. So every single 10%, every 2-hour window is worth fighting for. How do these compare? An A1C is a broad brush stroke. It gives you an idea of how the particular individual is doing over a period of time. It's very well validated. This is the metric used in most of the clinical studies, and the A1C isn't going anywhere. We're going to be using the A1C for quite some time to come, and we are still aiming to titrate treatment to an A1C. However, this SMBG and time in range, especially when deduced from either a 7-point to 8-point SMBG or from a continuous glucose monitor, give you much more granularity. Even within that granularity, the SMBG is like a series of snapshots. Think of it as a series of snapshots that you can try to link up to make a story. However, The CGMS derived time in range is the full movie. You're getting the full 24 hours, usually for about 15 days, 1 week to 15 days. So within these two metrics also, you get a much greater degree of granularity depending on which metric you choose. The utility of both these is that they can give you in real time an idea of what that person's control is at any given point of time, and therefore it will allow you to make changes in real time to adjust treatment or change behavior. So this is the full video. Maybe SMBG can be a TikTok video, and the HbA1c is just the movie poster, if you will, that you see once every 3 months. So I think, oh yeah, I'm in time and I'm going to stop here. So monitoring in a snapshot. Thank you. My time in range, I'm working. Yes, thank you.
Thank you, Dr. Usha. We'll take up the question at the end of the session. We go to the last topic, and again, I invite again Dr. Kumaravil, who will be talking on very important topic, beta cell regeneration.
Good evening, my dear friends. And the topic which I am going to discuss now is on beta cell regeneration. I think this has been a long-standing dream for any diabetic patient. And to understand beta cell regeneration, I think we have to understand two more concepts. One is your beta cell differentiation. How exactly is a beta cell is formed? So beta cell differentiation, basically your pancreatic beta cells, they originate from your embryonic stem cell through a complex of cellular processes which is termed as differentiation. And this process basically involves very coordinated and tightly controlled activity where you have activation of certain gene clusters and repression of certain gene clusters. For example, when you try to look at your stem cell, next you have a definitive endodermal cells, then you have a pancreatic multipotent cells which can in turn differentiate either into ductal cells or your acinar cells, or which could again differentiate to pre-endocrine cells. Then you have a beta cell, alpha cell, delta and polypeptide cells. Now as they differentiate, what happened, many of these gene clusters are expressed and some of the gene clusters are repressed. So in de-differentiate, what happens, some of the gene clusters which are supposed to be repressed becomes expressed. So one, we should try to understand what is beta cell differentiation. Second, we should try to understand what is a beta cell dynamics. So the beta cell dynamics is basically a balance between your beta cell expansion and your beta cell loss. Your beta cells could expand or could multiply either by replication, or you can have a neogenesis where you can have new beta cells formed from a precursor cell which could be beta or non-beta cells. Your beta cells could hypertrophy, which is commonly seen in obesity or pregnancy, which could be a physiological increase in your beta cells. Your beta cell loss, initially we thought cell death or apoptosis is the beta cell loss, but sometimes what happens is your beta cell fails to function. Your differentiated beta cells becomes a beta cell de-differentiation. So these are the target of cell which could really help us in regenerating a beta cell. It is very difficult to regenerate a beta cell from a death or apoptotic cell, but it is definitely possible to make your de-differentiated cells to regenerate again. So with your basics of beta cell differentiation and beta cell dynamics, now let's try to understand why is that you have a type 2 diabetes, or what is the pathogenesis of diabetes mellitus. You have a glucose which acts on a beta cells to cause insulin secretion. When you have a insulin resistance, your beta cell compensates by secreting more and more of insulin. But as your beta cell dysfunction sets in, your beta cell is not able to compensate for the degree of hyperglycemia and you develop diabetes. And we thought once when your beta cell dysfunction sets in, it undergoes beta cell apoptosis. So your normal beta cells become a challenged beta cell, then it becomes a dysfunctional beta cell, and then it became a dead beta cell. So the change of beta cell mass in type 2 diabetes or type 2 diabetes beta cell apoptosis, which led to beta cell loss, could be related to hyperglycemia, what we call as glucotoxicity, which could be related to amyloid deposition, or which could be related to oxidative or endoplasmic reticulum stress, or your inflammatory cytokines, which again could destroy your beta cells. You can have a dysfunction or autophagy of the beta cell, you can have a lipotoxicity. There are several studies which have reported that the beta cell masses decrease to at least 30 to 50% in patients with diabetes. Now here is the catch. We know in type 2 diabetes or any diabetes to manifest, 90% or at least 80% of beta cell function has to be lost. But when you try to look at the beta cell mass, only 50% of the beta cell mass is lost. So which means there are still 30 to 40% of the beta cell mass is remaining, which is not functioning properly. Now these are the beta cells we are trying to target for a regeneration. Now when you try to look at your extended pathogenesis of your diabetes, so initially we thought beta cell apoptosis, but after the number 4 we see there is another path where you have loss of insulin content and mature beta cell identity. So your beta cell could de-differentiate, or a beta cell could have trans-differentiated to alpha cells or delta cells, or beta cells could have just degranulated, lost its identity and just simply sitting. Now these set of beta cells you can try to manipulate or modify with a gene therapy, transcription factors or various pharmacological therapies. We know there has been some data in GLP-1 analogs which helps in beta cell regeneration. We have data on DP4. Now recently we had data on dapagliflozin also, which can cause beta cell regeneration. So we are trying to redifferentiate or regain this mature beta cell identity. Now having said this, what exactly is your beta cell de-differentiation? We have seen what is beta cell differentiation before. Beta cell de-differentiation is nothing but your mature beta cells, they lose to the various degrees their differentiated phenotype. So once when they lose their differentiated phenotype, they lose their cellular identity and they regress to a less differentiated or a precursor like state. So this concept of de-differentiation has been proposed apart from cell death, which is going to contribute to your loss of functional beta cell mass, but still your beta cell mass is persisting. Now this is the beta cell mass which we are trying to improve. So the process involved in de-differentiation is that, as I said before, there is down-regulation of the beta cell enriched genes. There is upregulation of genes which are supposed to be suppressed in the primitive cells, and there is upregulation of progenitor cell genes. You have various genetic markers which suggest whether your beta cell could have regenerated or de-differentiated. So ultimately what happens, this alteration or your phenotypic reconfiguration of beta cell ultimately results in defective insulin secretion and loss of beta cell identity. So when you try to represent the whole thing pictorially, you have a normal beta cell. In cellular stress, it becomes a dysfunctional beta cell, then it becomes a de-differentiated, degranulated or trans-differentiated. So these are the pools of beta cell which are still viable but which are not able to secrete your insulin. So apart from your de-differentiated transmitted beta cells which could be regenerated, the other possible mechanisms for beta cell regeneration: one, you try to improve the micro environment in which your beta cell is surviving. You try to reduce the inflammation, you try to use some immunomodulators. You can have in vitro regeneration protocols where you take pluripotent stem cells or stem cells which could be differentiated with the stimulus of ascorbic acid, zinc sulfate, GLP-1, various stimulators which could be done in vitro and then transplanted. You can regenerate it from an intrapancreatic cell where you can regenerate your beta cell from an acinar cell. You can regenerate your beta cell from ductal cell. You can regenerate from exocrine progenitor cells. And you can also try to trans-differentiate alpha cells to beta cell and your delta cells to beta cells. So this is regeneration in intra-islet, regeneration in intrapancreas. You can also trans-differentiate your intestinal cells to have a beta cell, because all these things, they more or less have a common lineage of differentiation. So whether you have drugs, we have diabetic kinome inhibitors, which are nothing but protein kinases that control and regulate protein functions involved in diabetes. And this kinome inhibitors has been tried in various illnesses, and one such is it has been shown to restore a beta cell. We have growth hormones, we have meganin, which again tries to regenerate beta cell. Of course, these are mostly in rodent models. We have very less data in human models. So other strategies to induce beta cell replication is that you have various cyclin D2, you increase a EZH2, there are senolytic therapies, you have glycolytic flux and glucokinase activators, adenosine kinase inhibitor, you can silence certain gene, you have hormone, you have serpentine, you have various drugs which has been studied not only in rodent models and also in human islets. We have data of human islets which are studied for beta cell regeneration with serpin B1 and other things. But in spite of so much data on beta cell replication, this regenerated beta cells should function properly. but we have lots of challenges in making the regenerated cells function properly. So you have various avenues to restore the function in regenerated beta cell, and one such hypothesis is that we are not able to balance the beta cell heterogeneity. What exactly is the beta cell heterogeneity? You try to look at various beta cell. When you try to stain your beta cell with insulin granules, some beta cells could stain high, some could stain medium, some could have a low. When you try to look at activity pattern in a beta cell, again you have various space setting. One beta cell could be a front runner, other beta cells could follow. You have various cell markers in beta cell which could vary, protein clusters. So unless you have a heterogeneous beta cell, the function is more efficient. When it is homogeneous, it may not function well. It's something like in a hospital, you have all specialists alone, your hospital may not function properly. You need a pool of, you need paramedical, everything to support. Similar way, if you lose your beta cell heterogeneity, it may not function adequately, though you are able to regenerate your beta cell. Second challenge in making the beta cell function is we are not able to balance the islet architecture. More than beta cell, your islet architecture is very, very important. Your blood supply, neuronal supply, where your alpha cell, delta cell, beta cell linkage is very important. We are not able to really restore these things. And you have problem in glucose sensing mechanisms. So all these things, though we are able to regenerate, we are still not able to conquer or make your regenerated beta cells function adequately. So this is my final slide. It is now established that impaired beta cell function in type 2 diabetes cannot be accounted for increased apoptosis alone. There are some dormant beta cells, or I would call hibernating beta cell, or dedifferentiated beta cell, which are still in your beta cell. Beta cell dedifferentiation may enable conversion towards other pancreatic endocrine phenotypes, and prevention of dedifferentiation or redifferentiation can be a potential therapeutic tool in regeneration. And this initial stages of diabetes is very, very critical in preserving the beta cell. What they say is within 6 years of onset of diabetes, your beta cell, you have still dedifferentiated beta cells which are alive, and if you are able to reduce your weight, control your blood sugar, there's all probability of regenerating your beta cell. There's nothing like regenerating your native cells. Any artificial regeneration, then functioning becomes a problem. I think I'll stop with this, and thank you so much.
Thank you, Dr. Kumaravel. I think the organizers are really disturbed that we are going beyond time. So we'll close this session now. On behalf of all the chairpersons, Vijayakumar, I can take that liberty.
If the evidence is not challenged, that is not admissible.
You
Bring at least physicians. You bring a study, maybe pharma alone is not the decisive, shouldn't be the decisive factor. Where is that girl? She just disappeared. And I would rather say academic conspiracy. You conspire with them and make sure that.
We had come on, Karnanidhi, you know me for the last 35 years.
But either you are provocating and this is very biased and academic conspiracy.
Your point is well taken, Dr. Karnanidhi. We have known each other for 35 years. I know you, you know me. Okay, thank you very much. Anyhow, in case you have any discussion, you can always have it in a private. We are running out of time. That is the only reason. We are running out of time. Okay. Thank you. Anyway, thank you very much, Dr. Karnanidhi. On behalf of all the chairpersons, I thank all the speakers. It was an excellent session. Thank you very much.
We'll be having another very interesting session, something new concept that's called Jugalbandis. Jugalbandis is nothing but two speakers will be speaking the same subject in conversation. So there are two topics, and before that I have great pleasure and happy, and also I am taking it as a pride to honor some of our great contributors to the field of diabetology from our city. So I take in pleasure and inviting them as well. May I call Chandru? Chandru, come.
Action in Western sector during the 1971 Indo-Pak War. From 1978 to 2005, he has served in Tamil Nadu Medical Service in various capacities until he retired as head and professor of the Department of Diabetology at Madras Medical College. Dr. R.S. Hariharan has established the Pregnancy Diabetes Service at Government Kasturiba Gandhi Hospital for Women in 1995, the second of its kind in the country. He is a popular invited speaker in CMEs organized by various professional bodies like API, IMEA, Diabetes Association of India. He has received numerous honors, including the Dean's Commendation Certificate from Dean of Madras Medical College in 2001 for the services he rendered, and the Eminent Professor Award from the Association of Physicians of India, Chennai chapter in 2001. He was also awarded the prestigious Nalgoda Award by the RSSDA for his contribution in the field of cardiodiabetology in 2011. He has received the Mentor Award for his exceptional service to the field of medicine and diabetology in 2013. He was awarded the Primer Award for the 50 years of contribution to medicine, diabetology and cardiology at Debate Conference in 2020. The Economic Times presented him with the Eminent Diabetologist Award on Doctor's Day in 2021. It's indeed a great pleasure for the organizing team of 3DCon 2023 to present Dr. C.V. Krishnaswamy Award to Dr. R.S. Hariharan during 3DCon 2023.
Next, we would like to present the award to Professor A. Sundaram.
The organizing team of 3DCon 2023 have immense pleasure in awarding the Dr. C.V. Krishnaswamy Award to Dr. A. Sundaram. He has joined the government service in 1971 and served in various distinguished positions for 40 years. He has completed his MBBS at Stanley Medical College in 1970 and he did his MD at Madras Medical College in 1979. Between 1979 to 1994, he has worked as a first assistant professor to Professor V. Seshaya at Madras Medical College. He was the first professor and head of Department of Diabetology at Dr. Ambedkar Institute of Diabetes at Government Kilpack Medical College and Hospital from 1994 to 2004. From 2006 until the present, he has served as the course director of the American Diabetes Association approved clinical training program for healthcare professionals at the Coimbatore Diabetes Foundation. He was crucial in obtaining free insulin for juvenile patients in Tamil Nadu in 1998. He has launched the country's first diabetes nurse educator course at Kilpack Medical College, Chennai, and this nursing training course is the first of its kind in Indian government sector. With the assistance of World Diabetes Foundation, he has established the first preventive foot care clinic, which was inaugurated by Her Highness, the Princess of Denmark at Kilpack Medical College in 2004. He has screened diabetic retinopathy to around 10,000 diabetics at Kilpack Medical College. He has served as the guide for postgraduate dissertation and PhD thesis, and he has presented with Professor M. Vishwanathan Gold Medal Oration, the Kummedcon Gold Medal Oration, Dr. K.V. Thiruvengadam Oration, Professor Sam G.P. Moses Oration, and Dr. V. Balraman Oration by Diabetes Club. He has written books and chapters on insulin therapy in diabetes, eye, kidney care, diabetes foot care, and earned the Government of Tamil Nadu Award in 1991 for his contribution. He is an expert committee member for the Forum of Injection Technique and Therapy Expert Recommendation, FITTER, India, for the best practices in insulin injection technique. It's indeed a great pleasure for the organizing team of 3DCon 2023 to present Dr. C.V. Krishnaswamy Award to Dr. A. Sundaram.
Now may I request Dr. Vasant Kumar from Hyderabad, please come over, sir.
The organizing team of 3DCon 2023 have immense pleasure in awarding the C.V. Krishnaswamy Award to Dr. C.H. Vasant Kumar. He has graduated his MBBS from Kakatiya Medical College, Osmania University in 1975 and did his MD General Medicine from Gandhi Medical College in 1981. He is currently employed as the Senior Faculty and Examiner at Madras City, India, and also as a Senior Consultant in the Department of Internal Medicine and Geriatrics at Apollo Hospitals in Hyderabad. Since January 1994, he has been involved in postgraduate medical education and clinical training of the DIPN-B candidates in internal medicine. Since 2015, he has been involved in the training and mentoring of the medical graduates undertaking the fellowship course in diabetology at Madras City. In association with Royal College Liverpool Academy, he has received the Rotary International Award for Polio Eradication in 2019, as well as the Best Physicians Award from the Senior Citizen Forum in Hyderabad in 2016. He has held various posts, including the President of the RSSDA from 2021 to 2022, the past Chairman of the APA Hyderabad chapter, and the past Chairman of the RSSDA Telangana State. He is quite active in community activities, and he is the founder and president of the Diabetes and You Society, which has been supporting children with type 1 diabetes since 2000. He is also the past president of Rotary Club of Jubilee Hills. He is currently the chairman of the Rotary International, and he has held several health awareness and diabetes screening camps in rural areas and government schools throughout the Telangana state, India. It's indeed a great pleasure for the organizing team of 3DCon 2023 to present Dr. C.V. Krishnaswamy Award to Dr. C.H. Vasant Kumar.
May I now request Dr. S. Venkatraman to please come on to the dais, please.
Please, sir.
Before I received this award, I was telling Viji, we are all part of this 3D. It's something like you're utilizing a forum to give the award to yourself, but as usual, he convinced me till I got convinced.
The organizing team of 3DCon 2023 have immense pleasure in awarding Dr. C.V. Krishnaswamy Award to Dr. S. Venkatraman. Dr. S. Venkatraman has had remarkable academic career with notable achievements and contributions to the field of diabetology. He has earned his MD in General Medicine from Madras University in 1984 and since held numerous important positions in prestigious institutions. From 1984 to 1998, he was an assistant professor of diabetology at Madras Medical College, where he made substantial contribution to the diabetes research. He is currently a senior consultant diabetologist at Apollo Hospitals in Chennai. He was also a former professor of diabetology at Madurai Medical College from 1998 to 1999. He has served as the visiting faculty member and consultant at Sundaram Medical Foundation. His deliverance and a lecture has had numerous and significant impact on the careers of many aspiring physicians and diabetologists. His commitment to education and to teaching excellence has garnered him the reputation as distinguished postgraduate teacher. He is a prolific researcher and has been active in evidence-based research on endocrinology with a special emphasis on diabetes. His research on pregnancy and diabetes as well as his clinical trials on standard diabetes treatment have received great praise from his peers in the medical community. He has also acted as the primary investigator in worldwide clinical studies, mostly on glimepiride, glycoside, inhaler insulin, showcasing his skill in cutting-edge research. He has also contributed significantly to the medical literature with multiple publications published in prestigious journals such as JAPI and RSSDI. He has also co-authored chapters in diabetics books written by Dr. B. Seshaya and Dr. G. Sainani, demonstrating his breadth of knowledge and skills in discipline. His contribution to the area of diabetology have been recognized with various accolades, including the IDF Award from the IDF Federation at 13th IDF Congress held in Washington in 1991 for his work on pregnancy and diabetes. He has also received the Indian Medical Association's Lifetime Achievement Award, further solidifying his position as a respected specialist in his area. It is indeed a great pleasure to the organizing committee of 3DCon 2023 to present the Dr. C.V. Krishnaswamy Award to Dr. S. Venkatraman.
May I please call upon Professor Anand Moses to come onto the dais. I would suggest these are the legends, and of course Dr. Madhavan also is going to come next, has been instrumental in shaping us, not only me, many people like us, in many things, not only in diabetology, in practice and everything. So it's a great thing. I thought we'll do it this evening. Dr. Anand Moses.
The organizing committee of 3DCon 2023 have immense pleasure in awarding the Dr. C.V. Krishnaswamy Award to Dr. C.R. Anand Moses. He has finished his MBBS in 1980 and did his MD in General Medicine from Madras University in 1983. He is a member of International Medical Sciences Academy, the Royal College of Physicians and Surgeons at Glasgow, and the Indian College of Physicians. He has received numerous honors, including the Best Doctor Award from the Government of Tamil Nadu at Government Kilpak Medical College and Best Doctor Award from the Dr. MGR Medical University. He has published over 50 reviewed papers in national and international publications. He has served as the Director and Professor in the Institute of Diabetology. He was also the former Professor and Head of Department at the Dr. Ambedkar Institute of Diabetes at Government Kilpak Medical College. He was the organizing secretary of the 40th National Meeting of the RSSDA held in Chennai in 2012 and the organizing chairman of the 50th Golden Jubilee National RSSDA held in 2022. With more than 30 years of teaching experience with both UG and PG students, he has been the PhD guide for the Tamil Nadu MGR Medical University, Chennai since November 2007. He is the recipient of Lifetime Achievement Award from the Chennai Chapter APA in 2022, and it's indeed a great pleasure for the organizing team of 3DCon 2023 to present the Dr. C.V. Krishnaswamy Award to Dr. C.R. Anand Moses.
May I call upon, last but not the least, Professor R. Madhavan.
The organizing team of 3DCon 2023 have immense pleasure in awarding the C.V. Krishnaswamy Award to Dr. R. Madhavan. He did his MBBS in 1979 from Chengalpattu Medical College and pursued MD General Medicine in 1983 from Madras Medical College. He has rendered its services for the Tamil Nadu government from 1983 to 2014, and he has held various posts such as Assistant Professor of Diabetology from 1984 to 2006 at Madras Medical College, Professor of Diabetology, Government Stanley Medical College from 2006 to 2011, and Professor of Diabetology, Dr. Ambedkar Institute of Diabetology Government Kilpack Medical College from 2011 to 2014. Professor and Director and Institute of Diabetology, Madras Medical College. He has 30 years of teaching experience for both undergraduate and postgraduate medical students. He is a life member of RSSDA National and Tamil Nadu Chapter APA, Diabetes Association of India, National Faculty for the Public Health Foundation of India. He was chosen as the examiner in Dr. MGR Medical University for various courses in diabetology, and he is a regular faculty in state level and national level CMEs and conferences. He has organized several CMEs and seminars in diabetology. He has authored more than 25 peer-reviewed journals. It's indeed a great pleasure for the organizing team of 3DCon 2023 to present Dr. C.V. Krishnaswamy Award to Dr. R. Nagar.
require GVK's permission to say that a couple of words about Professor CVK for such those who do not know him, and then probably on behalf of all of us, Professor Hariharan will thank Dr. GVK for the honor bestowed on us. Professor C.V. Krishnaswamy was a great physician, diabetologist. In fact, he was instrumental in starting the Diabetology Department Voluntary Health Services Center, if I remember right, and then mentored many stalwarts like GVK, Srivats, Dr. Jayasubramaniam, etc. I'm not talking about his academic aspects. He was a gentleman par excellence, and then he was so good in English as well as the subject. A couple of instances I'll tell you. In 1988, we had the Diabetic Association annual meeting in Bhopal. I think Madhavan will remember it better for the various other aspects. Professor Seshia and Professor Krishnaswamy were supposed to give a talk on pregnancy and diabetes. Unfortunately, Dr. Seshia couldn't make it. Last minute, I was sent to do the lecture along with Professor CVK, a doyen. So I was very scared. Before the start of the presentation, I just went to him. I just said, "Sir, I'll speak first, you'll speak." He said, "Thambi, don't worry at all. Treat me like a normal person." The comfort that he gave, remember in 1988, because I was talking opposite to a stalwart in the field of medicine and diabetes and was so well versed in English. Second is, I think, Vijay and Anand will remember, it was in 1991 in IDF, wherein he was there. See, Vijay does conferences, we have a sumptuous lunch, sumptuous breakfast, and look for dinner. When you go to an international conference, at least now in EASD you have the lunch. So that was my first major conference across, outside India, it was in US. So around 12:30 we were all feeling hungry. We were just looking for the lunch coupon or where the lunch will be served. There's no lunch. So he said, go to this stall, there will be some pastries, go to this stall, there will be some bread and sandwiches, some coffee. It was just he knew, see, these boys are so raw, they are anticipating some formal food to be served for the lunch. Second is, at that point of time, honestly, that particular trip I made because of Professor Asia, because there was an award of $1,000, which was adequate for my trip. Money was too good for anybody for that matter. There was one company which was marketing a cream for foot. You know how much we paid for a 10 minutes interview? $150, 1991. See, he called up everybody from India, go to that place, they'll ask some questions, answer that, collect $150. I mean, these are some small things. He takes care to see to it that everybody is comfortable. Great man.
Ladies and gentlemen, I would like to add a word or two about Professor CVK, because my association with him 10 years longer. So the first time, to tell you very frankly, the first time I met Professor Viseshia is not here, you would be able to attest to what I say. We fought over hemoglobin A1C, because he was, we were the first to bring in hemoglobin A1C in government setup way back in 1980. And we had a discussion on hemoglobin A1C in, I forget the name of the hotel, right opposite Egmore station. And yes, and we all had a discussion. Sundaram was there, I'm sure. Dr. CVK came out with some ideas. We had our own ideas. We said, discuss something. And ultimately, we realized the problem in hemoglobin A1C, difference in different laboratories was because the laboratories were not air conditioned. Unless your laboratory is not air conditioned, the hemoglobin A1C by the column method cannot be right. Now that we brought out at that time because there was a lot of difference of opinion about hemoglobin A1C at that time. After that, any number of times we have interacted with him. He has invited us to voluntary health services hospital. And as far as diabetic foot was concerned, Dr. N.S. Murali and Dr. CVK were the two sides of a coin. Whenever a discussion on diabetic foot syndrome was there, he would talk about the medical aspects, and Professor Dr. N.S. Murali, to my mind, is the father of diabetic foot syndrome as far as surgical aspects are concerned, as far as the city of Madras is concerned. He is no more there now, but he was the one who more or less brought out the idea of mid-plantar space infection and how one should cut open in the plantar aspect. Anyway, there are very many things I can talk about Professor CVK because I have been terribly associated with him in and outside, both professionally and personally. As Dr. Venkatraman made out, he is one of the best persons you can think about, both he and his wife, and they are very good, should I say, a very good couple who would invite anyone home and be friends with. Anyway, that's a part. So it's indeed a pleasure for each and every one of us here to receive a name, receive an award that stands in his name. And I should congratulate Dr. Vijayakumar for establishing this award more than anything else. It may look odd that half a dozen people get it at the same time, but I take it that is for the previous years as well. So, so that every one of us is aging after all. So it is nice to get it while you are alive rather than posthumously. So having said that, I should thank the organizing committee of the 3D conference for choosing the 6 of us for giving this award. And it's a large heart. First, I must say it is a large heart for anybody's on anybody's part to recognize the contemporaries, because nothing is more, should I say, nothing is more important than being recognized by your contemporaries. I think that is what is more important. Every one of us, on and off the stage, knows that what one is worthy of, what one has contributed, what one is doing. But when it comes from the organizers, it does mean something to all of us. I thank Dr. Vijayakumar, his team, and Dr. Chandrasekhar for this honor. Thank you very much. Thank you.
Good evening to all of you. I am the had oldest association with Professor CVK when I was a third year student at Stanley Medical College under Professor M.V.'s unit. He used to come to the ward like this, half shirt, white shirt, and well dressed. He was very handsome, but very strict in rounds. He will ask for urine examination, sugar and BP. You have ruled out two major diseases, diabetes and hypertension. And any infection or anemia will have to do peripheral smear. Without that, third year student cannot escape. We have done within 15 minutes infection through urine examination, and then many a times he has shown us leukemia slides. And then he will take us to ward rounds. He will discuss each and every case thoroughly. May take 2 to 3 hours. Only once or twice in a month. And he will take us to canteen. That's very good of him, to provide tea and biscuits or whatever we want we can take. That is at Stanley. At monthly meet, we used to pay 10 rupees for journal club meeting at Dasapragash. And we used to argue with him for many things. He was very vehement, but always, as Hari said, he will come settle down later. And then people should know that he was the only Indian who represented World Diabetes Food Foundation as a representative from India. Core member who made recommendations. And then he invited me to come to voluntary health services and shown me the register, type 1 register. In those days, 1967 to till my retirement, I had association with me even after that. And then through patients also we had. In one pregnant woman, you put the patient on diet, fetal wastage. When she came to GH, I put her on insulin, small dose, 5 to 10 units, she delivered a baby. Next visit, patient went to him, she was put on diet, fetal wastage. Then I put her on insulin. Then she went and told him, and he spoke to me, very gently appreciated. That is a very rare quality. And then he's a man against metformin from those days onwards, one should know. But sometimes he used to prescribe that. And he always, as others said, cordial to us outside. In rounds and discussions, he was very strict. And we used to appreciate his handsomeness and his dress and timing. Being an honorary physician, used to come from his residence near Adayar to Stanley on time. That is the best quality I have learned from him. Thank you very much.
that is Jugalbandi, that is session 6. May I request Dr. S. Venkataraman sir to remain on stage? Can I call upon Dr. Aarti Kannan ma'am to come on stage too?
Been a delay of 15 minutes, or 20 minutes rather. So we'll try to catch up. I think before without wasting much time, we'll straight away go to the Jugalbandi again, which is one of the favorite part of the agenda of any scientific meeting that you organize. Sir, we should have a Jugalbandi. That's always because two speakers speaking in tandem on the same subject with the same thought, or sometimes slightly different. I think Dr. Shekhar is going to do the Jugalbandi along with Vijay. Rajesh Rajput. Yeah.
Yeah.
So,
Rajput and
first is Rajesh. Yeah, of course. In fact, Rajiv is a very, very familiar face for all this Jugalbandis, along with his friend Chawla. Today, Manoj I don't see here. Now, just a couple of points before I hand over the Jugalbandi to you. I think we are, at the present day juncture, we are talking about a multi-centric approach in the management of diabetes, but still we should not forget the glucocentric aspect of the multifactorial intervention. So when I say glucocentric, all molecules work in most of the diabetic subjects. So, in fact, we have been practicing, I think Professor Hari, Sundaram and all of us, Madhu, Anand. So we have been practicing diabetes when there was only glibenclamide, glipizide, metformin, and animal insulin. Now we have a variety of molecules in the oral space as well as in the injectable space, and we have not only the molecules, we have the science. The science backed up by the data for the individual molecules as well as by the strategy. So combining these information, we are going to have a Jugalbandi by Dr. Rajesh Kovil. Can I have his introductory slide? And Dr. Rajesh Rajput. So to talk to us about choosing the right combination. Yeah, it is the right combination for the right patient at the right time. Yeah.
Thank you, Dr. Venkataraman. Can we have the slide projection? Right. So good evening, friends. Well, this is Jugalbandi, and we does not have made any formal slides. So we will show you only one slide, and we will like you to be involved along with us, and we both are discussing a case and also interacting with you. So this is a real world case. All of us see such type of type 2 diabetes cases in real world practice, and we manage these cases differently based on our own understanding of diabetes. So today we are going to show you a case, 55-year-old gentleman, known case of type 2 diabetes from last 10 years, BMI of 29.5 kg per square meter body surface area. Patient has some comorbidities in form of hypertension, dyslipidemia, urinary albumin was measured, it is 56 milligram per gram, which means microalbuminuria range. Patient has an eGFR of 73 ml. Family history of premature coronary artery disease is present. Fasting plasma glucose is 170, postprandial glucose is 210, HbA1c is 8.6%. Patient is currently receiving glimepiride 4 milligram twice a day, metformin 500 milligram twice a day, tablet amlodipine 10 milligram OD, and atorvastatin 10 milligram OD. Me and Rajiv, my friend, this patient is concerned and how to alleviate the concern of this patient. And in front of you, you have history, physical examination in brief, and the treatment which this patient is receiving.
So Rajesh, first important thing is that one, this patient is very fortunate. Usually you have to pay for second opinion, and this patient is going to get 100 second opinions without paying. So that is number one. So Jugalbandi, as GVK started, is about dialogue, deliberation, discussion, and we're going to have discussion with you also because this is a case scenario. So my first question to Rajesh is that why is this patient on 8 milligrams of glimepiride? How many of you all go up to this 8 milligram of glimepiride? Yes, Dr. Karnadi. Absolutely. So this is Rajesh's.
I'll come to you. See, whenever we see a patient, although we often discuss guidelines, I always said in the conferences, although we as an Indian, we are very fond of discussing guidelines, and probably in diabetes there are more than 50 guidelines, but we do not practice guidelines. So this is the reality number one. So please practice what we discuss. Now when we see this case, there are many important things historically and clinically when we are going to decide treatment of type 2 diabetes which we should take into consideration. 55-year, type 2 diabetes, duration of diabetes. While writing prescription, we never pay to the duration of diabetes. He is a known diabetic from last 10 years, and nobody on this earth with certainty can tell that onset of type 2 diabetes, which means it might be 15 years also. So duration of diabetes is very important when you are choosing therapy. Second important point, BMI of 29.5. As per Southeast Asian consideration, he is obese individual. So when you are going to choose therapy, take into account obesity. Because we often ask very casually to all our patients, vajan kam kar le, vajan kam kar le. I am speaking in Hindi, weight kam kar le, weight kam kar le. But unfortunately, we write drugs which causes weight gain. And patient is frustrated. So we have to find out the reason for weight gain. Third, patient has number of comorbidities, hypertension, dyslipidemia, microalbuminuria. So patient has already established diabetic kidney disease also. And there is a family history of premature coronary. Now, so all these things should be taken into consideration when we are going to write prescription, right patient, right drug. That is a basic motto of this Jugalbandi. And now Rajiv has asked me 4 milligram BD.
Yes, why 4 milligrams?
So if you see pharmacology, there is a beautiful diagram. At half the maximal marketed dose of all sulfonylurea, there is a plateau. 80% of the clinical benefit of sulfonylurea comes at half the maximal marketed dose. For glimepiride, we often see even prescriptions of 4 milligram thrice a day. Now here it is 8 milligram is a maximum DCGI permitted dose for glimepiride. Permitted dose, which means at 4 milligram, 80% of the effect of glimepiride has already come. So there is no point in writing dose of glimepiride more than 4 milligram, although we commonly say 6, 8 and even 10 milligram. So I think
Rajesh, the second thing, why twice a day?
There is no point in writing, first of all, a dosage of more than 4 milligram once a day, because glimepiride is a long-acting sulfonylurea, and number two, BD does not make any case. But then Rajiv, we sorted out glimepiride 4 milligram OD, best possible dose, but then this patient glucose is not under control.
True.
And so now we have so many different class of agents. So based on the history which I have told you, based on the physical examination, comorbidity, how will you go about changing his anti-diabetic medications?
So important to realize that this patient is not our garden variety of patients, and fortunately or unfortunately majority of our patients are like this, where there are underlying risk factors, heredity has loaded its gun, there are modifiable, non-modifiable risk factors there. He's got 4 risk factors, HbA1c is high, he's already on a statin, he's on a CCB, which we can again discuss. So now at 8 milligram glimepiride 1000 mg, I'm going to ask the house, how many people would be interested in insulin as one option. Reduce the glimepiride, add an DPP-4, reduce the dose, it's on 8 mg, reduce the dose, add a DPP-4, third option, SGLT2. So how many of you all...
Fourth option, injectable GLP-1 RA.
Can I just have another option?
Yeah, please, sir.
Yeah, another option is de-escalate the SU and then have a generic combination of a DPP-4 and an SGLT2.
Okay, so whether now patient is 8.6, our goal is 6.5, so we need 2% reduction, very closer to goal. So maybe a combination which will cost probably a 1.5% reduction in, that's what Dr. Venkatraman is suggesting. So how many for insulin in this patient? Dr. Karnan, Dr. GK. So we have very fewer people who are ready to insulinize this patient. But yeah, Dr. GVK, your opinion.
And then,
So GVK, it is not insulin. So you have to precisely tell us, the house, whether you are going to start basal insulin, whether you are going to start premix insulin, whether you are interested in starting basal bolus insulin.
I would like to, because the fasting is 170 and PPG is to 210. I would rather like to put a small dose of basal insulin so that it controls.
Okay, so Dr. G, you would reduce the glimepiride.
We will come to you, sir.
No, it's nothing to do.
See, small dose, 5 years. See, the first thing bedside with insulin is, if the patient is 5 years, okay, the fasting is 130 or 140. This is what we learned. Now that you are dumping DPP-4, the only drug which may be effective is SGLT.
What do you want to start in this patient?
First thing is, I don't know. I will advise is basal and bolus. Maybe the insulin is too with the SGLT.
So your choice is basal and bolus.
Your choice is basal bolus. Dr. Lilly, what's your choice for this patient? Would you go in for 2 drugs, 1 drug at a time? Would you go like a cowboy with 3 drugs or a cowgirl?
Yeah. No, I would start with the, if a patient is willing, then maybe a basal insulin.
Everything, patient is willing, affordability is not
Patient
an
is
issue.
willing, affording, everything.
This is science. So we should not discuss.
No.
Patient
Basal.
is willing, affordability is there,
Basal.
affordability is there. So you tell your
What is
best
your
option.
choice?
Basal insulin.
Basal insulin.
Yes.
Dr. Lakshmanan.
I think 8.6 is too much for an oral drug. Whatever drug you are going to add is not going to bring down the A1C. You want to target 7, isn't it? So I may step up the dose of metformin because it's very small for this BMI. Maybe delete the glimepiride, add a DPP-4 as said. DPP-4, SGLT plus metformin 1 gram,
Let him speak. Let
1
him
gram
speak.
twice daily. And rightly he said the difference between the fasting and PP is not much. It's only less than 60 milligrams. So add a small dose of basal, the fasting will come down. I may add for maybe for a few weeks till the sugar settles down. I think within about matter of 4 to 5 weeks, he'll come back to the nice control. Then the three drugs with a little weight reduction, you should be perfect.
So Lakshman,
yeah, and he has got albuminuria. Probably I may like to add a ACE or ARB inhibitors in this patient, along with amlodipine. Or I may stop even amlodipine. Amlodipine really induces proteinuria.
Yes.
If you ask, because it dilates both the afferent and efferent arteries of the.
So that's the reason we put amlodipine, so that there is some.
So a lot of things has to be modified in this guy. Maybe step up the dose of atorvastatin, premature CAD. I think
Why you want to step up the dose of atorvastatin?
Already
Suppose LDL cholesterol is already 70.
Doesn't matter at all.
Yes.
Matter. There's a family history. There's a very strong family. It's a premature coronary artery disease.
True.
One should be careful.
Thank you, sir. Thank you for bringing that up. So I'm playing the devil's advocate here. Why not pioglitazone? Have we dumped it? Sir, have we dumped it? CAD? Have we dumped pioglitazone? Anybody for pioglitazone here?
He's already.
Not after 10 years. It's the only insulin sensitizer we have. Nobody will use pioglitazone here.
What about lobeglitazone? Are you going to start lobeglitazone?
The data is not so.
No, it is a cheaper drug.
Huh?
I think it boils down to two things. Either it is a sequential addition of downsizing the sulfonylurea, substitute with a DPP for SGLT2 or SGLT2 alone, and then add a basal insulin, or a simultaneous basal insulin and an SGLT2 DP4 combination after de-escalating.
Right, we cut short it. Let's. We have listened everybody's opinion. Now let's cut short it, talk science. Now we have discussed there is no point of using glimepiride beyond 4 milligram. So there is no confusion. We have to reduce the dose of glimepiride. Number two.
The problem is diabetes is a heterogeneous disease.
We are coming to that point.
No, doctors also thinking such a heterogeneous fashion. That's a problem.
So now, see, when we have to manage this patient, Rajiv, we have to manage comorbidities also. Now, based on the present data, based on RCTs, I am not talking about individual opinions, based on randomized controlled trial, this patient is having CKD, this patient is at a risk for premature coronary artery disease. So whatever therapy you are going to modify, that should also address these comorbid conditions, apart from controlling your glucose levels. Now, when it comes to the battery of drugs available to us, two class of agent must be included in whatever way we are comfortable with. Now, these are GLP-1 receptor agonist and SGLT2 inhibitor therapies.
So Rajesh is right there that, in all the guidelines other than Israeli Diabetes Federation guideline, they don't mention BMI. And BMI is a very important criteria. Israelis are the only people who mention BMI. Right? They don't talk about HbA1c. They first segregate phenotypes of patient based on BMI. So if this patient at 29.5, he doesn't qualify for insulin. If he has a deep pocket, he qualifies for something which can make him lose weight. But
we are coming to that issue.
He has an overactive, paradoxically high glucagon.
Now coming to the insulin therapy, definitely this patient need some support for insulin therapy. Now, all of us are correct and all of us are wrong also. There is more than one way to initiate insulin therapy. If we see the difference between fasting and postprandial, and we understand the concept of fixed fasting first, with the decreased carryover effect, probably starting basal insulin is a good option. But considering duration of diabetes, basal bolus insulin therapy might be the option.
Rajesh, why not GLP plus insulin combination?
I am coming to that, Rajiv. I am coming. But then basal bolus therapy is very good to talk about in a conference hall. When patient has to take in real world, after some days, either patient change the doctor or stop taking the insulin therapy. So basal bolus therapy might be a really good option, but then we have to consider the practicality of application also. Diabetes is a lifelong disorder. Patient has to take therapy for long. So Rajiv, your question, there are now two options. We have to take care of risk factors. We have to control diabetes, duration. So if we see guidelines, before starting basal therapy, there is an option that we can start combination of GLP-1 RA with basal insulin. Now, there is a trial which is known as dual trial. In dual trial, they have compared a injectable GLP-1 RA with basal insulin.
Dual 7, where they compared basal bolus with
basal bolus insulin therapy. So it has been found that with use of GLP-1 RA with basal insulin therapy, it is a non-inferior in terms of glucose control to basal bolus therapy. At the same time, there are added advantage that risk of hypoglycemia is reduced, which is more with basal bolus. Weight loss is seen with combination therapy as compared to basal bolus, non-inferior glucose control, and you are targeting number of risk factors like present in this patient. So my take is I will like to start a combination of GLP-1 RA with basal insulin therapy.
So the point is that we don't want him to come to an HbA1c of 6.5. We want to see what are the various modalities available. Yes, sir.
Yes, Professor Sundaram.
Sir, in all diabetic patient, I always tell there are 4 Ds. First D is diabetes, second D is diet, third D is discipline, and fourth D is drug. So we are now discussing drug, but we are not forgetting the first 3 Ds. So they are always there in all diabetic patient. If a diabetic patient does not follow diet, costliest medication will fail. So they have to be part of, you are absolutely correct.
So,
absolutely. Very good word,
Yes,
sir.
yes.
Judicious is a wonderful word, but it varies from person to person.
Dr. Lilly, you have something to say. Yes.
Yeah, I just wanted to ask you, if a patient comes and asks...
Do not ask us,
Yes,
tell
please,
us.
please tell us.
If a patient comes and tells us that, I do not want to take so many drugs,
Yes.
I want insulin.
Yes.
What is your take on
Right.
pre-mixed insulin?
I will come there. Rather than starting premix insulin, I will tell you, I do not know how many of you knows, when we are choosing basal insulin therapy versus there is another concept, basal plus insulin therapy, which is combination of either a co-formulation, premix, or separate basal plus 1 shot of rapid acting insulin with largest meal of the day. BMI comes into picture when we are choosing single injection. If you have, this is written in textbook of endocrinology, if the body weight of the patient is more than 120%, our patient is obese, more than 120%, then probably single basal injection will not suffice because that individual is going to have a significant prandial excursions. So if the lifestyle is such that he is taking a 1 large meal in a day, which is very common nowadays, rest of the day we are eating very small amount, then rather than starting a basal insulin, it makes a case either a premix or a co-formulation or combination of a basal plus a short form of. So it makes a case.
So again, our 20 minutes went only in glucocentricity. Again,
Rajiv,
yes,
before
sir.
we go on,
Yeah.
will you like to reinforce monitoring? Lifestyle we always do at any level, intensification of therapy. Monitoring. What I'm trying to say is, going by our own experience, with a fasting of 170 and PP of 210, with HbA1c of 8.6, it is tempting to speculate that there are equally or much more contributions to the prandial state for the lunch and dinner as well. So, would you like to certainly capture those data before harping on a mode of therapy, wherein I think your combination of a GLP-1 and a
So sir,
basal insulin.
fantastic question. And so the postprandial and the glycemic variability, it has been tested in an RCT called as a flat sugar study. And it looked at basal bolus versus GLP-1 plus basal insulin on the background of metformin. Both the cohorts, 250 patients in each, reached the same HbA1c target. But the patient who was on GLP-1 plus basal insulin not only had a better time in range, this is a 7-year study, so better time in range today, but also had a lot of reduction in inflammatory markers and 24-hour Holter's ECG abnormalities. So it's just a hypothesis setting that probably when we look at control, we also need to look at flatness of control. Today we have that TIR, but this study is 2015, that probably we need flatness. So an HbA1c of 8.6 could be 90 and 350 for all is fasting and
But then
post-prandial.
Rajiv, we are often talk about time in range, but I always wonder how many of our colleagues actually know what is current recommendations for time in range. Do we have some volunteer who will tell us what is the current recommendation for time in range for type 2 diabetic?
Anybody? I think he's throwing it.
No, time in range. 70% of that time,
should be in
70% of the time, the blood sugar should remain in range from 70 to
180.
180 milligram per deciliter. There is another term, time above range and time below range. Those should also be there. That patient should not go beyond 180 to 250 and more than 250, which is less than 1%. Similarly, time below range less than 70 and less than 50. Now, time in range is a new concept, but again, measurement of time in range in real world in routine clinical practice is a big challenge.
So I'll again play devil's advocate here, that patient has proteinuria, hypertension, dyslipidemia. How many would add an ARB or an ACE plus SGLT2 plus a finerenone? Would it be added sequentially? Would it be added together like in heart failure you add multiple things? Would it be added in chronic kidney disease?
Well, the thing is, he is on a stiff dose of amlodipine, so scale it down to 5, introduce an ARB or ACE inhibitor of your choice, step up the maximal tolerated dose, and then probably withdraw, if possible, the amlodipine totally,
Right.
or even substitute with cilnidipine.
I will, thank you very much. This is a correct point. I will come to this. Actually, first of all, I will like to perform an echo in this patient. What is an ejection fraction in this patient? Patient has premature coronary history of premature plus other risk factors. So this actually makes a very strong case. He is obese. He might be having heart failure with preserved ejection fraction. He is smoker. So all risk factors are present. So echo makes a case rather than going for many fancy investigations. So echo make a case. We should do an echo, determine ejection fraction, whether it is reduced, mid-range, or preserved ejection fraction.
Would anybody like to add an aspirin for him? Yes. We would like to add an aspirin for him. So we may get his HbA1c from 8.6 to 7.5, but we will change him to an ARB, maybe reduce amlodipine or knock out amlodipine, maybe add an SGLT2, which we will add for this particular patient, knowing that proteinuria is the driver for chronic kidney disease. Statin dose we may...
But I'm stopping one drug we are forgetting. There are enough data, and there are actually, this is a very old drug. It has shown benefit in reduction in cardiovascular. It reduces your postprandial glucose, and that is alpha-glucosidase inhibitor. How many of you have experience and are willing to use alpha-glucosidase inhibitor?
So alpha glucosidase is like something which you don't acknowledge on the podium, but you write in your clinic. You know, because the postprandial the reduction it gives you, and all of us are eating so much of carb. So there's data to suggest that it works better in DPP folks, and all the incretin works better in Indians or East Indians as we are called, other than Caucasians. So because GVK is signaling to me that so patient injectable may be basal or basal plus or basal plus GLP-1 or only GLP-1 if somebody wants it. We remove the amlodipine, we get an ARB, we add an SGLT2 for this patient, we add an aspirin, we increase the statin.
But my question to you is, Rajiv, now all SGLT2 inhibitors are out of patent, they are generic. Cost is not a big issue. So which SGLT2 inhibitor you want to add? Empagliflozin, dapagliflozin, or even for that sake, canagliflozin?
So you gave me a googly.
You gave the answer. The generics are available.
So important in all the CKD studies, the eGFR has not been here. So EMPA kidney has 38, DAPA has close to 43. But EMPA kidney has more patients who have less severe chronic kidney disease and less proteinuria.
DAPA is ideal. DAPA is ideal for.
Where is
dapagliflozin.
Yes. So looking at this, where the proteinuria is low and the eGFR is high, so the mild CKD, probably an empagliflozin maybe.
Okay. So Rajesh and Rajiv, if you permit me, can you just sum up the discussion
yes.
so far?
Before we sum up, sir, we sum up, one last, because otherwise we will be not discussing that part, and that drug is available, and injectable form is actually, you know, just to inform the house, injectable form of that drug is approved by DCGI way back in 2022. But the drug is in shortage. The company is not in position to market and come that drug into the country, and that is semaglutide. And now it is available as an oral form of semaglutide with host of advantage. We have said price, we are discussing science. We are not discussing price. So, no, he is not alcoholic. Alcohol nowadays, no. So how many of you have a take on starting semaglutide in this patient, considering obesity, considering CAD, considering dyslipidemia, and other issues? How many of you are patient can afford anything? He want best therapy. Yes.
Sir. Here,
No.
sir, one thing we have to say, step up wise, because costly treatment immediately keeping on is not necessary, because the CAD is in a mild to moderate, not moderate to severe.
How do we know, sir? We have not done TMT. We have not done risk stratification.
That's the thing. If the severity is more, you might have mentioned it.
So in this, I think this case, beautifully presented by both of you and with excellent audience participation. It's a common garden variety, a diabetic of 10-year duration with 3 molecules on board. First, we'll talk about the glycemia. 3 molecules on board. The clinician's target is to achieve HbA1c of less than 7 if it is achievable without the risk of hypoglycemia. So a single molecule in the oral space cannot do this job, and maybe a combination of a DPP-4 inhibitor and SGLT2 also. So the options are, number 1, either a sequential or a simultaneous introduction of a small dose of a basal insulin, de-escalate and if possible try to eliminate the sulfonylureas, introduce an SGLT2 and a DPP-4 combination, or if the patient can afford a GLP-1 receptor agonist and a basal insulin. That is from the glycemic point of view.
Thank you very much.
Certainly.
you, sir.
So this is from the glycemia point of view.
Thank you so much.
So from the point of view of the comorbid conditions, the patient is in CKD A2, G2, right? So he is a candidate for accepted interventions in DKD, which are, number 1, we have already discussed ROS blockers, number 2, SGLT2 inhibitors, and number 3, subsequently are going to be prepared for intensification of insulin dose. The touch of SGLT2 will help you to achieve the target with less amount of insulin. Third is, as Lakshmanan pointed out, with a family history of premature coronary artery disease, is the statinization adequate enough?
Yes.
If you want to achieve a 50%, I think nursing and
Yes,
authority is there, you're going to discuss the next
Atorvastatin-
Jugalbandi. So this will form the complete multi-centric approach in this wonderful case presentation, beautifully taken forward
Thank
for
you.
discussion
Thank you.
by Rajiv and Rajesh. Please give a big
Atorvastatin,
hand.
is it given HS or OD? Atorvastatin, HS, but it is put OD.
OD and HS dose.
HS dose. Okay.
Thank you.
Then
Thank you so much.
can we add pioglitazone and no, yes.
Discuss that.
I was in Supreme Court, ஒரு Tamil lawyer. He is exactly like this. I said, you should be on insulin. Our Madras, Delhi, he is coming to Chennai. There, reputed, they said, you are not, this is not the right time to start on insulin. That is why we come and fight it here. Thanks to the influence of industry, people are getting cocktails and ignorance. Okay, this is contributes to the morbidity of the nation.
Thank you.
Thank
so
you.
thank
Thank
you
you
all
for your
the
final comments.
Nice intro. I think one Jugalbandi is over.
Thank you.
We are in for the second Jugalbandi. Now, this second Jugalbandi, I'm sure, like the previous one, both Dr. Narsingan and Dr. Lakshmanan will have audience participation. Now, as much as diabetes, discussion on hypertension and dyslipidemia is always an issue from the point of view of clinical relevance. For the simple reason, in hypertension, you have the targets for the various categories. Molecules are available. Are these targets achieved? Two more chairs you want? Come,
Yeah.
you can sit. Yeah, please.
Sigam is not doing well.
Yeah.
he
So I was
wants-
just introducing the topic, just a couple of minutes, Dr. Narsingan and Dr. Lakshmanan. You can have the introductory slides of both Narsimhan and Dr. Lakshmanan. So the targets are there. can you have the chairs and the pakam podriya thambi? So that screen mark here. So the targets and molecules are there. Now we always talk about 15% of Indian diabetes have HbA1c. 20% of, 25%. How many hypertensives achieve the target? It is not as if the diabetes is in poor control, hypertension, number one. And number two, at other end of the spectrum, somebody has written a good article which we reviewed later. That is it not time enough to consider restoring a normal BP, at least in a good chunk of patients? I mean, food for thought, since the two experts are there. And from the dyslipidemia point of view, I'm sure we are going to talk about the LDL targets, triglycerides. I think triglycerides has always been a soft issue with respect to major organizations, whereas we as practicing clinicians, we always believed in targeting the triglyceride. So with this brief introduction, I think you saw the introductory slides of Dr. Narsingan and Dr. Narsimhan. Yeah, it is there. Please project so that, because both of them have done so much of work and great friends and pioneers in the field of medicine. The whole city of Chennai and Tamil Nadu and rest of the country respects both of them, and especially Nursing has done a lot of work on lipidology, and Lakshman is really fluent in anything that you give it him, whether it is hypertension, diabetes, tuberculosis, infectious diseases, etc. So we are going to have a nice jugalbandi of the dilemmas in hypertension and dyslipidemia by Dr. Narsingan and Dr. Lakshmanan. Please.
Thank you, Venkat. I think the flow is like this. I'll be keep asking Narsingan some doubts. He'll try to answer, and also the people on the floor also can help. Venkat said the BP target in a diabetic, but so much confusion, Narsingan. One body says 140 by 90 target, other fellow says less than 130 by 80. You're all confused. What to do now?
I think one needs to concentrate mainly on the threshold beyond which one should concentrate on the definition of hypertension. You look at the data coming out from various guidelines. In fact, it was 160 some years ago by JNC 5th, brought down to 150 later, then 140. 140 we were staying at that stage for a number of years. JNC 7 started propagating the same message. European Society of Hypertension, European Society of Cardiology again endorses the same thing. The International Society of Hypertension also tells you that 140 and above 90 should be considered as hypertension. Hypertension Society of India also considered the same level should be considered for treatment. But what happened in between these 2015 to 2023? American College of Cardiology and American Heart Association had joined hands with 10 organizations. Nearly 11 organizations had come to the conclusion that the systolic blood pressure has to be brought down. So 130 and 80 is considered as hypertension. In fact, when they introduced this, a lot of criticism even in the United States. 14.8% of the people in the United States became hypertensive.
Currently, pharma driven. See, 130 by 80. So, half of the world population become hypertensive. Yeah, don't you think so? No. The question is very simple. When you put 140/90, it is 30%. When you put 130 by 80, it becomes 60%.
Yeah. In
Lakshman,
fact, there are
jokes apart. Would you like to have the target of 130 or 120 in some select patients? For example,
we are coming.
Proteinuria.
We are coming.
No, that I think he is going to ask. No, why I started talking like this, every time people say 140/90, I think we should probably think about the problem of prehypertension, which was actually coming out from JNC 7. 120 to 139, 80 to 89 is considered as prehypertension. The same group is now divided as one elevated hypertension and stage 1 hypertension. You go to stage 2, propagated by ACC/AHA, 140/90. If you say 140/90 applicable to Indian, that means stage 2 of Americans recommendation. I think we should revise our approach to people with hypertension, because the incidence of prehypertension is very high in our country. The problem of obesity is very high. The problem of metabolic syndrome is high. The prehypertension risk of getting cardiovascular risk is very, very high in those people with diabetes. If you take only diabetes, much more when compared to normal people. Normal people getting prehypertension risk is more. diabetes risk is more. When diabetes is associated with the prehypertension, the risk is enhanced. So we need to realize that we are having a problem with the prehypertension. We need to be very careful. Of course, you need to implement lifestyle changes for the next 3 months or 6 months. If the fellow is not responding, I think there is a place for pharmacotherapy. So we need to realize that we need to identify people above 130 and 80 that is acceptable even for our country, because there is good number of data. There is one study called Mumbai cohort study, which had evaluated people for the development of cardiovascular risk and mortality. The IHD mortality is much more when the blood pressure goes beyond 130. The stroke mortality is much more when it goes beyond 130. Again, stressing the importance of identifying people above 130. So when the risk is more, when the mortality is more, our own data, Mumbai cohort data, I think we need to accept that there is a problem by facing this sort of individuals with the prehypertension. We need to
so
probably
Narsigan
be
feels that 130 by 80 above should be targeted for BP control. But what happened to the ACCARD BP arm? In a diabetic, it did not show much benefit of reducing.
See, ACCARD study, I think ACCARD lipid arm, ACCARD glucose arm, ACCARD hypertension arm. In fact, no, they had reduced the blood pressure with all sorts of drugs and brought it down less than 120. People in whom the blood pressure was brought down to less than 120, there is no cardiovascular benefit. In fact, the electrolyte disturbances occurred, the problem of cardiovascular risk was very high. Of course, it had helped those people with the stroke prevention. Except for that, we don't get any benefit. So thereby, there is a definite information what we had gained out of this particular study is that ACCORD study had clearly indicated that blood pressure of 120, less than 120 in a diabetic person will definitely push him for an increased risk, including mortality. Because there are a number of studies, even accomplished study has started talking about the J curve. When you keep the levels at 140, the risk is there. When you bring it down to 130, the risk comes down. When you bring it down to 130 to 120, the risk comes down. When it goes down 120, the risk goes up.
That makes an interesting fundamental question to both of you. I'm sure you will agree. Now, when you talk about the sugar, there's always a compelling comparison between blood sugar and blood pressure. See, in blood sugar, you have fortunately a couple of populations like the Nauruans and the PMI Indians, wherein it's a bimodal distribution. You have the population which is clearly diabetic, you have a normal population. So the issue is settled. Of course, you have the other data. Whereas, do you have any data like that? Otherwise, it's a continuous variable. It's a single distribution. So for blood pressure, starts from 90, 100 onwards, there are data to suggest that you have some comorbid endpoints. What I'm trying to say is, are there any relevant reference in the literature with respect to some populations who do have very normal BP, low BP, and people who have got some hypertension with endpoints, so that will be a model for us to strike, to arrive at the target which we can aim in the other populations.
No,
see, that's what the sprint people did.
We need to probably depend on the guidelines, what has been published in the recent past. Whatever guidelines you are in favor, probably you can follow that. But unfortunately, many of us don't follow the guidelines. You need to remember that the guidelines are actually coming out of evidence. Where does the evidence come from? It is from randomized controlled trials, meta-analysis. We need to take that into account and then implement in our clinical practice. There is no point in just arguing all the time, what is normal BP, what is optimal BP, what is high normal BP, what is the stage 1, stage 2, stage 3. Lot of confusion for the Hypertension Society of India. I don't even remember the numbers, but I'm able to remember the numbers given by the American Association, because it was only simple classification of hypertension definition also. The target, ACC-AHA tells you whatever is the problem, whether diabetic, non-diabetic, with renal disease, without renal disease, with stroke, without stroke, everybody can bring down the blood pressure less than 130. That is 130/80, 130/80 should be the goal all the time, except in two conditions. One, if the atherosclerotic cardiovascular risk as per ACC-AHA calculator is less than 10% in an individual, you can probably start the treatment 140. You can keep it at that level. The second one, if you are going to prevent the secondary stroke in those patients, probably you can keep it at 140. Rest of them, including CKD, 130 should be the goal.
In stroke, is there a distinction between a thrombotic stroke and a hemorrhagic stroke?
Yeah, there is a definite difference.
I finish out the thing. the 130/80 by ACC-AHA came from SPRINT trial. See, SPRINT trial looked at the ACCARD BP arm, why the benefits are not there with the diabetic fellows. Finally, they come to the conclusion, the SPRINT, the diabetic population, they had a very good outcome after 130/80. They say the hypoglycemia in the ACCARD arm mitigates the benefit of the lowering the BP in the diabetic. That was the benefit. And coming to the question of ischemic stroke and the hemorrhagic stroke, I think when a patient has ischemic stroke, never treat the blood pressure for initial 24 hours. That is the real carry-home message. If the patient has got a high blood pressure with ischemic stroke, the outcome is good. People have got a very well tuned. Somebody comes with the BP of 200/120 with the stroke. Just keep the blood pressure intact for 24 hours, unless otherwise you want to give a thrombolytic therapy. If you want to give a thrombolytic therapy, then target the blood pressure from 220 to 160 systolic and 100 diastolic, then give the thrombolytic therapy. But hemorrhagic strokes, a different kettle of fish, you should definitely bring down the blood pressure to 160/100 by any means, because that is very, very important. That's the difference between the ischemic as well as the, but message is that when a patient with a stroke, ischemic, comes with a high blood pressure, he's a candidate who will survive, unlike a candidate who comes with the low blood pressure.
Sir, I just want, if I am permitted.
Yes, sure.
You know, we talk about hypertension every time. What perplexes me is that the blood pressure varies so much. Same individual. Blood pressure at home, blood pressure in the office, blood pressure while sitting, standing, every time. And the other factors are age, comorbid condition, so many. How can we actually achieve the so-called strict control of blood pressure? You want to keep it 120/80. Are we not going to end up more issues?
There are four things.
Let me just finish, because this is something that I have accumulated over the years. Because this I think is not an easy thing at all. You can easily say 120/80. What 120/80? Whose blood pressure of 120/80? Where is it 120/80? These are all the issues sometimes we are not addressed, although Dr. Narsingan has mentioned about comorbid conditions and other things. So in other words, are the international organizations are also trying to be a little more liberal, in the sense, if I read, some of them do mention about 140/80, because you're not identifying the age and all, so many things. This is what I want. This is always my concern. I wanted to say that. Thank you.
I think the BP variability, I fully endorse your views. We need to be very careful. It's not like your blood sugar values, you identify it, and then HbA1c, then go ahead and treating the patient. Whereas here, once when the patient enters into a room, it's an office blood pressure which you are going to make. What is the instrument that you are going to use for detecting the blood pressure? Are you taking it in the proper manner which is recommended with academic bodies? Many of us are in this audience are not doing it. The patient should be seated comfortably. All those diagrams are there, which I don't want to tell. That has to be observed. Then the readings should be taken 3 times. And the first one, you can neglect it. The average of the 2 readings, you should enter it. If you are going to concentrate only on the office blood pressure, if it is elevated and if you think that the target organ damage is not there, you can allow the fellow to come after 10 days, after 15 days, again recheck, again do it in the same way, if it is in the office blood pressure. If the fellow is able to bring home blood pressure monitor reading, that gives you a lot of information, just like your ambulatory blood pressure monitoring values. So you may identify whether the patient is really having blood pressure or not. Otherwise, the best way of making a diagnosis of hypertension is only ambulatory blood pressure monitoring. If you use that, probably that will be the best gold standard for you to make a diagnosis. In fact, NICE guidelines in 2011 started telling, if you like to make a diagnosis of hypertension, you should have the ABPM reading. Otherwise, you will be totally wrong. You will be treating a patient unnecessarily. I think the BP variability, what you had mentioned, minute to minute variability, hour to hour, morning to evening, night, everywhere it goes on like that. My BP will be very high because I am worried about Venkatraman, what he is going to ask.
I think what Vasant said, the BP variability, 3 things has to be looked into hypertension. One is the BP variability, nocturnal dipping. The patient dips in bedtime during sleep, early morning surge. All the 3 has to be taken care of. You have to choose a drug which acts on all the 3 parameters in addition to a 24 hours control. So all the 4 things are very important. As he rightly said, If a patient is got susceptibility for a variability, put him on ABPM. Gives you wonderful information. Now it also says systolic blood pressure, time in range. It's not only for glucose, it's also for systolic blood pressure. People have found out very new concept. The systolic blood pressure, time in range, at least more than 70% prevents the patient to go for any vascular complications. I think we'll stop with that.
I think, can you go on to the molecules? Since you did mention about Lakshmanan, about the nocturnal dipping, are there any preferential molecules which have a say in, for example, the systolic, the nocturnal dipping, absence of dipping, etc.? So can we just have the discussion, the Jugalbandi, focusing on the molecules?
The next question is, Narsigan, will you made a diagnosis of hypertension diabetic, what's your drug of choice? Will you start ARBS or ACI or a beta blocker?
Well, the thing is, if a patient is a type 1 diabetic or a type 2 diabetic, type 1 diabetic with microalbuminuria, without microalbuminuria, only hypertension. The different approach. Microalbuminuria, you need to specifically choose ACI or ARB. The same way, if a microalbuminuria or proteinuria is there in a type 2 diabetes, again ACI or ARB. Otherwise, if the patient with the type 2 diabetes seeks advice, no albuminuria, no coronary artery disease, nothing, blood pressure is associated with diabetes, you can choose any of the 4 molecules, any one, including a diuretic. You need not hesitate to start a diuretic even in a patient with diabetes. Please remember that. And if you are choosing an ARB, why do you always choose ARB? Why not ACI? That's a big question which begs answers from all of us. Can you give any comment on that? Side effect. Not that many. I understand, Karnanidhi, I understand. Only 30% of the patients with the ACE inhibitors get a cough. Rest of them are able to continue the drug. Even for many years I have been giving perindopril, people are very much better. They are all.
ACEs are generally, I feel, a weaker antibiotic than an ARB. I don't know about that.
No, that is only by our own experience people are talking.
But possibly one of the things is the dose that we use, ACE inhibitors, we always have an opinion that probably side effects are dose related. So that is at the back of our mind. That's one of my
that is right. Even previously when the drugs were introduced, people are giving a 2.5 ml of 5 milligram of ramipril. Take it at bedtime. They don't even escalate to 5. They don't go to 10 milligram, what was proposed in the HOPE study. They never tried, including cardiologists. So they think that it is got a hypotensive effect, first dose hypotension, all this fear was there in their minds. I think we did not use the ACE inhibitors properly. And all the studies which were projected before 2000, I think were only for ACI. After 2001, there are good number of studies only for ARB. Type 1 diabetics actually has shown much more benefits only with the ACI, not with ARB. Type 2 diabetic patients are showing much more benefits only with ARB because the studies are now coming out. For example, irbesartan, which was used in IDNTU trial, reduced the proteinuria. And the telmisartan, which was compared with the ramipril in the on-target study, non-inferior, and it proved that it has got a long action, duration of action. Even the nocturnal blood pressure, what Dr. Venkatraman was trying to talk about it reduces the nocturnal blood pressure also. And yet another drug which can reduce the nocturnal blood pressure is the chlorthalidone.
That's what I was asking. Can you utilize this forum to assure our friends about the positioning of the diuretics? Unfortunately, again, probably the literature has been ripe with some unfavorable aspects of the diuretics which is always being highlighted. But the advantage that you have, especially somebody with isolated systolic hypertension, and you have a diuretic, touch a diuretic, beautifully it brings down the BP. So the clinicians have to shut down their inhibition with respect to positioning the diuretics. Would you like to say when do they?
Yeah, 100% I agree with you. Because chlorthalidone has been there with us for the past 60 years. The good old study called SHEP study, systolic hypertension, the elderly program study, which had utilized this molecule compared with the placebo in elderly people. The benefits were seen in all cardiovascular endpoints, and people were followed up for the next 15 years. Surprisingly, people who received chlorthalidone lived for 555 days extra when compared to people on the other arm. So again,
we don't use chlorthalidone much in our population because we live in a hot summer. I've seen people coming with a hypokalemia, use a very small dose of chlorthalidone. But when you take the 24 hours action, when you take the BP variability, when you take the non-dipping morning surge, only 2 drugs. ARBS and CCBs. These are the two drugs which really acts on all the 4 parameters. Your beta blocker acts on the morning surge, but not on the dipping.
I agree, Lakshmanan. I agree. Okay, you have started ARB, you have started a CCB, the fellow is not responding, what will you use?
Yeah, then you have to add a third drug, only a diuretic.
Diuretic.
Yeah,
At that
total.
stage you are using diuretic.
But I tell you, now the pharmaceuticals are coming with a combination of ARBS beta blockers. Now selling like a hot cake, which I found it's like a combination of DPP4 plus SGLT inhibitors, 1+1 reduction of the A1C. The BP reduction is very, very good when I use a combination of ARBS and beta blocker. I don't know what indications will you put this drug.
In fact, I will not use a beta blocker as a first line of management for hypertension, irrespective of the matter whether the patient has got diabetes or no diabetes. I will not use it in the second step also. I will not use it in the third step also. I will probably select it as a fourth drug when other drugs have failed to show a reduction of blood pressure. But at any stage, first stage, second stage, third stage also, I will use it, provided the patient has got problems like increased sympathetic drive, heart failure, angina, or arrhythmias. If these are associated with that, probably I will not have any hesitation to use this drug.
I think at this point you can also make a mention about the ALHA trial wherein chlorthalidone was used, but unfortunately the beneficial effect was given to the thiazide diuretics. I think that's a point that we have realized later. Now that we are running out of time slightly, I think we have had a beautiful jugalbandi on hypertension. Your favorite topic, Narsingan, dyslipidemia. I think you can initiate the discussion, you can clarify the possible misconceptions about dyslipidemia.
What is the LDL target? You people say 30, somebody says 50, other fellow says 55, other fellow says 70. What is going on in the LDL targets?
If you allow me to recollect the data from
Make it very brief.
Cardia study, which had indicated if somebody has a lifelong exposure of LDL to 82 milligrams, the problem of getting a myocardial infarction is at the age of 100 years. If somebody has 122 milligrams of LDL throughout his life, the chances of getting a cardiac event, particularly myocardial infarction, comes down to 64 years. If somebody has 220 milligrams of LDL throughout his life, the problem of getting a myocardial infarction is reduced to 45 years. This is the data which we have got it, number one. Number two, we have seen people with the homozygous familial hypercholesterolemia. They are dying prematurely. Children are dying prematurely due to coronary artery disease. That is indicative of, again, exposure to a long-term exposure of LDL cholesterol more than 500 milligrams. In fact, I have my patient like that. Third one is heterozygous familial hypercholesterolemia. I think we are totally forgetting about this entity called heterozygous familial hypercholesterolemia. The moment the patient seeks advice for a myocardial infarction, if there are no other risk factors, kindly ask the patient's family history. If you are able to catch that, you can even have a cascade screening or a reverse cascade screening. You can identify those people and help them to get rid of all these problems. I have about 10 families of hereditary familial hypercholesterolemia under my care. I think it is time for us to think about that there is a problem of hereditary familial hypercholesterolemia.
I think clinically you think of it when they have an ACUS analysis of the upper cornea.
Yeah.
Number one. Number two, when somebody has got a random LDL of 190, please think about the familial dyslipidemia. Look at the tendons, xanthomas. All that gives you a clue. Family history, rightly said. Somebody has died at the age of 35, 40, premature. So all those things give, it is there, but we are not just looking at, we are missing it.
Yeah, beyond that scope, because he has identified.
So the family history, what is the pattern? It is autosomal recessive or autosomal dominant?
Which one?
The heterozygous familial hypercholesterolemia,
Yeah.
which I think the phenotypic features Narasimhan has nicely highlighted. When you have the pedigree chart, you ask them to follow, I mean, which is the one? Is it autosomal dominant or autosomal recessive?
Dominant, not recessive.
It is dominant.
Yeah.
So you tell the targets quickly. What target?
Yeah. He was asking about the targets. I think I don't know how many people are trying to look at the LDL to start a statin. If you are a diabetologist, please tell me.
I think we
how
can
many
have
of you are targeting or looking at the LDL to start statin?
Yeah.
If the all the time.
But it is the comorbid conditions, not the he's a smoker, then your target should be
Okay.
It is not individualized. If the person has got, if he is a smoker, if he is like sedentary lifestyle, then you have to be more aggressive.
My other way of asking is that, how will you identify the atherosclerotic cardiovascular risk in a diabetic individual? Is it based on a lipid profile or not? One of them.
No, I think his message is, do not just go by a total cholesterol and triglyceride. You need to have a LDL cholesterol estimated, not calculated, estimated.
Yeah, good. Yeah. Will you advise your patient to go for a fasting lipid profile or a non-fasting lipid profile? No. The things are changed now. It can be done at any stage. Non-fasting lipid samples are equally good when compared to fasting. So I have stopped doing it. I have stopped doing it for the past 7 years. That it was.
But triglycerides, because we did a study in Apollo for one of the products. So the difference between the fasting and the non-fasting triglyceride is very high. In fact, it is threateningly high. So I almost asked them to stop doing the triglyceride
Maybe our
and the non-fasting.
studies are like that. But can I quote one study on this context?
Please. No, we want to learn from you.
Yeah. The thing is, there is one study which was conducted in the United States. 1 lakh population of adults, males, females, children. They have analyzed the fasting sample and the non-fasting sample. The difference was only in triglyceride, 26 milligrams. Only 26 milligrams.
Absolutely. Plus the insulin resistance,
26
maybe.
milligrams. But even if
Once
you,
again,
even
target.
if you allow some allowance.
Tell the target, please. You not come to the conclusion at all. Make it fast.
You want the target. Okay. So depending on the person's problem. For example, a diabetes with no atherosclerotic cardiovascular disease.
Make it very brief.
And only 1 or less than 1 or no risk factors is a diabetic. You try to keep the level 100. If the same diabetic, no coronary artery disease, and there is no albuminuria, nothing, no other problem, but 2 risk factors are operating. For example, hypertension is a smoker. That means you need to keep the levels again less than 100, preferably less than 70. Person is at a high risk with the problem of increased cardiovascular risk based on the duration of diabetes, smoking, this, that, and we have divided in such a way. You can keep the levels less than 70.
Already had one event.
Very high risk, atherosclerotic cardiovascular disease, myocardial infarction, diabetic, keep the levels less than 50. If the person with a coronary artery disease also has got a peripheral vascular disease, polyvascular disease, more than 3 risk factors are operating, plus he is a smoker, that means he requires less than 30 milligram, as per the recommendation given by Lipid Association of India.
Now, do all hypertensives need a statin, like diabetics?
My impression is to put every patient with diabetes, every patient with hypertension on statin, because the safety of statin has been established. The efficacy of statin has been established. We have lakhs and lakhs of people on statin. I don't know why one should hesitate to put the patient on statin. Every time when the patient comes back to you with the muscle pain, stop the statin. You don't even realize that it was prescribed by somebody for an acute coronary syndrome, 80 milligram. You reduce it to 10 milligram. I think these are the things which should be avoided. Not that I am very knowledgeable and trying to probably think that you are not aware of all those things. You are already aware, but I would like to tell you that we should change our practice. We should change our approach in managing people with.
So your message will be, when somebody is a candidate for high dose statins, continue lifelong, or after a year or 2, you just taper the dose, and then if the target LDL is achieved.
No, I don't, even if I reach the target level, I don't stop the statin, I don't reduce the dose of statin, as long as the patient is not having any problem related to statin therapy. High dose statin, when it is started for an appropriate condition, I think it has to be continued for lifelong.
What about the dual therapy nursing? And you only give statin, or you give statin plus ezetimibe?
Statin plus ezetimibe in case the patient is not responding to the so-called moderate dose or so-called acceptable tolerable dose or so-called high dose statin, you have already started. The patient is at high risk, is not responding, is not reaching the goal what you want in acute coronary syndrome, less than 50, you add.
But that's a trial nursing, and improve it.
Milligram.
Even with the pravastatin, when they combined ezetimibe, the outcome was much better than just giving a high dose of high intensity statin.
Absolutely, I was about to raise the same point, because previously when we talked about ezetimibe, we always thought it's a mechanical barrier to the cholesterol absorption. But this trial has proven that it is something much more than just the LDL cholesterol lowering.
Time will again start the dual
better.
therapy.
So that being the case, why not the clinicians incorporate ezetimibe? For example, instead of giving rosuvastatin 20 milligram, if rosuvastatin 10 and ezetimibe 10 can do the same job, and both have the data and the trial to back it up with a very good outcome
my
data.
My suggestion will be, if the patient has got an acute coronary syndrome or a very, very high risk, don't reduce the dose of statin.
Okay.
If it's not reaching the level what you want for that particular individual, you add an ezetimibe.
Okay.
In case you have started a moderate dose statin in a comfortable patient with no other comorbid condition, fellow is not reaching the LDL goal, add ezetimibe. Ezetimibe will do wonders, because IMPROVE-IT study has shown remarkable improvement in cardiovascular risk reduction. The LDL cholesterol came down to 53 milligrams.
What about the pembroke acid? Now I think after the CLEAR study,
Yeah.
it has shown a very good outcome of LDL cholesterol levels, almost by 40%.
Yeah.
And the cardiovascular mortality has improved.
Yeah.
So we are running out of time. I think I would like you to focus on two aspects quickly before my co-chairman Aarti sums up the discussion.
Not opening at all, Aarti.
No, she is going to sum up. That's what the agreement between us.
Oh.
Now, I want you to talk about the triglycerides. When do you target the triglyceride, to what level, which population, by what molecules, briefly? And also, do you target HDL at all? Very briefly.
Triglyceride is a big problem even in people with diabetes. Type 2 diabetic people also have very high triglyceride levels. When their sugars are under good control, the triglyceride level comes down, but may not touch to normal levels. You need to realize what is the exact level. If it is more than 150 milligrams, you need to be careful. 150 to 499. Adopt lifestyle changes. Think about the secondary causes for hypertriglyceridemia. You are probably missing some case of hypothyroidism or some kidney problem. Try to treat that particular aspect of it. Fellow is not responding, dietary modification, less carbohydrate, exercise, that. With that, patient should become all. At the same time, calculate the LDL cholesterol or do a LDL cholesterol direct method. If it is raised, LDL cholesterol, that means you need to put the patient on a statin. Statin will take the job of reducing your triglyceride also, because we don't have enough studies to say statins are doing wonderful things only for triglyceride, because people were not focusing on that. They were all focusing only on LDL all the time. We know that it is also reducing the triglyceride. So 150 to 499 statin. Fellow is not responding to LDL, add ezetimibe even then. If you're not responding, add a fibrate at that stage or omega-3 fatty acid. Even if the patient goes beyond 500 to 1000, the pancreatitis problem may occur. So you should use the fibrate first, later omega-3 fatty acid. Do the LDL cholesterol very high. At that stage, you should try to introduce statin. The drug that has been introduced in the recent past, I don't know, Dr. Venkateswaran will be knowing it, not Venkatram will be knowing it, because I go to a hypertension forum where I talk to Dr. Venkateswaran, you are Venkatraman. So I have not realized that it is the diabetes forum. So the Bembi, no, not bempedoic acid. This triglyceride reduction, reduce-it trial. This trial has shown using icosapentaethyl ester, 2 grams in the morning, 2 grams in the evening, given to people who had already reached the LDL cholesterol goal of less than 70, with diabetes, without diabetes, with established coronary artery disease, and the cholesterol triglyceride level between 175 to 499. They were all recruited for the study. They had a follow-up of 4.2 years. Remarkable reduction. The primary endpoints came down by 25%. The secondary endpoints came down by 26%. So using icosapentaethyl ester brings down the cardiovascular risk. Is it by reducing the triglyceride? No. Because only 30% of the people had shown reduction of triglyceride. Rest of them were not showing. What does it mean? It means there is some pleiotropic effect by this drug. Pleiotropic effects are being seen. Endothelial function improves, is anti-atherogenic. Yeah, there are so many.
No, I think Narsingan, the point is the elevated triglyceride, is it a cardiovascular risk? Do you have any evidence? Number one. Number two, by reducing triglyceride, are you going to bring down the CV risk? Straight away come to the point.
Yeah. What I'm trying to tell you now, there are studies which had correlated the cardiovascular risk with increasing triglycerides. Number of studies are there, ApoC3 and all those things. People are now trying to investigate some drug for which will act only on ApoC3, which probably may be in the pipeline and we may get it after some time. But what is available today is to use the drug that is available even in our country, that icosapent ester, which I am using it for my patient. 2 grams in the morning, 2 grams. Start with the 1 gram, then 2 grams in the morning, 2 grams. That reduces the triglyceride to a remarkable extent. Please remember that you should use that in addition to your usual drugs of statin. Saroglitazar. Saroglitazar everywhere. No, we get the same question and the same answer. I think he is the correct person who has used in many patients. Please.
Yeah, it really helps to bring down the liver fat. Fatty liver is one of the wonderful drug. If you really add saroglitazar, and it really reduces the triglycerides, but we have no trial to prove that it is going to have a cardiovascular benefit outcome. We need a larger studies, but otherwise it's a very safe drug. It also reduces the blood sugar. The A1C reduction is 0.3%.
Absolutely.
So also acts on the PPR gamma and alpha. I think one point is that phenofibrate, I think slowly going out of market.
One point I wanted to ask. In fact, the quantum of triglyceride reduction, I'm sure you'll agree, all of us are using saroglitazar. The amount of TGL reduction achieved with saroglitazar is phenomenal. I would say, even from, of course, some people walk to you with uncontrolled diabetes. To what extent the good diabetic control would have reduced the triglyceride, that is speculative.
Use it for fatty liver. It's beautiful drug.
Yeah. And number 2, as you rightly said, the effect on the glucose metabolism.
Cardiovascular outcome data. The drug is there for the past 7 years or 8 years. You don't have any cardiovascular outcome data. Without
That's
that,
why I asked you the question. Triglycerides have always been identified as a marker, but is it a parameter to be targeted for the cardiovascular outcome? That, I think that is the thing that's boiling. I don't think we have the answer.
At this stage, if you permit me to answer this particular question, I may have to take another 2 minutes, if you permit me.
Oh, sure, please.
Whenever the triglycerides are going up, remember the triglyceride-rich lipoprotein particles are going up. The lipoprotein particles, TGRLP, are very, very important. There's a remnant cholesterol. How do you calculate remnant cholesterol? Total cholesterol minus HDL cholesterol, you get non-HDL cholesterol. From this non-HDL cholesterol, remove the LDL also. Then what is remaining is remnant cholesterol. So in my laboratory report, I always mention about remnant cholesterol. If the remnant cholesterol is high, more than 20, that means it is the starting point. Those patients with the triglyceride rise, with the remnant particle rise, they are the people who are at high cardiovascular risk. You need to remember that. Is there a data? Yes. The remnant cholesterols have been brought down even in the reduced trial. The reduced trial not only reduced the triglyceride in some segment of the people, triglyceride-rich particles had come down. In addition, the CRP levels are also coming down by usage of this particular molecule, icosapent ethyl ester. So CRP levels are coming down. So we are reaching this sort of what I can say exciting area where you can concentrate on the triglyceride-rich lipoprotein particles or the remnant particles. It has been correlated well with the cardiovascular risk. It's not the LDL, it is the VLDL cholesterol and not the VLDL triglyceride are important in increasing the cardiovascular risk.
A lot of articles on pitavastatin, especially targeting on cholesterol remnants, much better than LDL cholesterol. I don't know whether you have seen it or not.
I am not very much aware, Lakshman. I am not very much aware. PCSK9 inhibitor. Yeah, it is a wonderful molecule, monoclonal antibody, which is against the PCSK9. The Vijayakumar was a drug which was used in a 4-year trial, and then the alirocumab was used in the Odyssey trial. Both the drugs are very good drugs. Alirocumab yet to arrive at Indian market. Vijayakumar, I am also using it, Vijayakumar. I have used it even for homozygous familial hypercholesteremia. My patient who had about 700 milligrams of LDL cholesterol came down to 520 with the high dose statin ezetimibe. With all these measures, nothing had happened. She lost her sister also. She did not respond to any of this treatment. Ezetimibe, everything added. They were not able to afford PCSK9 inhibitor. Through our lipid association, we were sponsoring 50% of the amount. So she is buying it every month, now taking it. Even after PCSK9, the LDL cholesterol was 230. So what I did, now I added bempedoic acid. Surprisingly, now it is 181. 181, after giving all sorts of drugs at my disposal, I have used it for my homozygous familial hypercholesteremic patient.
The combination has come. Statin plus bempedoic acid already come to the market. Yeah.
Thank you, sir.
Yes,
Sir, I think we've had a very excellent Jugalbandi today. with both the stalwarts in the field of medicine discussing about hypertension and dyslipidemias. I think a lot of dilemmas have been cleared, but still I think there are a lot of doubts. They can discuss it with you, I think, during the dinner time. We thank both the speakers, and also I thank my co-chairperson also. And I also thank Dr. Vijayakumar sir for giving us this opportunity also.